broadly to heart failure with reduced ejection fraction, because that's the most important currently the target of investigations. And of course, I will be touching upon the heart failure with preserved ejection fraction also, for which we are now again having so many approvals or drugs which are shown to be important. But majority of us should remember that it's heart failure with reduced ejection fraction which you are going to target, and which is a target for most of the current developments. So just look at the timeline from 1987, when we had the first really gold drugs, that ACE inhibitors, was the enalapril and ramipril, which showed effectiveness in heart failure, to the use of beta blockers with the miraculous type of trials. We'll just discuss very briefly about these drugs, from MRAs to ARBs, and then development of RNAs, SGLT2 inhibitors, developed in the 2015, and then now we have got certain of these drugs which are actively being pursued. The SG soluble guanide cyclase stimulators like the verqueguard and so on. And now just look at this demarcation. Initially, we were targeting the neurohormonal systems, because we know that the main pathophysiology is in the neurohormonal, just as we discussed in the last slide. But now the target for heart failure therapy is more and more towards the heart as such, the cardiac targeting. That is, we want to target more and more of the pathophysiological changes in the heart, including the cardiac metabolism. And also, one important target for heart failure currently is inflammation. So, this is how the therapy has evolved over the time. It gives us a very broad view to understand what are the drugs. So, we'll just go upon the basic treatments of heart failure with a reduced ejection fraction treatment. So, the currently what we know about this is, we know them as the four pillars of heart failure therapy, right? So we know them as the four pillars, which include the four most important drugs, which are the either of the any ACE inhibitor or ARB or RNE. RNEs are currently the preferred ones. On of course beta blockers, the melanocortin receptor antagonists, which we all know, like spironolactone, eplerenone, etc. And now we have finerenone, one of the newer one. SGL2 inhibitors have been added as the fourth pillar of treatment of heart failure with reduced ejection fraction. And regarding these drugs, the less more I say, the less it would be, looking at so much significance these drugs have gathered in the last just half a decade. Then we have drugs for relief of symptoms. For example, we could have loop diuretics, which are very essential part, and of course, agents like verbradine and digoxin could be there. Treatment of chronic heart failure with reduced ejection fraction, that uh, if we just look overall, the first foremost would be the neurohormonal modulation, because we have discussed the most important pathophysiology is lies in the neurohormonal systems. So these include RAS inhibitors, which could be ACE inhibitors, ARBs, or ARNs, the angiotensin receptor and neprilysin inhibitors. Beta blockers, a very, very important group of drugs, melanocortin receptor antagonists. So, just a very brief overview of how these drugs act. I hope we all have an idea, just won't go into details. But we should know that the contribution of these initial drugs, which I was talking about, should never be overlooked, because they have paved the way for what currently we think would be useful. But the four pillars still are these four group of drugs, which are the first, either ACE inhibitors or ARBs, or the RNEs. Currently, the guidelines take the ARNEs, that is the angiotensin receptor neprilysin inhibitors, as the best choice amongst these three. So, the first class of drugs, which includes either ACE or ARB or RNE, RNEs are the first choice drugs. If they are not tolerated, if there's some other, then we can go back to ARBs or ACE inhibitors, right? So that's a very important thing to remember about RNEs. And we know that the RNEs, for example, sacubitril valsartan, that's a combination of marketed as Entresto. Now, this sacubitril is a neutral endopeptidase inhibitor, which inhibits the breakdown of natriuretic peptides. Now, remember that natriuretic peptides are one of those products which are helpful in preservation of the heart function. So they augment the useful aspects of natriuretic peptides. That is we call as NEPs, right? So, for example, they cause bulge dilatation, they reduce ventricular remodeling, and improve diuresis. And when we give it along with the ARB, that is valsartan, there are additional benefits. Therefore, combination of valsartan and sacubitril, that's known as ARNI, and that's one of the best choice amongst all the three. First, as I told you, the first category of RAS inhibitors, these are the preferred ones currently, because the landmark paradigm HF trial showed that these are superior to the ones kings of the therapy, that's enalapril, and then the second ones that which are the valsartan and so on. So they are preferred over ACE inhibitors and ARBs alone currently as of the first pillar of therapy. Second pillars are the beta blockers, which the more I say the less it would be, because as scientist way back Dr. Cruikshank has exclaimed, beta blockers continue to surprise us. From the drugs which were initially contraindicated in heart failure, when we were students, sir, we all remember books wrote contraindication in heart failure, beta blockers. And now we read in the books, we don't see that exactly. So this is really a sort of miracle. And beta blockers really are the drugs which are, I can say, as wonder drugs. We all know these are the drugs which have been proven to reduce the mortality in heart failure patients, right, who are already on the other drugs, and they should be given to all patients of stage C. They should be given to patients of NYHA class 2 to 4 with LVH dysfunction and after MI. But remember, this is not a class effect. We all know there are at least 12 or 15 beta blockers. But can we use any beta blocker for heart failure? No, we can't use. There are only four. And that was the, worth, that was the miracle of the trials which were done, Copernicus trial and so on. These trials which showed that we cannot use any beta blocker, but only the four. And these are bisoprolol, metoprolol, carvedilol, and recently nebivolol, especially in the elderly. No other beta blocker can be used for heart failure. That should be very much clear to us. They have various modes. They prevent excessive catecholamine, effects of catecholamines, attenuate cardiac remodeling, prevent arrhythmias or arrhythmias. They have antioxidant actions. A common question asked to our postgraduates, mechanisms for beta blocker. Of course, they also have some degree of anti-inflammatory effect. One important thing about using beta blockers is always to start low and go slow. That's a very, very, if something holds true for this line, start low, go slow, it's best explained with beta blockers. When using for heart failure, you would start with even 1/8 or 1/16, 1/8 of the dose, right? So if it's 25 milligrams the dose of, let's say, carvedilol, you'd start at 3.1 to 5 milligrams. Such a low dose has to be started because there is risk, always risk of decompensation, because beta blockers by their mechanisms will tend to decrease the symptomatic drive, which can lead to heart failure. So start slowly, build up on the dose over months, may take up to 6 months, build the dose, and that will lead out to miracles in most of the patients, because the ejection fraction will improve over the next 3 to 6 months. But in any case, if the patient deteriorates, stop the beta blockers and look for the patient, take care of him, and then try to induce later on. So that's the most important thing about beta blockers. And we know that aldosterone is one of the most important actors of RAS, and it causes all types of adverse effects in the cases of heart failure, especially myocardial and vascular fibrosis, and so on. And therefore, the antagonists of mineralocorticoid receptors, they are one of the pillars, the third pillars of heart failure. And these include drugs like spironolactone, eplerenone. And nowadays, we also have currently phenytoin is also accepted. Then comes the wonder drugs of the 21st century, the SGLT2 inhibitors. They can no less be called as wonder drugs. Initially started and approved for diabetes mellitus. Now these drugs have been approved, and they are the sole drugs which are approved for heart failure with reduced ejection fraction, as well as heart failure with preserved ejection fraction. And remember, this indication for heart failure with preserved ejection fraction goes only for this drugs SGLT inhibitors, and no other drugs as such have been given this exclusive for both the heart failures. So it's a really remarkable drugs. And we know these drugs are like DAPA, AMPA, and so on. And this is the site of the action, the act at the proximal glomerular tubule, and where only 10% of the glucose is reabsorbed. But their mechanisms are beyond these simple, and they go on to reduce oxidative stress, inflammation, fibrosis, reduce cytosolic sodium and calcium current concentrations. They promote weight loss, of course, and that also causes fasting and increased production of ketones. So very important currently targets of the heart failure will go on later on. So this is very briefly, you can say the multi effects of SGLT inhibitors in heart failure, starting from simple reduction of circulating volume overload, because they have a mild diuretic effect since they are SGLT inhibitors, but they have further effects of regulating energy metabolism by increasing the formation of ketone bodies. They can lead on to the utilization of ketones for energy, and thereby they decrease the heart's reliance on glucose, and thereby there is a decrease in fibrosis. And furthermore, they also have, as I told you, the decrease these exchanges of sodium and hydrogen overload. They prevent sodium and calcium overload in the heart, decrease the ventricular remodeling, and they have important effects on the oxidative stress by having the effects on the various mediators of inflammation. Further, they have potential effects on the mitochondrial dysfunction also. All these functions are related to the responsiveness in heart failure. They can decrease the endoplasmic reticulum stress, because these drugs decrease the increase of ROS, ATPs, and so on. Overall, these procedures are clear. Recently approved drugs for heart failure include Verigoat. This is a soluble guanylyl cyclase stimulator, right? So it sensitizes the enzymes to endogenous nitric oxide. Now, the importance of this guanylyl cyclase is that the nitric oxide produced thereby is very important and it causes smooth muscle relaxation, reduction of hypertrophy, and inflammation of fibrosis. So that is the importance of Verigoat, which is besides increasing sensitivity to nitric oxide, also directly stimulates the soluble guanine transcyclase and therefore improves the outcomes in heart failure patients. Some people have labeled it as the fifth petal of heart failure treatment, four pillars, and some authors like to say there are five petals. Fifth petal would be Verigoat, a very, very important drug because the role of nitric oxide is too much important in the pathogenesis of heart failure because of downstream effects. Then we have got drugs like cardiac myosin activators, omecamtiv mecarbil. So this is just like uh, it's positively activating the cardiac myosin distinctly. For example, this is the
Dr. Singh, please bind up in 2 minutes.
sure, sir. So this omecamtiv is also a new drug which has been found out to be useful, and this is the model for this would just be more hands pulling the rope, and thereby there will be more myosin activation, and it would not increase the heart rate, it would not increase the stroke volume, it would increase systole and stroke volume, but there is no change in this parameters which would be deleterious for the heart, and thereby this is useful for heart failure. Mavacamtam is a drug which is exactly opposite to that. It's used only for hypertrophic cardiomyopathy, and it is an antagonist. Basically, it's a myosin inhibitor. Ivabradine has been used for patients who could not tolerate beta blockers and has been found to be useful. And RN is currently one of the drugs which is being useful for patients of heart failure and for patients who have got heart failure with reduced ejection fraction. So, if you look at the treatment of heart failure, the current guidelines, which are, of course, to be updated later on, but currently we have these drugs as of class 1 recommendations, and that's when needed, are all the four pillars, and so on forth. So we can go on for the treatments. Of course, currently we also have so many other treatments in the form of mechanical devices and so on, but these four drugs are the pillars, and the new drugs which we have got. For example, I just want to tell you that the heart failure with the preserved ejection fraction, for that we have got drugs like semaglutide and tirzepatide, which are GLP-1 agonists. They have been found to be very useful, and currently we have got evidence that these drugs do cause so usefulness. So this is a figure which can help us to know the mechanisms of benefits of these are known as cardiometabolic drugs now. So these drugs, sitagliptin, SGLT inhibitors, GLP-1, right, are now better known as cardiometabolic because they target the metabolism of the heart. And GLP-1 agonists also have a very useful effect besides the useful in diabetes, which you know, they are being useful, proved to be useful for heart failure with preserved ejection fraction. Because in heart failure with preserved ejection fraction, it is basically the basics which are we have to go for. For example, diabetes, for example, hypertension, what other causes are causing the heart failure, and we have to look for those. So, inflammation is emerging as a very important biomarker, very, very important uh, feature in heart failure, and we're targeting inflammation, and we've got various drugs which we have thought to be useful. For example, Kanaki Nimba was the first successful drug. Endeavor trial, which Mitiprasad showed no effect because this is a malaprotease inhibitor. Though we have the currently anakinra has been shown to be effective in patients in the red heart study, and ziltivimab is being tried upon for the heart failure. And the last but not least, cardiac metabolism is the one of the latest targets for heart failure, and we have got various agents which can target the cardiac metabolism because cardiomyocytes as such have a limited capacity for the energy storage. So ketone esters have been tried because they enhance ketone utilization, thereby they improve the cardiac energetics, they decrease the utilization of the glucose. And we have other drugs like talagelstat, nicotinamide, riboside, and so on, which maybe in future we will be getting these drugs again as important targets for heart failure. So overall, if you look at this developments in heart failure, very very exciting, very tremendous developments, starting from the four basic pillars of heart failure therapy. Now we have targeting inflammation, we're targeting cardiac metabolism, and if you look at the four basic pillars, we have got ACE inhibitors or ARNIs, beta blockers, MRAs, SGLT inhibitors. We could add the Veriguat as a fifth petal maybe sometimes, and we have got a role for these drugs. The new targets are being achieved. So that's what I want to convey. Thank you so much.
Thank you, Dr. Jagjit Singh, for the illuminating session. The session is open for any question answers.
I am happy, uh, we have good number of delegates in the hall, and I am sure this is a very sensitive topic of heart failure. So, any query? Yes, please. Please introduce yourself, and you can. ये ले लो mic, please.
So I am Dr. Daman from CSR IHBT Palampur. I am a principal scientist over there. So Dr. Jagjeet was really an enlightened talk, and we enjoyed all. But as you have mentioned, there are a lot number of drugs starting from beta blocker to last. We have antibodies also that we are going to have for heart failure. So what your view about the? Did we say about the clinical practice that for the population, whether masses or India, that they have a conventional therapy and the multiple increase with the this antibodies and the new class of drug. What is the difference between the cost of treatment?
So thanks so much for your very nice question. It's a really concern for us because as we always tend to go for that part because we can't afford all the uh, medicines which are especially costly medicines as the Western world could. But one good thing about it, sir, that the four basic pillars, sir, the basic pillars, four pillars, they are still very much in our, under the common man can also you can just look at them and can have them because we're talking about advances they would be, as we tell, they are part of it. Maybe they are proven actually, and they're coming the guidelines. The current guidelines which are there, the four pillars which you discussed, is inhibitors are especially nowadays ARNIs, beta blockers, melanocortin receptor antagonists, and then the fourth one is the SGLT inhibitors like DAPA. So even in our country, dapagliflozin is still not costly. So I think, being the pharmacy capital of the world, this is to our credit that we can provide these drugs, the basic drugs for heart failure, to even our most poor patients. And that's the best part of it, sir. And as far as you're concerned about the antibodies, and of course, when they will come up, let's see, sir, because the whole world is changing. And we all know, as students, and most of you know, that currently we have got so many maps being approved, isn't it? So, Kanakinumab was one, which I just told you, but of course, it was not so useful. But the thing is that the world pharmacy is turning to, what you can say, very elite type of preparations, which
Biologics, they're moving towards biologics,
yeah,
and a time will come that biologics will be cheaper than your chemical molecules.
sure, sir.
This is what is presumed as of now, but
But one thing we didn't worry, that we are the pharmacy capital. We have made so many drugs. We will even make the biosimilars of those MAVs, sir. I think with such a good expertise we have in the pharmaceuticals, and I am really I give claps for my pharmaceuticals industries because they are adept at making, once the drug is out of its
patent.
period of exclusivity, we will make those, and there's no, I don't think there's a point of worry. But the important thing is, sir, for therapy, we have got the four pillars exclusively under our, you can say, we can buy them, they are not costly, and patients can be on them. And oh, yeah, one important thing about is that, of course, if anybody has not asked or would wonder, do we start all these four together? So what do you think? We're talking about four drugs, isn't it? I'm talking about four drugs. If you go into hospitals and ask the clinicians, I've got many of my cardiologist friends and people in medicine also, we talk to them. They said that, yeah, it is not so easy to start. You're telling four drugs, four pillars, yeah. But it's not so easy, but we try to give them when they're hospitalized. So when they're in the hospital, we try to give them all the four drugs together because at that time we are administering them. They don't have choice not to get it or not. And once they feel the betterness, they feel better with that, they can continue at home. That's the advantage of starting four drugs. Of course, they should start at low doses. We should titrate them to the highest doses. They should start at low doses. For example, beta blockers, we know ARNIs should be started at the low dose and build all the four together. The current guidelines also say that the adherence to this. So if I just like to add to it that the guidelines are told were of 2022, but currently 2025 guidelines of ESC, they have given a position paper on how to increase adherence to this GDMT. GDMT is the four drugs, right? So they have given us guidance to start slow with all the four drugs, build up the drugs, and because it has been seen that these four drugs, if added to the patient's therapy, can increase can improve mortality over 5 to 7 years, can be added to the patient's life. Such is the importance of giving these four drugs together. Of course, there are challenges, but we should try to do that. Thank you.
Thank you so
Thank
much.
you, Dr. Singh. I think now we can further the discussion during tea. Okay, be limited, please. First time is yeah.
So nice to meet you.
I want to ask in the last slide you have mentioned what is the role of iron
Yeah.
in management of heart failure.
Sure, sir. Because iron deficiency has been found to be increasing the patient's part in the pathophysiology of heart failure. It's something known as pyroptosis. We call it apoptosis, something known as pyroptosis. Deficiency of iron has been found to be having an increase in uh, problems in heart failure patients. Additionally, though correcting iron would be useful, but as I told you, I just like to show you the latest one of those slides, which show that we may not be improving the mortality, but we can improve the symptoms. This is one of the latest gamma trial, which was published just few months back. The question was efficacy and safety of IVRN, right? The prescription uses ferric carboxymaltose, right? And of course, it did not improve the outcomes of death or mortality, but it improved the symptoms. So that is how the usefulness of currently what we know about the usefulness of iron. Though usefulness of iron is approved in the guidelines since they play important part in the pathogenesis, including part of apoptosis, and thereby they have the usefulness. Trials have given us to right. The Iron Man trial, for example, was the one which proved the way of iron for heart failure therapy. Thank you.
Thank you, Dr. Singh.
Thank you.
Thank you, Dr. Jagjeet Singh. Sir, please. So, as a gratitude towards him, we will request the chair sirs to kindly bestow him with a small momentum. So, kindly. एजेंसी पूछिए हाँ आपकी स्लाइड्स शादी जी हाँ
Uh, Good afternoon, I think. Good. So we have the next speaker with us, Dr. Vijay Bhatt.
हाँ sure sir please be seated for right introduce you.
He's a distinguished scientist and group head of DRDO Defense Institute of High Altitude Research, Leh, UT, Ladakh. With a strong academic foundation in veterinary science, he holds BVM, MVSc, and PhD. He formerly served as ARS scientist at ICAR CARG. His research chiefly revolves around adaptation, physiology, and nutrition in extreme environments, high altitude stress biology, pineal gland chronobiology, environmental toxicology, and water quality impacts on health. He has made notable contributions in developing region specific animal technologies suited for cold, arid, high altitude regions. For instance, hybrid broilers, goats adapted to Ladakh conditions. Dr. Bharti has published over 200 research papers, hold multiple patents, and has guided several PhD students. He has also authored important work on pineal gland physiology under environmental stress and its role in circadian biology. His work plays a vital role in DHAR's mission of developing agro-animal technologies tailored for sustainable living in harsh, high-altitude landscapes of Africa. With this small introduction, I invite Dr. Vijay to continue with.
Thank you so much, sir, for kind introducing me. Uh, Good morning to all of you. As introduced, I'm working in the Defense Institute of High Altitude Research in Leh Ladakh region. So last 15 minutes, I will be sharing some of my work with you regarding water quality in North Western Himalayan regions in India and how it is going to affect our health, public health perspective. So we all know that whatever the waters comes from Himalayan region and mountain region, it's generally we say it's safe. So in another couple of maybe another 15 minutes we will be uh, going through the actual qualities of different water resources in, uh, in Ladakh, Himachal Pradesh, Uttarakhand, as well as a new state of Union Territory of Jammu Kashmir. So I will be focusing on only these four states of northwestern Himalayan regions. So as we all aware about that, and next part of my talk will be the how this problem can be solved because uh, in isolation, not only one institution, maybe DRDO or any universities or any public health department from the state governments or local NGOs and local level at panchayat level can solve this problem. And you are also well aware about that the scarcity of water in those regions and specifically during the long winter periods. So we all have responsibility to safeguard those water resources. So just I will share those of the things with you and. The once you know the water is affected and water having the something that is not uh, we just say it's water as some essential minerals, it's a part of our essential nutrients. And if you consider if something they are also we are drinking and we are taking some contaminants with those essential nutrients as well as the water. And now you can imagine the infrastructure economy involved to control those waterborne diseases, water related diseases. So you can just imagine the impact of load and impact of economy and public health systems. So if you will say it's a why this water resource is northwestern Himalaya is something is entirely different to control for developing the control measures as compared to other plain regions. If you see that it's altitude, the environment as well as the temperature range and wind velocity, these are the few things. And geology specifically when we say the water quality, especially the mountainous region of Himalayas, igneous and metamorphic and sedimentary, that's the something important. Even though the human intervention is very less in those regions, but because of these regions still those waters across the different resources are not suitable for drinking for longer periods without any treatment. This is the main reasons. So if you will see this, why even now I'm also proposing that the the quality standard set by the BIS and WHO for water for plain region may not be suitable for the mountainous region. Because of that, the whatever the tolerance level, any toxicants, the safe level is decided based on their entire what is called physiology of the particular species and the surrounding environment. If you'll see the animal, whether the as well as the human beings living in the extreme altitudes, greatly affect because of hypoxia. And whatever things is very looks it's a normal in plain region, the same thing when became the very what is called deleterious to the human health as well as the animal health. So whatever the tolerance levels, safety levels, and the reference range set for the plain regions, other regions may not be suitable for mountainous, and that too also high altitude northwestern Himalayan regions. And as we know that the main resources of water in those regions is the glacier melted, and because of this global warming, that's still, so we are going to face in near maybe one decade, future decades, so limitation of that glacier, and that too that will lead to the what is called low uh, level of the water from the river. Basically we are getting the water resources from the river as well as the groundwater, and groundwater gradually, not only in the plain region, in high altitude region also going gradually going down. It's on an average 150 or 200 feet below we are getting the water from, and that too also we have to shift the places to get those groundwater. I will not go into detail for this, why this fresh water is still it's a limiting factor for the livelihood and what is a habitat, and increasing that the what is called habitation in those areas. If you'll see here, I've just put in the few earlier study that so in even the Lake Uller and this last 2014 in the Kashmir Valley, and it has been already affected. Our group started in Ladakh in 2010 in just Indus River and Siok River, surveying this water from the different what is called the sites where the most of the farmers and villagers were taking those drinking water as well as the sources of irrigations, just to check out what is the level of contaminants in Indus River, because Indus and Siok River is a very important river system in Union Territory Ladakh, and that is also going to the Union Territory Jammu and Kashmir. In, during those regions also 2010, E. coli, presence of E. coli, as well as at some places the arsenic and lead were very prominent. So then we shifted towards we should look into the groundwater system, and at some places also groundwater also were affected with the arsenics as well as aluminum concentration high as well as the iron concentrations. So by this, for this first review, we went into detail to why not we just study in different block system and village and different valleys of Union Territory Ladakh to have a comprehensive data set to formulate certain managemental aspects to control those measures to reduce that contaminants. So these are the parameters. If you will see that it's a so it's that is clearly indicative that even the mountainous region of water source is contaminated with uh, what is called heavy metals as well as the even the essential minerals at higher level, and some of the minerals at lower level. So we need treatment before drinking for longer periods. And if you'll see these data, uh, even the dissolved oxygen and the chloride content, hardness, and specifically hardness, mountainous region water resource is very, very high. Some places, if you'll go even the 500 what is called, we generally we say it's a TDS level should have a 120, 80 to 120 or 140 in our what is potable waters. Even the but in general in high altitude regions you will find the beyond 150 200 even more than 400 TDS levels. So there is urgent always need to just filter before drinking. Otherwise it's a lot of issue to develop the high calcium content because of high magnesium content and chloride content affected caliculi, uh, incidence of caliculi in renal caliculi as well gallbladder caliculi. Even you see that although the nitrate, sulfate, and phosphate level is very high, because you all are aware of that these are the sources comes from the industry as well as the agriculture waste and domestic waste. But if you see the chloride and bicarbonate content is very high, that is indicative of because of this mountainous igneous and immature types of rock present in Himalayan regions. Again, these are the findings of trace minerals and heavy metals. If you'll see here, the arsenic and iron, silicon is important, and at some places nickel is also is a concern. Uh, at some places, even the zinc, nickel, and iron, and copper. So invariably, heavy metals are presence is very common in across the water resources in high altitude regions. Now we have also studied the hazard index. So how long it will take to cause the diseases in animal and human beings? So for that model, we took the dairy cattle as a important model, because dairy is an important source. Dairy product is an important source for getting the whatever the soil is contaminated and plant is contaminated with the uh, hazardous materials, hazardous chemicals. It will come to the animal uh, animal body, and the animal products will have some of the parts of those contaminants.
Dr. Bharti, please conclude in 2
Okay.
minutes. Yeah,
Okay.
fine.
So this is clearly indicative that the cobalt and nickels it's having, so directly it is linked with the sources of water sources as well as plant sources and soil sources affecting our health. So we cannot ignore the contaminants presence in the high altitude water. It may or may not cause the what is called hazards to the human health as well as animal health. It's clearly indicative. It is affecting our health. And these are the glimpse of those regions how this is water is contaminating. And so I have highlighted here the lead, arsenic, and fluoride also could be presently. Fluoride didn't we have not found the at many places it's a higher level. And so as no, I will go. What are this solution? I have just here put the collaborative solution and future process. The joint and collaborative efforts are very, very essential, because if you'll go to the literature, maybe 2 minutes. What? So the working on water, if you'll go to the literature and publications on the water quality, we will get huge number of publication and level of contaminants. So we need to standardize. We need to establish what is the level that is will be alarming or hazardous. That's a very confusing thing. If you pick any samples from anywhere, some parameter will be higher, some parameter will be lower. So there we need to have a collaborative approach. There one centralized data banks where all the data has to be what is called processed. Then only it will be helpful for developing any policy. So that is lacking, and that too also in the high altitude regions. So sharing and available data knowledge in water quality is very, very important. Then for getting those standard data sets, we have to have a standard of SOP for collection and analysis and methods. So I'm not concluding this. So current laboratory findings that's clearly indicative that even the high altitude northeast western region water resources are affected with what is health hazardous contaminants, and we need it's a basic region, it's a natural rock erosion anthropogenic sources, and the task force need to establish in those states to address this very alarming problem. And then just proposing Himalayan water quality observatory, and then a strict monitoring of the use of high mountain river lake, and as well as the tourist visit of, and the mandate tourist carrying capacity has to be established before permitting them to visit those areas, and then promote green chemistry approach to reduce uh, contamination of those regions, and then mainstream one water approach, integrate watershed management, watershed reuse has to be otherwise in coming decades we will have huge problem when water crisis in those regions. And with this I'm concluding my talks. Thank you.
Thank you, Dr. Vijay. It's really insightful to understand that we were usually thinking that when you go to Leh, Ladakh, or Kashmir, you will have the purest form of water. But
What my
you're
message to
alarming
say,
us that the quality of water will be not so good for tourists even to consume, even from the ponds or from the hand pump or from other sources. One of the reasons you are saying is erosion from the rocks.
yeah.
And another thing which you are talking about is barometric pressure. How it is affecting the quality of water.
Uh, if you, I don't know how many of you have visited those regions. If you'll see that they are the what is called capacity to accept those population is, if you'll see Union Territory Ladakh is in hardly 3 lakh population in entire states having, and the sources of water is very small, and the influx of tourists is I think in lakhs, and then so because of this misbalance, and so the west is it is confined to the particular regions. It's a few water resources, manage Indus River's water system. So it has a huge load of contaminant, and that because of that, it's a gradually it's a that's the main reasons. So that is why we are proposing to even restrict the tourist movement in those regions.
That is one reason. What I'm asking is, you are talking about barometric pressure. We can understand that the oxygen, let's say,
Yeah,
hypoxia is there because of that. That is understandable. How it is affecting water quality?
yeah. It's not a water quality. I was trying to say the how does even the slightly change in the water level that may be safer. We say as the SOP is developed as per the BIS and WHS standard for plain region, the same level maybe one ppm fluoride is safer for us to take 1.5 ppm. That level may not be safer to high mountain region because of this hypoxia. Because of hypoxia, our
Okay, you're
tolerance
relating it
levels
to
of
hypoxia,
yeah,
that level.
our tolerance level. So we need to address immediately those problems. That's one.
So please go ahead. You need mic?
Good morning. My name is Avnish Mishra, and I'm from Naipur, Guwahati. It's a really wonderful talk to highlight the challenges in the higher altitude area. So, what are the common arsenic level you have identified in that region, and how it is different than the other region where we are having the more arsenic contents, like in the Ganges belt and some of the southern belts, we are having high amount of arsenic in the groundwater. How you are correlating this with your scenario?
Gangetic region, what I studied, I've not quoted those data. We have data for this one. It's a very huge. It's even somewhere you will get even the 15 ppm of arsenic. You know, 0.05 is a
It's more
tolerance.
than 50, 100 ppm
Oh
is
yeah.
also a
So
ppb.
so I studied in Haryana state. I studied in Karnataka states in northeastern region. Also, my friend collaborator. It's entirely different. That is why when I was reporting this high arsenic content from the Ladakh region, Himachal region, I I had to look 20 times before saying in any conference and publishing the data. So that data is still not published because first we have to confirm the arsenic, how the arsenic will come. Because generally we say it's a Ganga or other rivers, Yamuna rivers is coming from the industrial waste and domestic waste and human waste. It is because of kind of igneous rock,
Yes, alluvial sources.
alluvial sources that is coming in the Indus River and Siok River and the groundwater of the Leh Ladakh region, JNK, in Himachal Pradesh, Uttarakhand, maybe Arunachal Pradesh. I didn't have it, data right now data. So those, because of those, so we cannot control that groundwater uh, contaminated through this rock. So better we have to propose the community-based filtration system.
Even
That's
though filtration is not sufficient to
yeah.
eradicate this one.
That is why a lot of people they are working over it to have for longer the life
So
of membrane should be.
what are the major health concern you have identified in that region because of this?
So that is why I was saying that renal calculi and gallbladder calculi in mountainous region is very common, and that could be the one of the reason because I found it's a 200, 400, 500 because this project started when the problem come to the Indian soldiers. So why the soldiers is having everything is fine, but still when we went into details, Then we found that is because of calcium chloride and sulfate nitrates they are coming. So caliculi, other study I have not done much
Because
to correlate.
renal failure and all those things are quite common with
Yeah, yeah.
hepatic failures. That's
Oh,
also.
definitely
Thank you for
liver.
highlighting this issue.
I think if there's one more.
Dr. Les Dika, member of pharmacology at the University of Nottingham. I want to hear just that how gallstones they are in unpurified water.
Gallstone. It's a high calcium content. High calcium content in sulfur. It's making a caliculi, nucleus of caliculi. That is the reason. So minerals content will be high. The filtration rate
No, sir.
because
The renal calculi can be there because of high calcium, but he's talking about gallstones.
I think they are due to fasting, due to say heavy meals. How they are related to unpurified water.
yes, it's because of this liver, because of the liver damage and high minerals content. That could be the one of reason, but I haven't correlated directly. The higher incidence, these two incidents is very common in mountainous regions. So I cannot
So
give the
somehow indirectly it is related to liver damage, and then it may be leading.
so I cannot from this link it because I haven't studied clearly.
Anyone else from students from the last rows would like to interact? That's more important for us.
And
If there's no questions, so
and
thank you, sir.
I would like to invite you all to our laboratory for collaboration and do such kind of work. DRDO is very eager to collaborate and fund and help you all the students, researchers, and what is the faculty even to address this is a very common issue not for the Indian soldiers, even the public health point of view. Thank you so much. Our lab is in Chandigarh also, in Leh Ladakh also.
Thank you.
Thank you.
It's a token of appreciation. Thank you, Dr. Bharti, for the wonderful talk. We would like our chairpersons to honor him. Hands, please.
Hello. Moving on, we have the next speaker for the session,
Dr. Navneet.
Dr. Navneet Purana. Navneet Purana holds a PhD in pharmaceutical sciences and have over the years has established himself as a prolific researcher with more than 130 publications to his name. Scholarly contributions span neuropharmacology, Alzheimer's disease, Parkinson's disease, oxidative stress. Dr. Purana is particularly noted for using PAS software to virtually screen phytoconstituents for their potential neuroprotective effects. He plays a major role in the academic leadership of lovely professional university. He has a lot of achievements in his biodata. So because of paucity of time, I think I'll ask him to continue with his talk. Thank you very much.
Thank you very much, sir. It's my privilege and honor to have my talk in presence of my own respected teacher, Dr. Goyal, sir. And good morning to all present here. With the permission from the chair, I wish to put light on one generalized topic, which is very emerging and important nowadays. All of you have heard about AI ML role in our life. Hai It is somehow you can all correlate with all your daily activities. It is coming in a big way, and it is not a new topic. If we talk about it, is if we talk about AI, we all are aware about it, and what comes in our mind, we there are a lot of softwares we are using it currently when we talk about AI. So if we talk about very common one is the Chat GPT, then the DeepSeek, and Gemini, many things are coming in our mind, and they are not new, and they are emerging day by day. And if we talk about the applications of AI, that is a quite new thing which is coming in different sectors, and it is in a still emerging phase only. And for that particular component of AI in preclinical and clinical research, I'm going to cover in my short talk. So coming to this first, what is AI and ML? We all are aware about it. Okay, thank you. So AI, we know about it. It's a artificial intelligence by elaboration, and there is a system which learns how to interpret the data which we are giving to it, and according to the data which we are giving to the system, they and the commands, they are learning the data and interpreting it and giving us the output. So that is a AI. And ML, if we talk about, this is a machine learning part, whatever the things which we are getting, the data which we are getting in, if we are connecting into a machine that is giving a output, so that will become a subcomponent of AI, that is ML, machine learning. So talking further, if we talk about the preclinical one, so if AI role is there in our life, we know about, we used to take the help in many aspects. In preclinical, it is equally important, and n number of things are coming in preclinical research also for using the AI as a application part. So what if we talk about AI in ushering the different roles, it starts from the first step, this one, drug discovery. So let's see about drug discovery. The first step in drug discovery might be the lead identification. And in that part also, there are n number of things coming into the market with the application of AI one. So what happens when, if we talk, go about the conventional route for drug discovery, it is generally starting with that certain molecules which are having a good binding affinity to some receptors, and accordingly we go further. So in that, there are n number of things which are already there in the existing things without the AI also. Now, how AI is helping in whatever the data which we already have in the literature, that are to be put into the system, and that system will automatically identify the lead molecule based on a specific receptor, the activity, and accordingly that particular activity which is coming up for the best for a particular lead molecule, subsequent steps are also generated. What has to be done further? So if we talk about, it is a hypothetical note, it is not a hypothetical. There are softwares in the market. If we type in Google or any other software, you will get n number of softwares for all AI applications in each step of drug discovery, starting from the first step to the last step. So in that way, drug discovery, it is helping in accelerating the compound identification, optimizing through intelligence screening also. Subsequent to that, if we go about toxicological screening, that is also helping. That is also the AI systems are coming in this particular application part also. Pharmacokinetic, you have heard about Swiss ADME also, na? So that is basically predicting certain pharmacokinetic parameter based on the previously fed information, है ना? So in that way also, many softwares are also emerging out in this particular section of pharmacokinetic AI ML also. So then another one is the disease modeling. If we talk about disease modeling, in that there are the softwares which basically help in proper designing of a model for mimicking the pathophysiology of a condition. So in that also, the AI is taking place the role. And biomarker discovery, quite obviously, the novel therapeutics, targets and agents, they are also helping in this particular aspects. Sorry. So it is helping in automatically identifying the relevant chemical and biological properties. And there are computational approaches for streamlining all these things in the preclinical research. If we talk about the advantages of AI ML, what advantages it offers over the other conventional methods, quite obviously the automation and objectivity. If we talk about the manual methods or the conventional methods, we have a exhaustive system to follow. and there is a limitation of manual intervention also. So manual things can be done to a limited extent only. But if we talk a help of AI system, it will be a automated system, and objective it will be more in the output. Then data driven insight, quite obviously, everything which is coming as a output from the AI software is basically the input that you have given earlier to the system, and it is having a enhanced accuracy also and cost effectiveness. Quite obviously, when manual intervention is least and the output is based on the data and the system which we have already put into a existing system, so cost effectiveness will be quite obviously more in that. Now, one example of AI thing application in not only preclinical, in clinical aspects, it's coming in a big way in clinical one. Preclinical is also equally applicable. That is imaging analysis. So you must have heard about the softwares. There are software which put your scan of CT scan, maybe the normal other scans also, the body scans, and they give you the proper diagnosis. Whatever the things which are there in any body part, they can be easily detected and identified, and it is helping the physicians also. And the same thing is applicable for the preclinical research if you are doing some image analysis of some animals tissue also. And if we talk about the video tracking, we have any number of softwares which help in the video tracking of animal for behavior analysis. In that, the data is coming up automatically. That is not AI. But the data which is coming up from the softwares, if we put it into a system which is having a earlier some inputs that this data has to be analyzed in this way, so all things will be coming up automatically as the output which we need. Okay, so that is also the applications of AI in the video tracking system. So this is one example. If we talk about the activity levels, here you can see the AI can detect the activity of the animal automatically and give the inference of the experiment based on the inputs that you are looking in. Okay, then social interactions, which are very difficult if you do it manually or some software also. The data which is coming is quite large for analysis, and that can be easily analyzed and coming up with a very concise output through the help of some AI tools and the cognitive function also. Okay, then it helps in the predicting modeling also. As I told you that there are certain conditions what has to be optimal for going up for experimentation, that can be also optimized through the AI system. Means, for example, how many groups, how many duration of the study, what the doses are has to be followed, and many a number of variables are there which can be what you can say restricted for a particular experiment through a proper involvement of AI systems also. And these things are right now already there in the existing system. So study designs and optimization, it helps in these things. And if we talk about the ethics part with respect to animal studies, which we are very much concerned also, that is the 3R concept. So it is also going to help in that direction also. So reduction of the animal use, because we are going to use a very optimized system which is predicting through the existing data sets. So in that way, there will be a 3R follow. We can follow the 3R. So what 3R we know about? It's a replacement, reduction, and refinements. Those all three things are possible with this AI usage at the each step. So that is one replacement. We can replace certain things, certain usage of the animals at a particular step. We can reduce the number of animals for a particular experiment by using a proper AI tool here, and refinement of the processes also. Then what it empower us for this, it gives the real-time feedback. You see that if you have a long experiment where you need a feedback simultaneously when the experiment is running up, so it is not possible for a person to be there, or if it is a video tracking system also, you need to have the continuous analysis or feedback what is going on in experiment, so that the AI tools are now having a capability to do this real-time feedback, precision medicines also, and efficient data collection also. Then if we talk about integrating this real-time data for dynamic interventions, this all data can be easily applicable and applied to the real-time interventions like continuously monitoring the things, automatic interventions, and improving the safety of the first you if you do about preclinical, then also in the animals and the clinical part also. Now, everything which is there in the society, they have some positive things, pros, and there are cons also associated with this. So these are not cons, these are not disadvantages, but yes, challenges quite obviously will be there in any system, any new technology if it is emerging out. So challenges will be there. So this AI in application in the preclinical or clinical part also has certain challenges. One is the data quality. Basically, the AI system which is predicting the things, it is predicting the things based on the data which you are giving in earlier. So it is all dependent upon the things which you have given it earlier. So the intelligence, automated intelligence, this artificial intelligence is not an intelligence automatically. It is the intelligence that you are giving the system earlier. So that data which you are giving in is basically linking to the output which you are getting out of. So that data quality, if it is good, then the system will be giving you good output, good quality output. Otherwise, the quality of the output can be substandard also. And interpretability, then also it is a issue, because what you interpret from the results is also a challenge in this AI system. Coming to the ethical consideration, what I suggest you, what I can share it here is the challenge which is coming in the AI now, which might not be in our mind currently. Let's say, for example, if we are using a chat GPT, so what output which we are getting, we are blindly following it, है ना? So how that output is coming, is it, can it be managed? Can the output which is coming out from a system, is it possible to manage? Yes, it's possible to manage. So if for example, if there is industry or a big person, big you can say organization, who is willing, or who is having a what you can say, intentions to influence the masses for particular thing. So whatever the AI system which they are developing, the input, if we are giving it in a different way which is not intentional, so that input to the system may influence the output, and that will be that output is the many persons are using that particular software, so all will be going into that wrong direction also. So this is coming up with the challenge, coming up not in a big way, but yes, it is there, that the chat GPT and other things which are they are predicting it, they are predicting based on the influence of certain industries which are putting the data into it, and that output may infer the users, that what basically they intend to do. Okay, so that ethical consideration can be the issue. It is there with the previous system too, and it is there in the AI also. So that basically it is the main thing among the challenges. We have to limit of those challenges and come up with the bridging the gap between the existing one and the future one, and that computational sciences and experimental sciences we can merge it, and it will lead to the cost reduction, increasing the speed of the experimentation, and the reproducibility of the experiment will also be improved. Okay, so this is a new paradigm for biomedical innovation if we talk about AI applications in all the aspects of drug discovery. And one aspect which I wish to share it, which is not the preclinical one, the clinical one. This particular project, I gone through it. I conducted this small project in Punjab, specifically to the school-going students of 8 to 9 to 12th class, with the SC community. And we had taken the help. This is basically funded by the Punjab State Council of Science and Technology under the DST one, and what they are willing to have is in the data for AI prediction of certain anemia condition. So in that way, what we have done in this for this particular project, it is a clinical one, not preclinical one. But here, what we did is we went to certain schools where the students are there from 9th to 12th class, specifically for the SC community, because it is the call for SC community only. And we try to get the data from the different aspects which are correlatable to the anemia output. Okay, so those all data we have taken out. There is a lot of parameters like the social things, the other all the habits that they are following, the food they are taking, the symptoms that they are getting in. Okay, so all these things we have taken up, and the demography detail and all those things, we put that data into the system. And then we have also taken the HB levels, the all the other things which are related to the anemia condition. And we, out of the data of total, we can say the 1000 students, 85% data we have put as a input to the AI, and remaining 15% we have predicted through the same system. So the what we got is the 15% we had the already the data which is available with us, that how many persons are anemic or not anemic. So we are able to predict 85% accuracy with the remaining 15% population. So this AI system is helping with the basic input of demography and symptoms to predict the anemia condition without testing also. So what is the use for this particular project is, if in government sector, government agencies like state governments or central governments, they have certain basic information with them, demography and basic things. They can be taken up through the apps also. That information, if we are putting into the system, this particular AI software will be predicting the probability of having the anemia population in a specific region. So they can target specific region for the covering up that anemia condition in the region. So
Dr.
that we
Navneet,
have done.
please bind up.
This is the last slide. So this particular flow is there, and this is the system which we have developed for the Punjab population, anemia risk explorer. And here we have different sector. This is the first slide where we have to put the data. If we have the data, initial data, that will be put, that will be validated. After validation, then the prediction will be happening for that particular data set, that how many persons from this particular sector can have an anemia condition. So how it works, I'll show you. This is the accuracy one of this particular system. It is coming around 85% the accuracy, and this is in Punjabi and English language for general public. So we get some basic information from the users. This is in English, the same things. We are putting the information here, the like basic details, how you are feeling. This will basically the symptoms of anemia, menstruation details for the girls, diet details, then social and lifestyle things. And these are the influencing factor which we have found from the our previous study, which are having a high correlation with the output, that is anemia or not, anemic or not anemic condition. So that's why we have figured out and put these things into the system. And out of that, when we click on the assign risk, this is coming from where the person is not having that uh, test done on that, the probability of having anemia condition with 90% probability coming it. So it is having 15 out of 20 score, means the chances are there to have a anemia condition based on the four major contents. Similarly, this is not one thing, this is the only the prediction one, that will not help the community. So there is subsequently the another one, which is anemia action lab, that will help the person to get from the anemia to non-anemic condition with the different interventions like diet and all those things. So this is how, if you set your HB score or the score which you are getting in the previous one, the daily food choices which you have to add up to your daily one, according to this, you will get 8 weeks, 12 weeks, what you can say, diet chart for the particular person to follow, so that he or she can get out of the anemic to non-anemic category. Okay, so that's all. That is small work. Thank you very much.
Thank you, Dr. Navneet. Uh, we are having a good time to discuss, maybe 5 to 7 minutes. We can take 2 to 3 questions from the audience. Yeah. Can somebody pass on the mic?
Thank you very much, Dr. Navneet, for that very
Thank you.
insightful and informative presentation. And
Thank you.
I think that is the future of sciences, wherein AI and ML is going to have a huge role. But my question is, now that you know there are digital solutions available for preclinical studies like drug design and development,
Mm.
starting from target and lead identification to its optimization to its validation, and then molecular docking and other aspects. We have the digital solutions available, but ultimately we have to test the drug again in the animals in the in vivo models. Once the targets and the leads have been identified, validated, optimized, then we have to do the in vivo testing. Is there any digital solution which will completely replace the animal use in future and replace them with digital solutions for in vivo testing also, or maybe in vitro? In vitro anyhow can be done, but in vivo, is there any digital solution which could completely abolish the use of animals?
Thank you very much for your question. It is quite relevant also. And this is a question which came into my mind also earlier. And that's why I'm working on a very small project in the similar direction, how we can replace the complete pack of in vivo study. But currently it is a regulated one because in vivo study is a regulated requirement for going up to the clinical study. So we don't have currently like this any regulation to waive off the in vivo study. Just go by the
No, is it possible?
Yes, now future, less future is definitely it is possible. Definitely it is possible. It is coming into the US with a guideline in the last year with the certain reduction in the in vivo study based on certain this organ to chip and other activities. So it is there in the developed country like US. They have FDA has given a guideline related to the improved usage of certain these AI things and other digital tools to reduce the animal usage for subsequently. But what is your question is it is yes possible. It is yes possible in the future because whatever the data which we have for in vivo studies currently, it is sufficient to predict many things. But that is a challenge. What challenge I can foresee is body is very complex. It is not behaving same as we are doing it in the AI system. So it is very complex. The body of the animal is very complex. Similar, the same thing is with the humans too. So the prediction might not be proper, but yes, the systems will be coming into the future, which may reduce or maybe may omit also in vivo in future. I
I
don't.
think there is one which is coming up. That is the use of digital twins.
Yes, it is there in the digital twin is there.
Digital twins of not only the animals but even the human beings.
Yes,
And
this
in
software is
future,
there.
we may see that even clinical trials would be conducted
Yes, yes.
completely on digital
I
twins.
seen that digital twin. Based on that digital twin, I given a project to my student also. So I am also working in this particular direction. Right now, we are not having any data, but that is in the initial phase. So digital twin is very good tool, which can be explored further for reducing the usage of the in vivo and just predicting it without with the data also. So this is true. Yes.
Thank you. Thank you very much.
Yeah. Manish?
Thank you, Dr. Kurana, for the wonderful insight about AI and ML. So, in continuation to your question, sir, USFD has uh, now they have told to go for some kind of in vitro studies. Even they are not restricting it to the in vivo studies. So, in might be future, we may be getting some AI ML tools that might be like replicating the human or conditions. Yeah,
No, no, no.
maybe.
Nothing will come
No,
too long.
there is already a virtual cell. You see, it is working like a normal cell. Whatever the changes we have, perturbations we give to the cell, the response is similar to the natural cell.
Yes. Hmm.
Yes.
Hmm. Oh, yes, it is there.
Yes.
Yeah, it is there. Yes.
One
That is
more
very good also.
one more ethical concern comes in my mind whenever we are just going to give all the data to the AI/ML. What will be the surety and safety of our data?
That is there in the ethical consideration. There are
Yes,
two challenges in this.
because once we are just making it to open, the
Ah.
others may be having the access to those data.
Even
So
after going through clinical trials, we are not sure about safety of drug.
yes, how the AI
How can
can
you digital twins
Yes.
exactly no. So
making us
it
sure?
is with the asterisk sign only that maybe going into a right direction may not be going it. Yes. but it will help
Let,
generally.
let's hope
Con-
best.
Dr. Navneet, really a wonderful talk.
Thank you.
Firstly, I congratulate that you are doing a very good work on social aspects also.
Thank you.
We are also carrying out a certain type of these studies for anemic children under
Okay.
Poshan Abhiyan.
Okay.
So for that, I think I must have to take your input because this is a good idea to take into consideration.
Thank you.
Thank you.
Thank you. Thank you very much, Dr. Daman.
Anyone who would like to ask more? Ah,
Thank you.
if there are no questions, so let's wind up the session.
Thank you.
Request our chairpersons to kindly felicitate him. So please.
Thank you. It is my honor from my teacher.
So please accompany them. I would request our worthy speakers to kindly honor our chairpersons. Kindly join your hands. Dr. Rajesh Goyal. Thank you everyone for joining us. We will rejoin after 5 minutes. Thank you. Sir. I hope you have taken your.
Yes, I have taken. Thank you.
Thank you, sir. बेटा उनकी kids को kids को plan में लगा थी that way है ना इसका Dr. Rajesh Dr. Rajesh Dr. Miran Thank you. It's just a नीचे करना आगे से कहते हैं अंदर ही है प्लीज बटन ऊपर हो गया हाँ हो गया
Oh, there's no three remote.
I think it is in, let me see, Prague. Prague. Sorry, this is wrong for that. Let's just see. India. I don't know. This is yeah. This yeah. This is yeah. Which is very quickly. Okay. 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 This is
ये वाली
yeah. Okay.
सभी point पे ये point
A pointer.
ये point पीछे ना ये हो गया और आगे पीछे करने के लिए अभी freeze किया सर अभी check इधर आ लो
That's fine.
freeze it up
Yeah. So do you load or can I take the pen drive? Can I take the pen drive?
yes sir
Did you load it? And then I can. Otherwise, I will forgot it. Okay. And do you have also a microphone or only this one?
sir है mic वो है cordless mic
Okay. Thank you very much.
please हाँ जी यार वही mute कर
Where are we?
well oh yes clear good clear please go to खुल के सकते कौन सा आपके
हाँ जी मेरा हैगा चंडीगढ़ ਜਿਹੜਾ ਸੀਗਾ version 2 ਇਹ ਸੀ ਮੈਂ ਸਹੀ ਆ ਗਿਆ ਚਲੋ ਦੋ ਹੈ ਨਾ version 2 ਨਾ हाँ जी
ये वाली सर
ओके हाँ जी
ठीक है इसको मैंने कॉपी चेक करवाते हैं
34 slide तक डाले this is the last one
चाहिए बस यहीं तक है हाँ भाई 34 तक का सर
हाँ चलो वही भी
do you think you have to 34 to
yeah नहीं है तो जरा से
ये 34 है
ਨਾਲ ਬੁੱਧਾ ਦੇ ਬਾਅਦ ਵਿੱਚ
thank you 35 तक का
किथे
35 you think
I have to go quickly. There are 35 slides.
keep reminding you
Yeah, no, ਜਿਹੜਾ ਸੀ ਚਲੋ ਆ ਸੀਗੀ ਤਾਂ ਥੈਂਕ ਯੂ ਵਾਲੀ ਸਲਾਈਡ ਜਿਹੜੀ ਸੀ ਬਟ ਇਟਸ ਆਲਰਾਈਟ ਇਟ ਡਸਨਟ ਮੈਟਰ
चेक कर ले एक बार
ਅੱਛਾ ਇਹ ਇੱਥੋਂ ਵੀ ਹੋ ਜਾਂਦੀ ਹੈ
हाँ जी सर ये रिमोट भी है ये आगे पीछे करने के लिए ना ये ऐसे
ਆ ਜਿਹੜਾ ਸੀ ਆ ਫਾਰਵਰਡ
ये
ਓਕੇ
ਤੁਸੀਂ ਰਿਮੋਟ ਯੂਜ਼ ਕਰ ਸਕਦੇ ਸਰ ਪੁਆਇੰਟ ਵੀ ਹੈ
going back is this one home.
अभी स्लाइड
Oh.
ऐसे हो जाएगा यहाँ से फॉरवर्ड हो जाएगी आगे ये बैक ऐसे एंड तो वहाँ अपना फॉरवर्ड करना होम तो बैक
अच्छा नंबर 1 ते खड़ो कर लो okay okay
तो ना हल्का
so this is forward ਜਿਹੜਾ ਸੀ
ये
okay
एंड इसको सेव कर स्टार्ट चेक कर लेना स्लाइड लग गया हम चेक कर रहे हैं
अच्छा
ठीक है कॉपी करो
yellow
हाँ जी सर
ये बच्चे 2 है ना
हाँ जी सर वही रिवाइज्ड वर्जन बूटा 2 है
thank you sir okay modern technology yeah
short by
I went to school where were no computers
so funny short by KB by basically copies of and I'll figure it out not एक मिनट में सर ये बैगन कर no, there's 20 only. There's some extra on the back. Okay, so this is launched. Very I will not fix it now. Okay, only this. Yeah, 24 is 22. How many? The Diogenes. Come on, sir. Hello, no. एक मार कर लो ठीक है नाम से आ गया उनका नाम से बोलो इजी होगा नाम से
We are running short of time. We are running short of time. That's why we are. Because we are running short of time. That's why.
बोली ना नाम ही पता मेरे पे दे तो गए हो पहले फुल भी खोलो नाम होगा एंट्रेंस वेरो बस ठीक है यहीं से खोल लेंगे फिर नाम डालो ना चेक करके नंबर कौन सा है मैम कब इनका एंट्रेंस वेरो
बेटा
3 हो गए एंट्रेंस वेरो को कब भरी है
हैं?
एंट्रेंस वेरो को कब भरी डॉक्टर एंट्रेंस वेरो
उनका डलवा दिए
डाल दी
डालिए ना बस हो गया
ये सर ये तो सर है वो सर सर ठीक है बीए वाली सर की है सर का नाम पूछो ये कौन वाली है उनकी सर आपका नाम क्या है नाम क्या है आरवी ठीक है लिखा होगा ये लिखा आरवी सर की है ये सर की दूसरे के यहाँ से पता है
ठीक है।
ये है वो मैं ये खोलने के बाद सर नहीं है ना भी पड़ी हुई इसके बाद
Welcome back, everyone. I have the distinct honor of inviting our distinguished session chairs for this session, Dr. Pavan Krishan and Dr. Vandana Roy, to kindly graciously ascend the dais and preside over this pivotal session. सर आप 2 मिनट बैठिए मैं हमारी चॉइस
नहीं मैं स्पीकर है
हाँ सर ਤੁਸੀਂ ਕੋਈ ਨਾ 2 ਮਿੰਟ ਇੱਥੇ ਬੈਠ ਜਾਓ
अच्छा
ਮੈਂ ਤਾਂ ਹੋ ਜਾਂਦਾ
ओके
प्लीज प्लीज हाँ
अच्छा
No issues.
Swap.
What happened? Request everyone to kindly come forward. It's already delayed. So Dr. Pavan Krishan is professor and former head of Department of Pharmaceutical Sciences and Drug Research at Punjabi University, Patiala. Specializing in pharmacology, clinical pharmacy, and herbal pharmacology, he has guided many PhDs and MPharm scholars. He has published more than 90 research papers and received several honors, including the prestigious Saroj V. N. Sharma Prize. He remains active in academic and professional organizations, contributing extensively to the national and international scientific forums. Welcome, sir. Dr. Vandana Roy is the Director, Professor, and Head of Department of Pharmacology at Maulana Azad Medical College, MEMC. She holds a distinct position in academic and pharmacovigilance, serving as an expert member for National Health Program and Ethics Committee. She is also a fellow of International Medical Science Academy and has received several accolades, including a Distinguished Service Award, Teacher Award, and a Community Service Award. Under her leadership, the MEMC Pharmacology Department has been deeply involved in pharmacovigilance, running an adverse drug reaction monitoring center recognized under Pharmacovigilance Program of India. Through her academic leadership, Dr. Roy plays a pivotal role in promoting rational drug use, patent safety, and high quality pharmacological education in India. Welcome, ma'am. I would request our speakers to introduce our guests. I mean, our chairs to introduce our speakers. Sorry.
Thank you.
Good afternoon. It is afternoon now, otherwise it was to have been morning. So, am I audible? So, good afternoon.
This one is
Yes. Symposia 4
Yeah.
of SOL 2025, the 65th Annual National Conference of ICS. The symposia is on innovations in cardiovascular health and therapy. We have three speakers. We have three eminent speakers who would be speaking on different topics. We have requested the speakers to kindly shorten their talks and presentations by 5 minutes each because of the fact that the conference is running short on time. Our first speaker is Dr. Harpal S. Gupta. It is a pleasure to introduce Dr. Buttar, who earned his Doctor of Veterinary Medicine from Hisar, India, and another PhD in Pharmacology from University of Alberta, Canada. Over a 41-year career, he has served as a senior research scientist and assessment officer at Health Canada, retiring in 2013. He has authored many innumerable chapters, monographs, peer-reviewed articles with nearly 4,000 citations and an H index of 30. And his research has significantly advanced the prevention of cardiovascular diseases, obesity, and diabetes through dietary interventions, functional foods, and lifestyle modifications. In recognition of his international contributions, the International Academy of Cardiovascular Sciences India section established the Dr. Harpal S. Bhuttar Oration Award in 2014. Dr. Bhuttar holds many fellowships and recognition awards from the society, from many national international societies, and his collaborative work spans Canada, India, Europe, Asia, and the Americas. He is ranked among the top 0.5% of scholars worldwide. So, welcome, Dr. Buttar. Please.
Yeah. Thank you, Madam Chairperson, for the kind remarks. See, I will start. दुनिया गम तो देती है, शरीके गम नहीं होती, किसी के दूर जाने से मोहब्बत कम नहीं होती. वारिश वारिश शाह न दिला तो दूर हो ये पावे सैकड़े को दूर वसीए जी. I have been away from India for 62 years, but my heart is always here. Thank you. Yeah. So what we are going to talk about, prevention of cardiovascular diseases. Prevention is better than cure, and prevention is less costly than cure. We will always need surgeons, we will always need physicians, we will always need drugs. But there are many things within our own reach. The incidence of cardiovascular diseases in India is very high. Diabetes is also very high. Yeah. So it has been said that many people die at the age of 50. Many people in Asia die prematurely. So there are ways and means, risk factors. When they are taken into consideration, we can prevent cardiovascular diseases, non communicable diseases, and we can lead a better life. An Interheart study was done by Salim Yusuf and published in 2004. So what they did, the study was done in 52 countries involving about 30,000 people. Yeah, they identified non-risk factors, preventable risk factors, and modifiable risk factors. One of the biggest problem was the cigarette smoking. Cigarette smoking is considered to be one of the very high risk for cardiovascular diseases because it promotes atherosclerosis. It also causes oxidative stress by which free radicals are produced. And if there are not enough scavengers available, it will cause cardiovascular diseases. The other thing they identified was diabetes and physical inactivity. With modern man has less exercise, less physical activity, and what we need is movement is medicine, and I will show it to you how it works. So these are the findings of the implications of Interheart study. Previously, it was thought that nearly 50% of the risk factors were involved. 50% was genetic and 50% was modifiable. But what the Yusuf study did, they said that 75 to 80% of the cardiovascular diseases are preventable by taking care of the risk factors. Here is the slide of Hippocrates, who said that if you can cure a disease with food, leave the drug in the chemist's pot. These days, even in United States of America, the Secretary of State, Mr. Kennedy, is saying that every medical school must teach the courses in clinical nutrition, and because the doctors are trained with drugs, but they also should know about the what the nutrition can do so that they can play an important role in the prevention of cardiovascular diseases. The Mediterranean diet, it has been found that in the Mediterranean region, people use lot of legumes, yeah, yeah, which is rich in fruit, vegetables, poultry, and omega-3 fatty acids. And Dr. Esposito in Italy, she has done a lot of work in this area because in the Mediterranean region, the incidence of cardiovascular diseases is less as opposed to other regions of the world. That's why the Mediterranean diet is becoming very popular these days, in which people should take care if they eat Mediterranean diet, even vegetarian diet, what we eat in India, yeah, that's very good. And but it should be less in salt, it should be less in carbohydrates, it should be less in saturated fatty acids. Makhan, people should not eat too much makhan, and that will help them to. Okay. How come it is not moving? Enter? Okay. Pregnant women, those who take Mediterranean diet and breastfeed their babies, their children have lesser allergies, food allergies. So it is good that during pregnancy, if mothers use Mediterranean diet and breastfeed their babies will be more healthier. Yeah, there is another diet which is known as the DASH diet, which is translated as dietary approaches to stop off hypertension, which is very similar to the Mediterranean diet, and it is very similar to the vegetarian diet what you eat in India. Okay, so I'll keep on moving with this one. Yeah. Yeah. So during pregnancy, many women they don't take folic acid. The lack of folic acid causes spina bifida, and it also causes cardiac anomalies. If you take 700 micrograms of folic acid during pregnancy, you can prevent spina bifida and cardiovascular diseases. Nitrates. They are present in high amounts in in green vegetables as well as in red beet. As you know, nitroglycerin is commonly used for the vasodilation of, and it causes nitric oxide is used for the signal mechanisms in the cells, and nitrates also prevent aggregation of the blood platelets, so the coagulation of the blood does not take place. So taking green vegetables and red beet, it will prevent cardiovascular diseases and it will not cause stroke. Yeah. Anar, pomegranate, it has been used in Unani medicine as well as in the Ayurvedic medicine for centuries. And it contains large amounts of anti-inflammatory, antioxidants, and the principal ingredients are anthocyanins as well as phenolic acid. They are both, they prevent the free radical, they are scavengers of free radicals in the cardiovascular system, and help in maintaining the strength of the cell membranes. Yeah, Russian Nobel laureate, yeah, Eli Magnitov, who shared the Nobel Prize with with Paul Ehrlich, who is considered to be the father of chemotherapy. Yeah, so Eli is known as the father of natural immunity. So he promoted that the fermented milk products which we are using as probiotics these days, yeah, they contain the, the acid lactic acid bacteria, and they strengthen the gastrointestinal tract and increase immunity in our system. The lactobacilli, they also promote healthy microbiota in the GI tract. Yeah, probiotics stands. Yeah, yeah, probiotic is for life. This is what they contain. The live microorganisms are present in the lassi, dahi, yeah, which people you used to take lot in our culture. But these days, people are they go to the restaurants where they can pick up the hamburgers and they pick up the French fries rather than eating the probiotics. And they also help in the prevention of inflammatory bowel disease, and irritant bowel disease are prevented by the probiotics. The probiotics also help they do not allow the contact of the pathogenic organisms in the GI tract. So that means the non-communicable diseases will not occur if you are taking probiotics and if you are keeping healthy microbiota in the gastrointestinal tract. Probiotics also stimulate the goblet cells in the gastrointestinal tract, which produce mucin, and that the more mucin is produced, the more lubrication will be. It will reduce constipation in the gastrointestinal tract. There is a growing evidence that the children born with dysbiosis, they suffer from type 1 diabetes. And type 1 diabetes is an autoimmune disorder which kills, which eats the body, autoimmune disorders. And the immunogenic, the autoimmune will also kill the beta cells in the pancreas, and these children, they always need insulin. But if you are using the probiotics, then they will help as complementary treatment for the prevention of cardiovascular diseases and dysbiosis. And this is a slide which shows what are the dysbiosis causes. Even diabetes is caused by the gastro disturbance of GI tract. Trillions of microorganisms live in our body, which many people did not realize that what kind of role do they play in maintaining our health. Yeah, most of the dysbiosis occurs in the colon, and these are the different uh, different factors which cause dysbiosis in our system. Yeah, and some of the oligosaccharides which are short when they are metabolized in the colon, they produce short chain fatty acids like citrate, butyrate, and these amino acids, when they are absorbed, they help in the metabolism in the body, and they also help in building our muscles. Yeah, when they have an anabolic effect in the muscle building. Another thing which occurs the microbiota and the gastrointestinal tract, they produce trimethylamine, and trimethylamine is metabolized in the liver to trimethylamine oxide, and trimethylamine produces atherosclerosis, and it also produces the coagulation of the blood. So coronary thrombosis can be caused by trimethylamine, and people are finding novel treatments like resveratrol and probiotics. They prevent the formation of trimethylamine in the gastrointestinal tract. If the medical students must be that these days lots of papers are published from China, India, that gastrointestinal, the microorganism, microbiota are very important in our GI tract. Smoking. Yeah, smoking, the pharmacologically active principle of smoking is nicotine and carbon monoxide. Yeah, yeah, nicotine causes vasoconstriction and causes hypertension, and it also the nitric the carbon monoxide is changed into carboxy hemoglobin, which the oxygen carrying capacity of the blood is reduced. This is how the smoking is interfering in our system. Hookah smoking, yeah, it became very popular in United States of America in the university students. Yeah, they say one hookah session is equivalent to 10 cigarettes. Marijuana, marijuana smoking is also used recreational as well as it is used as a medicinal product in many states in USA. Yeah, marijuana has been legalized. Even in Canada, marijuana has been legalized, but it is just like a smoking. It causes the respiratory as well as the cardiovascular diseases, just like cigarette smoking. Where people ask me a question, how about vaping? When the modern man is using vaping, it produces the same effect as the cigarette smoking will do. Yeah, green vegetables, exercise, they are the best. The reduction of risk factors in the reduction of cardiovascular disease. Modi ji is leading a session of yoga. Yoga is becoming popular even in the Western world. There are many forms of yoga, yeah, and yoga has been used for centuries in India for promotion of health and keeping our body healthy. It does not need any gymnasium. You can do your yoga at home and keep your body healthy. There are 100,000 miles long blood vessels in our body. And whenever we walk, all these blood vessels come into play and they help in the prevention of cardiovascular diseases. Well, walking is one of the best exercise. When we walk, it also promotes our bones. It also promotes the cardiovascular system, and it also promotes the reduction of neurodegenerative diseases because the brain will get more oxygenated blood. We don't have to walk a long 30 minutes walk is good enough. Even 15 minutes walking will help you if you are brisk walking. Yeah, it reduces the walking reduces prostate cancer as well as the breast cancer in women. This is a Hindi slide. Yeah, चलत फिरत ना मरे बैठा हुआ मर जाए बैठा हुआ भी ना मरे जो थोड़ा थोड़ा खाए. So moderation of eating is very, very important. Yeah. So it seems that cardiovascular diseases can be prevented by our by reducing the risk factors which I have told you, and movement is medicine. Yeah, science cannot help all people. People have to help themselves. As I said before, we will always need surgeons. They have saved millions of lives in the world. They put the stents. They also do open heart surgeries. But it is our responsibility to take care of ourselves. This is what Lord Buddha said, that it is our responsibility to take care of our body, because we always say healthy mind lives in a healthy body. Yeah, so this is the ancient wisdom of India, which you guys can use. That's why we are motivating the young minds to go back uh, to our ancient system. Thank you very much for your kind attention.
We have time for a couple of questions. Does anybody, sir, do you have any queries, comments, observations? Yes, Raghav. We tell you for that.
Hmm. Yeah. Yeah. What was the question, ma'am?
Question is eating less or walking more?
Yeah, yeah. Yeah, she eat less, walk more. Yeah. Yeah, yeah, and eat the healthy foods, which are vegetables, which are fruits, and yeah. See, whenever we go to the restaurant, remember we always eat more when we go to the restaurants. Yeah, yeah, yeah. So moderation is the best policy.
It says which one is better, eating less or walking more. Out of both these, which one is better? कम खाना खाना या ज्यादा चलना में से कौन सा बेटर है?
Yeah, yeah. कम खाना मॉडरेशन बेहतर है. कम खाना सैचुरेटेड ज्यादा लोग salt खाते हैं. You should reduce the intake of salt. You should reduce the intake of sugar. You should reduce the intake of saturated fats, which promote cardiovascular diseases. Yeah. Yeah. Thank you.
Questions? Comments? So I summarize what Dr. Mughal has said. When we want to talk about the role of diet, lifestyle model, improving pregnancy outcomes, child development, preventing diabetes, preventing heart disease. Please talk about the role of science by healthy diet, moderate walk, yoga, now. So thanks so much.
Yeah, yeah, yeah,
Thank you,
yeah,
sir.
yeah. See, thank you very much. Yeah, and I will add one sentence for the people, those who sit on in front of the computer for a long time. Do not sit long time, 4 5 hours. Yeah, sit for a couple of hours and then take a break. That will be very helpful for you and healthy for you, because the exercise always gives you a better sleep, and it also promotes your better thinking, and staying healthy is our responsibility. That is the message I'm giving to you, that blaming others is very easy. Yeah, so to blame yourself is very difficult. Yeah, ये कैसे हुआ? अगर मुझे पता होता तो मैं करता. Now you know that what are the risk factors and you avoid those risk factors, and you will have a healthy lifestyle and you will live longer. You will have a happy, healthy, and long life. And quality of life will also be better. Thank you so much.
So, Client County would like to honor Client thank Professor Buddha with a small award. He wants to get a picture.
अपनी ये हमें नहीं पता ये फीस जो है मैंने ताम देते हैं
Better meet you can always talk.
So good afternoon, everyone. Continuing with our series of presentations in the symposium, our next speaker is Dr. Rajkumar Verma. So it's my immense pleasure to introduce Dr. Rajkumar Verma. He is an assistant professor at UConn Health in Farmington, USA. His lab focuses on the discovery and development of new medicines for stroke treatment using mouse models. Dr. Verma's passion for drug delivery discovery began in childhood while helping his father's pharmacy in India, sparking his creativity about medicine development. This led him to pursue the bachelor's and master's degree in pharmaceutical sciences, followed by doctor in PhD in pharmacology at Central Drug Research Institute, Lucknow, India. Motivated by the lack of effective stroke treatments, Dr. Verma continued his research journey and came to US in 2012 as a a postdoctoral fellow at UConn Health. Now, as an assistant professor since 2016, Dr. Verma has built a strong research program at UConn Health dedicated to advancing stroke treatment. He has published his research in several high impact journals like Stroke, Molecular Therapy, Nucleic Acid, Brain Behavior and Immunity, and PNAS. His work has been supported by several major funding and grant agencies such as NIH and American Heart Association, enabling him to continue his pursuit of innovation in stroke therapies. Thank you, Dr. Rajkumar. Welcome, and we are eager to listen to your innovations.
Thank you so much for the kind introduction. And thank you, organizer, to invite me and to share my work with you guys. So as you can see, the title is miRNA inhibitors. So these are, like you had heard about the so many mRNA-based drugs. So or RNA-based drugs, mRNA is one of the subtype of RNA. And with the COVID vaccines, so this research has gained momentum from last several years. So in that way, we have started our work to see if these mRNA, which now serve as a biomarker, can also serve as a therapeutic target, therapeutic moiety. So these are the outline of my work. So I will introduce you a little bit about the stroke, and then mRNA, their functions, how we can how mRNAs are modulated after strokes, and can we use them as a therapeutic targets. Then a little bit about miRNA synthesis, which we do with the help of collaborator and then we'll see its validation, both acute and chronic setting, as well as little bit we will touch about its mechanism action and some future directions. So as you know, stroke is a focal neurological disorder with acute onsets. What happen is whenever there is a disruption in blood supply to the brain cells start to die immediately within 2 to 5 minutes because brain don't store glucose. It depends on continuous blood supply. And when the blood supply is lost, so brain cells start to die and then can lead to stroke. Um, it's the second leading cause of the mortality in globally. In US, it's the fifth leading cause because of the advancement in the care. Um, you see the almost 12 to 15 million people worldwide suffer from the stroke. If you will see the statistics in your lifetime, one in the four people will have a stroke. So this is the severe condition. When I'm talking to you, every 4 minutes someone is dying from the strokes, and we don't have any treatment for that one. That's our driver. So globally, there is no neuroprotective drugs, though there are two drugs that I will discuss later on, which is used to create the reperfusion so that to prevent the further damage. But there is no globally approved neuroprotective drug except the one drug that in India it has been approved last 2 year back, which is endothelin beta agonist. So we are lucky to have any drug that we can have use as a neuroprotective therapy. Strokes are two subtypes: ischemic stroke, which occur due to emboli, and these are the major subtype of stroke, the like ruptured emboli that can travel to the brain and cause disruption of blood flow. And others are the hemorrhagic stroke, where the blood vessel is, disrupted in blood vessel is ruptured in the brain, or inside the brain or outside the brain. So I'm going to focus on actually this major subtype, which is ischemic stroke. Okay, pointer is not working, but anyway, so my focus, which is the pointer, laser. So I will take. Okay. These are the current diagnosis in clinics. You can do CT scan, MRI, as well as carotid artery imaging to understand what is which type of stroke is there, or is there a stroke or not. And as I told you earlier, the ischemic strokes in which the blood flow is reduced. So you see that there is no blood flow in these in the site of the blood here in these arteries. And when they do reperfusion, when they do reperfusion with the help of a thrombolytic drug, which is RTPA, or a mechanical thrombectomy, it lead to actually the perfusion. So perfusion restart giving the blood flow again, and then damage start to show the recovery little bit. However, even these two treatment has very limited use. 5 to 15% people are only eligible for these treatment. So because of their either side effect or their limited time window, or especially in case of endovascular thrombectomy, it's a very sophisticated surgical techniques which is not available everywhere, and it has limited time window too. So now let's come to why I chose the RNA therapeutics. So, we have to learn from the failure of previous drugs. Every single drug that has been used as an experimental drug in the in the labs, when they come to clinical trial, they fails. And there are so many reasons. I'm not going to tell you here. The one of the main reason that I'm trying to focus here is it's a multifaceted disorder. There are so many protein pathway involved in stroke damage, and you cannot control it with a single protein inhibition, single target inhibitions. So miRNA especially, which actually regulate lot of mRNAs, which may be of a particular class that may be neuroprotective, maybe anti-inflammatory, maybe neuro or uh, providing the trophic supports. So it can controls multiple mRNAs and then thus multiple proteins. And then if we are able to identify such miRNA that can control multiple pathway that happens after stroke, we may be able to get a treatment. That's our hope, that miRNA will control. So I will skip this slide. These are the type of RNAs, but we are focusing on miRNA, which are very short nucleotides, like 20 to 25, which I will describe in the next slide. So here, just briefly, there are almost like 3,000 mRNA in human discovered so far, almost 2,000 in mouse, and they are highly conserved between the species. So we can test them in the animal and then can use them in human, once we are successful. They are regulated post-transcriptionally, and this regulation has been linked to many disorders. They also serve as a biomarker. I'm not going to go in the detail here, so how the mRNA is synthesized, but basically what happens when mRNA actually bind with the mRNA, it stops the protein translation. When anti-MIR blocks the miRNA, then this inhibition is unstopped, and then it lead to protein translation. So this is how the anti-MIRs, or if it case the mimic, they will enhance they will stop the protein translation more. These are the some drugs that has been used in the phase 1 and phase 2 trials for cancer. So this list tell you that there is some hope for the treatment mRNA based therapy, and we are trying to do it in the stroke model. So now when you want to study any mRNA, any protein, any things, you need an animal model. So for that, because you want to create a injury and then test this inhibitor or even the protein or their pathology. So we use a very common, highly used middle cerebral artery occlusion model, which is transient. So what you do in this model, you take a suture, nylon suture, and then block the opening of middle cerebral artery here, and later on you reperfuse it to create a ischemia reperfusion injury, and this injury lead to actually acute damage that you can test by colored dye, which is TTC, trifluoride tetraethyl chloride, or through the CT scan in case of human. So we will use this model for our testing. So what we did, once we create this model, we did whole microRNA assays. So whole microRNA assays give us some target that are upregulated or downregulated in case of the miRNAs. So in this study, actually, we published in Stroke Journal, we found that MIR200C and 141 class miRNA are the highly upregulated. So now we know that these mRNA are upregulated, and we want to test the hypothesis: if we downregulate these mRNA, will it produce inhibition, or it reduce the infection or not, or it will reduce the damage or not? So for that, we also want to check. So before that, because it's a translation relevant or not, so we check that this miRNA is increased continuously up to 15 days in mouse model, as well as we took the advantage of clinical samples from the stroke patients, and we found that this miRNA is also increasing up to actually 90 days in the stroke patients. So this suggests you that it can be used for the further human subjects if successful. So I will not go in the detail about the chemistry, but we collaborate a chemist across the campus, Dr. Bahal, who is expert in synthesizing a specific class of antimirs. And these antimirs actually are long-acting antimirs that inhibits for a longer times. And why do we need is the most of the problem in treatment of stroke is most of the drug don't go to the brain once the brain barrier is sealed. Only during acute stage, the blood-brain barrier is ruptured, so you have a leaky barrier during the acute stage, and you can use your drug treatment during that time. So that's the opportunity. So when you use a drug that of not long-acting, you have to give multiple times. But once blood-brain barrier is sealed, you cannot give it to. So we were interested to get a drug that can inhibit it for a longer time with a single dose. So we can give the dose during this acute time setting. So with the help of Dr. Bahal, we were able to actually synthesize a modified
PNA, which is peptide nucleic acid based anti-MIRs, which are very stable, nuclease resistance, and they can block the miRNA for up to 15 days. That I will show you data later on. And we also made the nano formulation of this drug with the help of Dr. Bahal so that we can prevent its peripheral metabolism. So we started with, I will go quickly because I was told that I have to do. So we started with the in vitro analysis just to first safety, whether these nanoparticles or antimers are safe or not. So we use two classical tests, MTTSA. It tells you that it's toxic to cell or not. And the LDHSA, it tells you also about the cytotoxicity. So both of these assays suggest that these drugs are very safe, at least in vitro settings. So, and then we also want to, sorry, we also want to test these drug efficacy in vitro just to find out a dose range. Um, Also their efficacy. So we use actually three different subtypes of mRNA inhibitors. The phosphothyroid is the classical inhibitor that are not long acting. PNA, regular PNA base and gamma PNA base inhibitors. So as you can see here, the third one, the gamma PNA one, has capacity to inhibit up to 90% of the expression of miRNA in vitro inside the cells. So it suggests that it is highly efficacious. Now, once you culture the cell in this and then show that it is inhibiting miRNA in culture, we want to see if it is inhibiting miRNA in vivo also and is also neuroprotective. So we give a dose 4 hour after intraparental dose of this MIR anti-MIR nanoformulation 4 hour after stroke. And then after 3 days, we did a lot of biochemical tests, which is TTC stain. It shows reduction, almost 50% reduction. It also reduced the mRNA level, and there is very good correlation between mRNA expression and infarct volume. So it also reduced neurological deficit score. Sorry. We also, sorry, the picture is not visible, but we also want to make sure that this drug is going to the brain. So we tag these miRNA with a fluorescent dye called TAMRA, and which fluoresces when you take the pictures in the brain after dissection. And you can do immunohistochemistry and tag these to take the pictures to show that these mRNA actually went to the brain and the target site. So now you have seen acutely. There was one other problem with the drug failure is people has shown acute neuroprotection and but not shown the chronic effects, because the chronic effects are very relevant in the translation setting. So we also did the chronic effects. We saw that this drug is inhibiting up to 15 days, and this drug is also very specific, not blocking other miRNAs. You see, their effect is only MIR141. Also, the stroke occurred mainly in the aging disorders, aging population. So what happen is if the drug is not working in aging population, you might not use it for the stroke. So we recapitulate the same study in the aged mice, which are 12 to 16 months old, and we were able to see the same neuroprotection and inhibition of these miRNA in the aging population too. So we'll further actually give us confidence that this drug might be effective, now, as a biologist, you always want to do the mechanism study. I will not go in the details. So what we did is we identify its mRNA target from the target scan and then validated by qPCR. And in that way, we were able to find out. And then once we validated, we found that TGF beta receptor family was the target of this miRNA. Also, it also increased the BDNF and IGF level, which are the neurotrophic factors. So as I told you initially, it should block multiple pathway like blocking the neuroinflammation and as well as restoring the neurotrophic factors, so which may be a better candidate. We also tested at protein levels. The another requirement is you want to test these inhibitor for long-term efficacy in term of like behaviorally. So protein changes should translate into behavior functions. So we use a sensimotor task like rotarot test where we check the latency to fall. So more latency to fall means they have better sensimotor functions. As you can see, our drug has improved the latency to fall in terms of the rotor test, and as well as this discrimination index in a novel object recognition task. Briefly, we want to see if the memory is intact, it can detect the novel object or not. So the discrimination, okay, I'm come. So discrimination index is the ability to discriminate the novel object from the familiar object. If you have toward the more positive sides, you means it has intact memory, and if it is toward the zero side, it means it's losing the memory. So we saw that SYP and this gamma PNA based inhibitors were very effective in restoring the memory. It also increased the survival, so which is one of the parameter, when you want to test the drugs, whether it's increasing the survival after stroke or not, because there is always a mortality, almost 20 to 40% mortality in the stroke subject mice. Okay, in summary, I want to say just thinking that this is, I have not detailed about you, but these inhibitors actually block this inflammation through activating this TGF beta pathway receptors, which active. And also, I skipped some of the slides where we have shown the expression of SMAD, because this pathway ultimately lead to the activation of several transcription factor or target gene that may lead to the synthesis of neuroprotective proteins later on. This is my summary. Summary that we have shown this drug is effective both in acute setting, long-term setting, in aging population, and we hope that with the help of test more safety studies, we can provide a drug that can be used in the IND application for the stroke treatment. So we are collaborating with a lot of companies. They can take up this molecule and then do some safety study for us. This was published in Molecular Therapy Nucleic Acid. If you want to go in detail, please read this. This is my last slide, sorry. We are also working knockout mice model. If you want to study the precise mechanism of action, we need a knockout model. So we generated the knockout, and we were able to see some neuroprotection as we see in the drug. And now, if we want to see detailed mechanism like or other effects, so we'll use this model for the future studies. And in the end, sorry, I was running fast. In the end, I want to acknowledge my lab member, especially Sanjeev, which is toward my left side. Who did a lot of the work, and Dalin, the furthermost on the left side, who did a lot of behavior, Dr. Behal, and funding by NIH. Without funding, you can't do anything. Thank you so much for listening. And if you want to contact me at uh, ravarma@ucsc.edu. Thank you, Dr. Verma, for your very innovative and novel area of for challenging diary for snow, magical snow and treatment. So thank you so much for venturing into a new area, and we are very hopeful that it is successful with respect to the treatment as the treatment still remains fast. So we have quickly you can take one or two questions or any suggestions, comments from the audience. Yes. Yes.
Yes, Dr. Buttu.
So, what is the incidence of hemorrhagic stroke and ischemic stroke? Which one is more?
So in term of if you are talking about total overall prevalence is 1 to 2%. Ischemic star, yeah,
My question is about the incidence of hemorrhagic stroke and the ischemic stroke. Yeah, so does,
so ischemic stroke are more common. I told you in 85, but if I'll go to the severity, hemorrhagic stroke are more, almost like 50% people die after hemorrhagic stroke. In case of ischemic stroke, only 1 in 6% die. But yeah, common are more ischemic stroke.
yeah, but sedentary habits, they also promote stroke.
Yeah, I know this is a lifestyle disorder. So follow the guidance by doctor.
Yeah, sedentary habits mostly promote ischemic stroke.
Yes,
Yeah. Yeah.
thank you.
Yes, the audience.
Yes.
Are they in clinical or they are in like preclinical studies?
So for stroke or other neurodegenerative diseases is still in the preclinical stage. But for the cancer treatment, there are certain mRNA that are discovered or diagnosed in the cancer one. They are in the phase 1 and 2 clinical trial,
Sir,
but
and
not from the stroke.
neuroprotection, are they in clinical uses or still
Not yet.
exploring the?
We are just exploring. Yeah.
Thank you, Dr. Verma. I have just one small query we can address, I feel. There's a challenge regarding the reversibility of the when the neurons are dead or they become infarcted or due to ischemia.
Yeah.
So, what's the time frame when this can be useful or beneficial? With that aspect, have you explored? Because
So
when we say in ischemic stroke,
yeah.
the window frame is about 4 to 5 hours. So it almost takes time to diagnose and investigate. By the time even mRNA will take some time to produce or regenerate the proteins.
Okay.
So
Yeah. This is
how do you address this issue?
so. This is very good question. So I did not tell you that in the penumbra core region, which is the area where the blood flow is immediate surrounding of the blood vessels, which is occluded, the neuron die immediately and you cannot rescue those, but there is a lot of area which called penumbra area surrounding that core region. There are a lot of neurons that are not died yet and they are like injured. So if we can give treatment as soon as possible, sooner is better in that case. However, we are also trying to reduce the secondary damage which happens between the day up to day 3, in case of mice, and then up to day 7 in case of human, and where the neuroinflammation actually cause another damage. So actually this mRNA therapy might reduce the secondary inflammatory
That means
damage.
we can attempt for a post
So
stroke.
we are actually in our grant, we are trying to increase the window. So we started with the 4 hour, we have done 8 hour experiment, we have seen, and then we keep increasing it up to at least 12 hour, I hope. But after 12 hour, I think everything is died. So so we cannot go
not
beyond.
recoverable.
Yeah, unrecoverable.
Yes. Thank you so much.
No problem.
Very challenging and task. Thank you so much.
Thank you, Dr. Verma, for the insightful session. We would request our chairpersons to felicitate Dr. Verma.
सेल खत्म हो गया क्या
जिसका
इसके
शायद
शायद
इसका हमारी रिस्पॉन्सिबिलिटी नहीं थी ना
हाँ
So we come to our third and last talk of this session. Our speaker is Dr. Andras Swaro. So may I invite you on the stage, please? Dr. Andras Swaro was born in Hungary and he has a medical degree from Medical University Szeged, Hungary. He began his career at the Drug Research Institute, Budapest, and then did his PhD and postdoctoral fellow in leading institutions in USA and UK. He was then with the Department of Pharmacology, University of Szeged, Hungary, where he led the Cellular Electrophysiology Laboratory, became a full professor, served as the chairman and vice rector for science and innovation. Currently, he is Professor Emeritus at the University of Szeged, Hungary, and a full professor at the HUN Research Institute, Szeged. I may be pronouncing it wrong. Szeged is okay?
Szeged.
Szeged. Okay. Dr. Varo's research focuses on cellular mechanisms of antiarrhythmic and pro-rhythmic drug actions, particularly cardiac potassium currents. He has published over 300 papers, accumulating nearly 19,000 citations and an H index of 73, mentored 15 PhD students, received numerous honors, including the IACS Lifetime Achievement Award and Doctor Honoris Causa from the University of Buenos Aires. He is president elect of IACS and co founder and president of the National Academy of Scientist Education Hungary. So, welcome, Dr. Professor Faro.
First of all, I would like to thank for the nice introduction, and I would like to thank to Professor Goyal and Kumar for the invitation to here to India. And this is a beautiful country, and I appreciate not only the science, but also the culture of the country, which I enjoyed so much. So this is not the first time that I am here. This is the eighth occasion here in India. And I'm very pleased that in the crowd, mostly I see young people. And I would like to shorten my talk. So if I reach 20 minutes, please gently warn me. I don't want to waste your time too much. And because I think the audience is not specifically trained in cardiac electrophysiology, I try to simplify as much my talk as it is possible. So my talk is about possible novel target for antiarrhythmic therapy. And arrhythmia is an important disease. And this is maybe a complicated slide, but if you just focus on this, can have a pointer. There is a pointer because, yeah, this is probably. Yeah. So if you focus only this part, this shows that cardiovascular disease is leading cause of death presently, and arrhythmia is one of the most common causes. Arrhythmia can lead to sudden cardiac death. This is about 400,000 people dies every year in the United States, and this number is so high that the American Army, United States Army, lost during World War II 4 years of fighting. This is a very big problem and not only mostly does not affect the very elderly population, but quite a wide range of population suffering of that. Other type of arrhythmia is atrial fibrillation. This is directly not lethal most of the cases, but due to other consequences like, for example, stroke, this can affect quality of life and mortality as much. And the problem is with atrial fibrillation that it's very frequent. It's affect probably more than 5% of the population age above 65. So this is a major problem. We need also prevention for arrhythmias, which Professor Butter gave the talk about, but also medication to prevent, if not cure, but prevent the sudden death or the consequences, bad consequences of, due to atrial fibrillation. So the major strategy after the cast and sword studies, which the studies just showed that the antiarrhythmic drugs, which we used for many decades, were not effective because they did so much harm as benefit. So we needed new strategies. So this is cardioprotection, preconditioning, the treatment, the underlying diseases, and application, novel discoveries, special attention paid for drugs against atrial fibrillation, because as I told, it is very frequent. And the atrial drugs against atrial fibrillation usually should be atrial selective, and this can affect different sort of ionic currents. So when I go to directly to the topic of my presentation, I have to just simply tell you that antiarrhythmic mechanism, mostly the arrhythmia is due to the re-entry type arrhythmia, which is due to the problem of the impulse conduction.
and also the impulse propagation and the refractariness. So refractariness depend on the duration of the single action potential, cardiac action potential, which mostly, but not entirely, governed by different kind of transmembrane potassium channels. And the other important aspect is impulse conduction, which is mostly affected by the fast sodium current. So modulating these ion channels can be very crucial for the antiarrhythmic efficacy. But the problem, as I told you, modulating these channels, they also not only can prevent arrhythmias, but can also evoke arrhythmias when the patients are in a symptoms-free situation. So therefore, amiodarone, a very old compound, was the compound which had the least proarrhythmic complication. Therefore, in the industry and the drug development business, there was the attention was turned toward not the selective antiarrhythmic drugs, which only affected one single specific channel, but we had a multi-target effect on different channels, affecting both refractariness, impulse conduction, and also automaticity. And this was the structure of this is the structure of amiodarone, which is a complicated molecule. The problem is with amiodarone is that has a lot of extra cardiac side effects, not so much the effect which I mentioned causing arrhythmias. But the problem is that the ratio of these side effects is quite frequent. So amiodarone as a multi-ion channel blockers, it can affect different sodium beta receptors, potassium channels, calcium channels as well. So therefore, amiodarone was followed by the different compounds. Dronedarone was a compound which the concept was that they remove the iodide ion from the structure, and the desethylamiodarone, which also we had intensive work with. This is basically the main metabolite of amiodarone. So these were the studies which precluded my studies with the compound which I will talk about, tedisamel, another compound like that. And then we reached some compounds like the 16638. This was developed by my colleague, a chemical colleague from Budapest. And then we ended up with the SV compounds, which is, I will talk about that just today. So I think I can skip this slide because these are conventional methodologies in cardiac electrophysiology in vitro and in vivo type of experiment measuring experimental arrhythmias and also measuring transmembrane action potential and the underlying ionic currents. So this is the structure of amiodarone, and this is the structure of the SV compound, SV2649, basically, which is, you can see here, we have the two iodide, and otherwise this structure resembles to the class 1b sodium channel blocker maxiletin. This is a conventional old antiarrhythmic drug, a congener of lidocaine. So when we studied the effect of this compound, our compound, SV compound, it showed on the ECG that it lengthened the PQ interval, which was suggestive of a mild calcium channel blocking activity, and also lengthened the QT interval, which is indicator of the action potential duration in vivo setting. This is also was obvious in PEROS and after intravenous application. And also it's decreased the sinus frequency as well. So then we studied the electrophysiological effect of SV compound on ventricular preparation. This shows the so-called hair current, which is the underlying current on the action potential, repolarization, action potential. Duration, as you can see here, that the SV compound lengthened action potential duration significantly, and also decreased the maximal rate of depolarization, the speed, how fast the action potential develops, and this is indicator of the impulse conduction in vivo, or the QRS duration on the ECG, and this shows the effect on impulse propagation. So, now I show some effect on the atrial preparation. This shows a effect on the so-called gear current. This is the alpha. This is the current flows through the alpha subunit of the acetylcholine sensitive the potassium current, and this has particular importance when somehow we would like to treat atrial fibrillation, because this has antivagal activation effect. So then we see here the effect on the atrial action potential, also like in the ventricle, the impulse, the V dot max, the maximum rate of depolarization also decreased, and there is a also increase of the action potential duration, which is somehow correlate with the refractory period. And in this experiment, what you can see, this is an action potential recording. This is the control situation from an atrial fiber. Then when we apply carbachol activating the acetylcholine sensitive current, it shortens back, because this is a potassium current which shortens repolarization, and the compound, the S3 compound, lengthens this abolition, even lengthens the action potential duration beyond. So this is a very typical and useful antiarrhythmic efficacy, and amiodarone also shares this effect. And this is the effect on on the effect on experimental atrial fibrillation in the dog. So the compound comparing some other drugs in the therapy prevented atrial fibrillation in vivo dog model. So the effect on isolated canine ventricular myocytes on the late sodium currents are shown here. So this is the original current recordings, and this shows the effect of the compound at 10 micromolar concentration. This is also in the ventricular muscle myocytes preparation on the inward calcium current. As you can see, this is the original recording, and this is the current amplitude at different clamp potentials. So it shows, and this is important, there is a significant but moderate calcium channel blocking property of this compound. This is patch clamp experiment on different potassium current. Potassium currents, as I told you, are responsible to finishing cardiac repolarization, affecting effective refractory period. And this is the rapid delayed rectifier potassium current. The compound decreases it at 5 micromolar, a moderate effect at 10 micromolar, quite a robust effect. And there is a moderate effect on the slow delayed rectifier potassium current. This is another type of current. There is two other repolarizing potassium currents showing the complexness of the repolarization in the cardiac ventricle muscle. In these currents, the drug did not affect too much. And this slide shows the effect on the ischemia reperfusion ventricular arrhythmias in experimental arrhythmias in rats. And this figure shows that it was more effective, this compound, than the compound which we used as a reference compound. And this is, it overlaps this part, but this is the important figure. This shows that the compound almost completely prevented these arrhythmias even better than maxilatin, which was the starting point in our studies. So summarizing our data here is that based on the presented experimental data, the SV compound possesses antiarrhythmic properties as it was effective against both experimental atrial and ventricular fibrillation. The cellular electrophysiological mechanism of the SV compound are similar to those of amiodarone. This is important because amiodarone is the most effective antiarrhythmic drug in the market presently, but the compound exhibits the multiple channel effects and strong inhibition also the acetylcholine activated potassium current. And the advantage should be what we expect from this compound, which already patented, that its chemical structure is substantially different from that of amiodarone, lacking the benzofuran structure, and it expected to have therefore less severe side effects than amiodarone. And this is what we hope. It's a promising tool for further investigation at the cellular level and the pathophysiology of the antiarrhythmic and proarrhythmic effects of this compound. I think I skipped these. This is the list of my collaborators in this work, and I think this is can be my most important slide for today because I would like to encourage you, if you are master and bachelor students, that we have a very good student program in Hungary, together working with the Indian and other countries' government, which can finance PhD position in Hungary. And I would welcome every of you who are interested in cardiovascular research in Hungary in our lab. And I have to mention that we do not only do drug development start to this is a sort of drug development study, but we do basic cardiac electrophysiology, trying to understand the mechanism of antiarrhythmic drug effects and also the proarrhythmic efficacy of drugs or any other different condition, like, for example, like elite athletes arrhythmia. So therefore, thank you for your attention. And if you have any question, I would be ready to answer. And this is the program. And I put a poster on the wall if you are interested. And thank you for your attention.
Thank you so much, Dr. Varo, for sharing your vast work in discovery for another new antiarrhythmic like amiodarone. You all must be knowing that amiodarone is one of the most broad spectrum antiarrhythmics, but it has a lot of side effects, but it's still a broad spectrum antiarrhythmic used clinically. So we are looking for more amiodarone like antiarrhythmic drugs with lesser side effects. And it's just shown you what all their lab has elicited. So we have time for some questions. And thank you so much for sharing about the Hungarian program. So all the PhD scholars and the master students sitting here, you could talk to Dr. Varo. He's available and he's put the poster outside. So thank you for that. Also, we're open for some questions. Yes. Can somebody give the mic? Why don't you come in front? Come on the side. Or speak as loud as possible from there.
Sir, I want to question by what mechanism did amiodarone-like products counteract the arrhythmic effects?
He wants to know them.
Yeah, that's what's clear. It was a good question, and the answer is that has effect on the impulse conduction, especially at fast rate. I had not the time to go into detail about the frequency-dependent effect on the conduction, but has effect on the conduction and can block re-entry mechanism by blocking impulse conduction. At the same time, blocking potassium currents lengthens action potential duration, lengthens the effective refractory period, which also a very important so-called class 3 effect because it's prevent the early excitation by any kind of stimulus. And also, as I try to point out in the lecture, it blocks the acetylcholine dependent acetylcholine sensitive potassium current, which is an important current during atrial fibrillation. So as this three effect and also affects a little bit moderately the L-type calcium current, which has also importance. And blocking sodium and calcium current is important in the sense that has less proarrhythmic effect like other antiarrhythmic drugs, which have only selectively blocking the potassium current, lengthen action potential duration too much, therefore causing towards the point cardiac arrhythmia. And in the safety pharmacology studies, this is a major concern that if the drug can be cardiac or non-cardiac, lengthens QT interval, usually that's a major problem with many drugs. But this compound does not lengthen action potential duration as much as amiodarone has a limitation because not blocks only outward but also inward currents. And that was a very appropriate question. Thank you.
Okay, thank you. Any more questions? Any comments, observations?
SVG as an experimental drug. Are you planning to use as a therapeutic target or not, like as a therapeutically, or you just want to use it only experimentally to study the side effect of amiodarone? What's your goal with this SVG?
Yeah,
long term?
this is very conventional drug development project because we had the concept that we would like to end up with a compound which similar like amiodarone but without the extracardiac side effects because amio is quite good in terms of the cardiac side effects and we have a patent on this drug already and if the safety pharmacology and all the toxicology chronic this is just the beginning of the road making the long story short. And if it's patented and some companies are interested, the development can go on, or we can, and we have some follow-up compound, but I did not go into detail because of the time limitation. So this is, yeah, we would like to develop. That's the ultimate goal.
Thank you.
So one question. So toxicity, the toxicity of amiodarone, massive. I mean, it causes hormonal changes, lung changes, skin changes, and all. So you are working on the preclinical toxicity aspects of this drug?
So the chronic so this study was concerning on the mechanisms. Our hypothesis behind is that because the structure is so much different from amiodarone, lacking the benzofuran structure, we would not have this long list of side effects which you mentioned. Because we think that especially most of the extracardiac side effects depend not so much on the iodide, which many people think that it's depend on the iodide, but we think it's depend on the benzofuran structure. Toxicology studies is very expensive, and this is beyond our capacity in an academic basic lab. But this is the goal: have an amiodarone without the without the long list of extracardiac side effects.
Thank you so much. So we close this session. Thank you so much, Dr. Varo and the other speakers. So please.
Thank you, organizers and the speakers, for the wonderful session. So thank you all and the audience also for having patience. Thank you so much.
Thank you, Dr. Andras, for the wonderful session. We would like to felicitate you. A small token of appreciation for our worthy chairpersons. Request our worthy speakers to kindly come on the dais to present our chairpersons with the token. डॉक्टर गुप्तर को लेने के लिए
Sorry.
तुमको no, he's coming. Now it's we've traveled from both parts of the So this is for Dr. Vandana Roy. Thank you, ma'am, for making all the efforts and coming there. बेटा उनका पकड़ लो Please join your hands. Dr. Pavan Krishan. Thank you, sir, for coming here. We close the session now. We will come together again at 2:30.
Okay, doctor.
Cycle.
कॉपी है ये प्रेजेंटेशन
चाहिए ओके अभी इनकी सभी हाँ हाँ लास्ट वाली ना फर्स्ट वाली सर छोटा करते हैं हम देख लेते हैं भाई
अभी ये
इनकी नहीं हम शायद उन्होंने खुद डिलीट कर दी थी उस टाइम
इसमें देखना रिसाइकल में
सारा प्रोजेक्ट होगा मैं कोई अभी आप क्या फोन कर रहे हो यस कौन सा स्ट्रीम में फार्मास्यूटिक्स फार्मास्यूटिक्स
Please don't get some should be should be Okay. Immediately after lunch, I'll just make sure that Dr. Gata has it.
No, sir, pen drive.
Okay, sir. चेक करना चाह रहा है सही को देख लो फुल में तो इसमें में कौन सा इसको मैंने ये तो नहीं लेके आता मेरा फर्स्ट ही है
चलिए इस टाइम आप जैसे आएंगे आपसे
escape करके फिर पढ़ेंगे जब प्रॉपर में निकाल रहा है ये कहना चाह रही हूँ बंद करो पहले आपने पढ़ाया में ऐसे रैंडमली
वो चेक करा देना मैं प्रेजेंट हो गई मैं सेफ ही मूव करूँगा
आप तो वो निकालो इसको लेकर हमने मिनिमाइज किया इसको क्लोज करना है फाइल
कौन सी है
ये वाली हाँ नहीं इसका अगर बंद हो गया तो ये भी बंद कर दो तब निकल फोल्डर खुला हुआ है ना ये तो आपका चला चाहिए मुझको
ऐसे ही कर यूज में यूज
निकालो फिर ऐसे कैसा तो ना अच्छा है
तेरे जेब में पढ़ाई निकाल के देख
कभी गया खाना भी नहीं गया वो वापस आ गया मैम जा रही है वो आएंगे फिर तुम लोग मेरे साथ पे क्योंकि ऑर्डिनेट कोई और कोई आपका है ये टी है कि फोल्डर नहीं रखा और आ जाना है तो फिर अटेंडेंस लगानी है मैंने
अबे यार क्या हो रहा है इसको
यहाँ पे एक चेयर और लेकिन इस सेशन में इन स्पीकर और वो
अब मैं लगा
यार ये
तीन स्पीकर मेरे पास ये जो है वो कोई नहीं कुछ और कुछ फिर मैं बोल में जाऊँ लेकिन सीधा करके दे दे चाहिए हम तो बना ले बना कोई तो बना ले यार तो लागे और सीना बस ऐसे ना आगे करना चाहिए कौन सा Yes, sort of.
Are you one of the speakers or the chairperson?
Both of us are chairs, and then she's a speaker also.
You're Dr. Miguel. So we have three more speakers: Dr. Ghulam Muhammad Hussain, Dr. Muhammad Yunus, Dr. Ritu Khamis.
What you should do, you get a taxi outside your building. You go to our shop.
Ma'am, you had your lunch?
Yeah, well, it's Saturday, it's
Oh,
Saturday after
Yes.
sure, fine.
I don't want to bother you.
No, no. You also want that? We took that. If you want, you can go and have your lunch. Please. You're comfortable. Okay, lunch is available till 2:30. It's fine.
ठीक है
हम तो बोल रहे आ जाएंगे वो शिक्षण जाना है एक लोग आ जाएंगे
ठीक है सर
इसमें ना स्कैन वो नहीं है
Call for your personal university judgment. I'm not able to classify the do it this only with I don't need.
सब अलग ही ये ना बताने बस नहीं क्या हो गई तो अच्छा अच्छा वाला वाइवा तो ले लेंगे
वही आ जाओ वहां से रवि और दोनों आ जाओ रवि और रोहित हाँ सुबह जल्दी खा के आ जा और जल्दी कर लेना जल्दी मैं भी बुला दूंगा तो हाँ
या फिर अगर अपनी जैसे हम जा सकते हैं चल के
Study workshop which are she was into the सामने कोई भी जवाब देते मतलब we should do here thinking asking the question बस वो चीजें तो बहुत से इसके बाद में तो अपनी सारी मजे से सॉल्व कर
मैं देखती हूँ उधर ना ये टाइप पीछे से ये इसको पूछते हैं इसमें ये ना वो आपके वो
ये मुझे फाइव सेकंड की शायद सी और ट्रैक को एवरीथिंग हम पास नीचे पड़ा मैं कोई भी फ्लक्स होता है हमारे दोस्त हैं एक डॉक्टर अग्रवाल बनाया था मैंने लास्ट ईयर तिरुवनंतपुरम अग्रवाल मुझे दूसरा है डॉक्टर त्यागी भी मेरे दूसरे जैसा भी ये लास्ट ईयर त्यागी ये एसडी कॉलेज में पहले घर में ऐसे वो करेक्टर सबसे शेयर चलिए ना ओके ओके जा तो हाँ ये चाहता हूँ कि आप एक बार से बरिका चक्कर लगाओ और किसी की बार की कंडीशन बदल जाता है आज शाम को आप अटेंड करेंगे वो जो इवेंट आपको रजिस्टर करना पड़ेगा अटेंड करने के लिए कुछ खास नहीं हमारे भाई होता है जरा अपना डिनर पार्टी में
he will be here. So if you want any help, you can contact.
No issues. We're just helping for our colleagues. You can have your lunch.
So I'm just going for the lunch. I will be sending the other teacher back.
Yeah, thank you. I'm here only.
He is here. If you want any help, you can contact.
Please be comfortable.
Thank you.
Also have your lunch.
No, I'm here only. Okay, for the purpose, as you can drop here. मेरा सैटरडे तक ट्वेंटी थर्ड परसों आया नहीं संडे मतलब 3 दिन अच्छा ये स्पीकर जगह सी रात को होटल भी ट्रेन निकल ਤੁਸੀਂ ਟੈਕਸੀ ਵਾਲੇ ਨਾਲ ਪਤਾ ਕਰਦਾ ਵੀ ਕਿੰਨੇ ਪੈਸੇ ਲੱਗੇਗਾ ਸਹੀ ਇੱਕ ਦਿਨ आता है जी वाला जाने के बैठ वो भी दिन का 25 रुपए लगते मैंने चार्ज पे तो ट्रांसफर नहीं होगा मतलब बढ़िया है 2500 रुपए हाँ वैसे तो टैक्सी वाले जो है थोड़ी सी टैक्सी बढ़ी चाहिए है तो फिर बैठना आसान हो जाए नहीं मतलब चाहिए तो 4 सीट 2 सीट भी ना सिर्फ 400 रुपया बाद लगता है सच ठीक है मैं तो कर लेने मैं कर ले लेना लेकिन ये होता है ना उन्हें फिर छठ से usually 4 से 2 days वो से 5 लगते हैं So what, how's your family, how's everybody? Wife take
दो किताबां में ना रिश्तेदारी को भी है तो वो जानते हैं कर बन गए तो वो अपनी एपिलेप्सी वाली भी तो शादी वाली भी होगी या सर अच्छा अच्छा और कास्ट चार्ज नहीं होता मतलब कॉपीराइट भी आएगा उनको सेंड करना होता है शादी में हेलो ट्रेनिंग है हाँ जी हाँ so आज नहीं जा सकते या कल तो शुरू पिकअप करते हैं ना सर ਤੁਸੀਂ ਮੈਨੂੰ ਬਸ ਦੱਸ ਮੈਂ ਕਿੱਥੇ ਕਰਨਾ ਮੈਂ ਕਿਹਾ या किन्ने भी ਉੱਥੇ ਹੋਣੇ ਕਿਹੜਾ ਸ਼ਵਾਲੇ ਕੋਟ ਅੱਛਾ ਠੀਕ ਹੈ ਸ਼ਵਾਲੇ ਪਿਓ ਠੀਕ ਹੈ ਜੀ या ਤੇ ਉੱਥੇ ਫਿਰ ਆਪਾਂ ਸ਼ਾਮਲ because she wanted to change the yeah if I don't see her you'll be very disappointed sort of बहुत सुबह तक हो गई मैं workshop में busy हो गई बस end moment में you must respect people like और इस संडे का नहीं हो बड़ी आदमी करती है she's very bright ਉਹ ਜਿਹੜਾ ਦੂਸਰਾ ਜਿਹੜਾ ਅਮਰੀਕਾ ਗਿਆ ਸੀਗਾ ਉਹਦਾ ਉਹਦਾ ਵਿਆਹ ਅੱਛਾ ਉਹਦਾ ਵਿਆਹ ਅੱਛਾ ਕਿਤੇ ਸੰਡੇ ਨੂੰ ਹਾਂਜੀ ਆਇਆ ਵਾਪਸ ਅੱਛਾ ਹਾਂਜੀ ਉਹ ਸੰਡੇ ਦੀ ਸ਼ਾਦੀ ਹੋ ਹਾਂਜੀ ਅੱਛਾ ਚਲੀ ਗਈ ਹਾਂ ਬਿਲਕੁਲ so that's you will get everything ਪਹਿਲਾਂ ਮੈਂ ਨਾਲ ਬੋਲਣਾ ਕਰਦਾ ਸੀ ਉਸ ਦਿਨ ਤੋਂ ਬਾਅਦ ਅੱਛਾ ਇੰਨੀ ਛੋਟੀ ਜਿਹੀ ਗੱਲ ਸੀ ਸ਼ਾਰਟ ਟਾਈਮ ਪਰ ਫਿਰ ਉਸ ਤੋਂ ਬਾਅਦ ਉਹਨੇ ਆਪਣੇ ਆਪ ਹੀ ਵਿਆਹ ਦਾ ਕਾਰਡ ਭੇਜ ਕਰ ਦਿਆ now right lesson of the chaos that the man yeah I don't feel very like ਕਿੰਨੇ ਪੈਸੇ ਹੋ ਸਰ ਪਤਾ ਹੀ ਨਹੀਂ ਹੁੰਦਾ ਕਿਸੇ ਤੋਂ ਕੁਝ ਵੀ ਨਹੀਂ ਸਿੱਖਾ ਹੁਣ ਤੋਂ ਨੇ ਆਪਣੀ ਵਾਈਫ ਨਾਲ ਕੁੱਟੀ ਹੋ तो नहीं पड़े so yeah money is not the motivating stuff like that and then running for our own business आज के लिए होटल पे कार्य छवि छाता होती है एक डाल people want to know like ਤੁਸੀਂ ਹੋਣਾ ਚਾਹੀਦਾ Sending up a delivery intervention. Sending up a delivery intervention. Shall we tell the recycling is a very well now? Okay. Second time we get a challenge. Research is a very job. Yeah, so the sharing we have just to share around you know, the QBI with just in dollar. Anche grandi nostri gira. Gioca con uno di un giallo con di mise. Stato sia definito con un giallo. Facciamo studi. Lo fanno di spiegare il workshop. Actually, sir, research already somebody to Sham, sir, Sham will be Sham.
Swelling is the लेकिन नहीं होता है जो गला डेवलप भी है ना वो पीने लगे so something which but we can meet before that the bachelor championship the PGA these are the lessons between the PGA यार सेल्फ मूड यार मैंने वाले भी पेगन ये चीज़ें पता नहीं लगती सगर बुद्धि गुलाम से स्लैम के ऑफिस प्रेजेंटेशन इसके देना अन्य सिस्टर्स तो टॉप आएंगे अगर फ्रेंड सेंटर में अभी ना ठीक है फिर बाद में तो प्रॉब्लम होती है जिसका होता रहेगा वो ट्रीटमेंट टीम डॉक्टर रूज भी वो भी आ रही थी नीटवा बात रहती हाँ जी ये हमारे लंबा और मेरा नाम है कर चल दे यार एक कर दे विच तो विच है जो अच्छी छोड़ वो माने गए हैं इट्स अ वेरी लाइक सिर्फ पूछता मैं पेन ड्राइव में लगा के चला सकते हैं अगर आपको शेयर नहीं करना नहीं कोई ऐसा नहीं आप रखो बाद में डिलीट करके कुछ ऐसा ही वहाँ से हटो लैब में सर कौन 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 से हैं वन करके एक दवाई इसमें एक होगा ये
पीडीएफ है
नहीं नहीं कॉपी पीटी है सर पीपीटी है गुलाम हुसैन करके कॉपी कर लो तो आपको आसानी रहेगी डेस्कटॉप पे सर मैंने फोन करना है था खत्म हो गया इसका गुलाम हुसैन तो आपको -3 -3 and you may stop document में दोनों में stop है उसकी डायरेक्ट की वो लगा दो स्कैन करना हम तो बिल्कुल डायरेक्ट देखते तो सर्विस कौन भी नाम सब आधे आधे सेम कंप्यूटर में सेट के होंगे आधे सेम registration they will
for इसको मैं यहाँ फोल्डर खोलिए
और फोर हाँ यार टैक्सी वाले क्या अभी नहीं खत्म हुआ समझ नहीं आ रहा क्या काम करने के लिए किसको डॉक्टर तेजल गांधी क्या वो भी
See, Dr. Boyle, Dr. Boyle, Vice Chancellor,
को इसकी सेटिंग पता है?
फोन नहीं होगा।
अरे ऑन तो है, ये देख। नहीं रहता ये
Dr. और पूरे लोग अच्छे this time it's very obvious we are
डॉक्टर गुलाब प्लीज ये मैंने इसको रीनेम किया ये मेरा मैंने वो हो गया चेंज ये कुछ और ही होंगे मुझको फोन को तो भी आगे देखते हैं इसका नहीं है और अब हम के बाहर नहीं रंग देगा सेवनी का उसका ठीक है टेक्स्ट ऑफ पी इंडियन पर फाइनेंस स्टॉक में है हां ये तो पी
डिफाइंड स्टॉक है ये
हां इसमें पी फाइव पी
just right to confirm there is covered
ये मेरी पीपीटी की फाइल है
पता कौन सा बता नहीं है कर दूंगा ये देखना है सही है बात है पूरा देना ये
हां
एक्चुअली मैंने क्या होगा स्पीसी रहना था पता था हां मतलब उन्होंने पेपर इतने कॉम्प्लिकेट कर रखे हैं ना सर हां लगा वो बस सीमा में नब्बे नब्बे सर क्या तुम्हारा वहीं पे बिजी रहता है वो तुम्हारा भी डालना होगा
प्रॉपर्टीज में कहीं कुछ मैंने रीनेम किया पता है रीनेम
ज्यादा क्या हुआ कि ऐसे अभी कुछ ये मुस्लिम जगह से अलग अलग बात तो टेक्स्ट काम करो पहला नहीं करना लेट्स फिनिश मदर सेटा we are to show that seriously the information is for the this and you know that is correct families are also very more certainly the document work के लिए ये तीन बुक्स तो हो गया इसकी एक न्यूट्रिशन वाला मेरे दोस्त है डॉक्टर अभिषेक सिंह उसके साथ एक वो दूसरे मतलब क्या नहीं नहीं मेरे साथ मेरा अपना भी डालना है सोचा था ये वो वो एकदम मिल चुकी है तो मतलब बहुत ज्यादा स्ट्रेस हो गया है और ऊपर से अभी let's finish these things first then think about it how election वाले तो मेरे ख्याल next year निकल जाएगी हाँ ना मार्च में बताओगे
ये मुझसे रीनेम करने का
शामिल करने चैप्टर सब
क्या वो खुलने नहीं मैम पीपीटी की फाइल थी मैं उसमें अपना नाम ऐड करना और बन गया को लैपटॉप मेरा कहीं किया नहीं ना मैंने अभी फाइनल वर्जन तो ओपन ही नहीं हो रहा ना ये तो कोई सभी
हाँ यार इसी चला देना नहीं चल रहा है साले और जरी लड़की संगरों को पता कुछ है गारा है हाँ जी वो oh my god yeah the what is
Thank you very much.
एक काम करो इनको इनिशिएट कर दो
ये सब जगह ही
इसका मैडम आप लेकिन लाइट आ रही है वैसे का तो स्पेंड कर रहे हैं लाइट बंद एक लाइट और आ रही है सामने इसके ऊपर में जस्ट लेकिन वो नहीं आएगी तो शायद ये वाली नहीं होगी पोस्ट में प्रॉब्लम वो लाइट नहीं चार्जिंग फोन का nó cái gì đúng sẽ ô đi cho phải thì chỉ là ở đây chỉ chút giờ chỉ cả sự là transfer cho nên nó một chuyện nó Australia inside the finish to those conditions to be published oh yeah now the one that I see that thank you very much दो मिनट बाद ही करते हैं शिक्षक जब नहीं इसका बेहतर होगी हम तो वर्जन भी शेयर करते रहते हैं पिछले क्या है अपने पास जल्दी बुला रहा है रवि को नहीं Students generally do not get fully established in this and they will confidentially value like with friends. That's when I got to learn. वही ट्रेन कर दो सारे चार हम जब आए थे अभी सोच रहे थे आपको बोले जितने टाइम से कर रहे हैं जब पता चला कि विक्ट्री सबसे पहले जांच की तो आपको ही चेक आप हमें टेंशन Wait, even after but the end of something that actually such a good thing for now what is be my brother so I'm thinking you know I have
अच्छा वो बाहर जा ओके बाय खबर नहीं आएगी Yeah, this keeps going into two.
आपको ढूंढ रहे हैं सर फ्री वाले कोई नहीं हम जब नेम क्या कुछ सर मेमोरी इश्यूज ओके ओके ये उसका I'm sure she will contact the some people. I'm doing this for ये किसका होगा ज़्यादा किसका फॉरन हो phone problem. Contact about in charge of the so there's the government the government to maybe the society the students are coming 5 minutes. Right. The Charlotte Hills or the government also yeah, it's several other government. What is the type of yeah, I have both the students here as well. Sponsorship, that's another one. How editorial thinking. हाँ, 4 दिन के बाद परसों मेल आया कि रिजेक्टेड ठीक फ्लेक्सिबल more than 40%. मैंने क्या करवाई फिर 4 हार्ड वर्क software उनके पास भी कुछ लिमिटेड रहते हैं खैर मंगवाए तो अपनी बहुत और रिपोर्ट se effettuava nella Messica un'altra trama but if you're only in Tunisia,
Ma'am, you want your this to be pre-board? Okay. Second number. आप अपना ना डेटा दे दो डाल दिया बेटा kindly wait for 10 minutes the children are having their lunch मैंने बोला है मैंने कर दिया मैंने मैं वापस ही आ रही थी तुम खाना खाया वो कहाँ है दोनों कहाँ है वो आएंगे नहीं ना और अभी फोन बोल रहा मैं कैसे भी कराने और तो कौन है बताओ रवि का नंबर तो है फिर ये भी जाएंगे नहीं नहीं मैं फिलहाल वहाँ ना बहुत रश है हम तो वीआईपी वाले रिसोर्स पर्सन थे ना तो जल्दी खाना मिल गया बच्चों का थक ही नहीं रहा रवि हेलो रवि बेटा वापस आ जाओ खाना खा के उसको भी बुला साथ में तेरे कौन गया होगा रोहित हाँ बुलाओ दोनों वापस आओ ताकि कोई यहाँ टेक्निकल के लिए हो फिर ये दोनों जाएंगे इन्होंने भी तो लंच करना आ जाओ जल्दी आओ Ma'am, you want water? तुम्हें बाकी आ रहे बोलिए यार मैंने भी बोला पारस ट्रे लेगा ट्रे लेगा Sorry, sister, I don't know what I'm saying here. I don't know. Central Mali medicine, Ikidosi, confused lens. So you will say Canada user will be age of me. Speakers cover everything. Maybe speaker. Very modern. एक ट्रे और रखी तो इतनी बढ़िया बनी है। नेटवर्क अंदर नहीं आ रहा, मेरा भी नहीं आ रहा है आज। सारे सीसी आ रही है उनकी, मैं देख रहा हूँ कुछ नहीं।
What in the speaking of my client, he's a lady, very personal.
चेत स्पीकर भी हो चेत उनकी कभी करना
पहले नहीं हो रहा था बीच में हाँ मेरी बात पहले भी नहीं जाना बार बार चेंज करना है भाई ये देख अब ये तो वही चाहिए सबसे पहले आएगा 1 मिनट मैडम आएगा ठीक है क्या नाम मैडम है क्या नाम है इनकम हम मैम
फर्स्ट
हम अपने कंट्री कंट्री फुल करके कंट्री पे चला है कंट्री ठीक उसके बाद कंट्री में चलेगा दूसरा ऋतु का चलेगा ऋतु का भी तीसरा मेरे ख्याल से खोज होगा ठीक ठीक है ठीक और फिर मैं लोगों ऐसे जो नीचे चेंबर से भी यहाँ पे ठीक Slide on to चलो भी
Good afternoon to one and all present here. I have the distinct honor of inviting our distinguished session chairs, Dr. Ghazala Javed and Dr. Negat Anjum. Dr. Ghazala Javed is Assistant Director at Center Council for Research in Unani Medicine, Ministry of Ayush, Government of India, where she oversees technical operations and contributes to planning, implementation, and monitoring of research in Unani medicine, including drugs, standardization, quality control, and fundamental research. Dr. Javed also holds a PhD diploma in intellectual property rights and WHO fellowship in public health program management. She has authored or co-authored around 90 research papers, participated in more than 200 scientific platforms, and reviewed or edited 20 books. She worked extensively on international cooperation, engaging with WHO, WIPO, UNESCO, and she received several honors, including the Make in India Award, NCR Delhi Ratna, Dr. Abdul Razak Award, and the Dr. Sarojini Naidu International Award for Working Women. And our next session chair, Dr. Nigat Anjum. She is an esteemed research officer in the Unani division at the Center Council for Research in Unani Medicine, New Delhi. Dr. Anjum brings deep domain expertise in Unani classical formulation, clinical research, and regulatory sciences. Over the years, she has contributed significantly to the Unani knowledge base, having co authored research on traditional therapies, pharmacognosy, and patent dropout dynamics Unani clinical programs. She also played key role in research and public outreach. Dr. Anjuman hold a strong academic and research profile documented on her Google Scholar page and has been actively engaged in advancing the modern scientific understanding of Unani medicine. We welcome you, ma'am, both of you. Thank you. And
I welcome all of you to this session. Straight away, as I think we are already a little beyond schedule, so I'll straight away request Dr. Ghazala Javed to present her talk.
same.
She will be apprising us on um, Unani medicine in mainstream healthcare, the current scenario.
Full screen. Here, just click on this. Thank you. A very good afternoon to everyone. So, I really thank our respected Director General, Dr. N. Zahir Ahmed, who could not be here for nominating us for this symposium. And I also thank the organizers for providing this opportunity. My main aim is to set the tone for discussions and give you an insight in what Ayush and specifically Unani medicine is and what our research council is doing in this. So I'm sure most of you know about Ayush. The young crowd sitting over there, have you heard about Ayush? It is an acronym for Ayurveda, Yoga, Naturopathy, Siddha and Suvarigpa and Homeopathy. And recently it has been adopted as a word in the Commission for Scientific and Technical Terminology. So this system has got social and political push since the beginning. Father of nation Mahatma Gandhi, he was a staunch believer of indigenous system of medicine. And today, if we see the scenario, you can see the Ayush market growing from USD 2.85 billion in 2014 to 2023. So it started as a department of Indian System of Medicine in 1995, and then it was renamed as Department of Ayush and elevated as a dedicated ministry in 2014 to give a focused approach to these systems. So the objective of Ayush is to promote the traditional and indigenous system of medicines, and it is involved in policy formulation, regulatory framework, scientific validation, conducting awareness campaigns, and educational programs. This is a snapshot of strength of Ayush, where you can see the number for Ayush colleges having adequate number of UG seats and PG seats, Ayush hospitals and Ayush dispensary, just to give you an insight that we are there and the strong infrastructure is there. And out of this, if you'll see the strength of Unani medicine in India, so as the latest report in 2023, you can see we have 267 hospitals with 4,036 bed strength. Education infrastructure is also strong. We have colleges offering UGs and PG and also PhD programs. So today we can proudly say that India is world leader in Unani system of medicine. So basically, if it is new for you, what is Unani medicine? It is a science of which we learn the various states of body in health, and when not in health, and the means by which health is likely to be lost, and when lost is likely to be restored. The main focus is on the preservation and promotion of health and prevention of diseases. So since 8th century, it is flourishing in India. And as you can see, Hippocrates is the father of Unani medicine. These are our concept and principles. As I just mentioned, main focus is on preservation and promotion of health, prevention of diseases, and our diagnosis is based on the mizaj of a person, temperament. Normally, we usually ask, "Aapka mizaj kaisa hai?" It's different than that. So every human being has a particular temperament which we analyze, and accordingly we advise the prophylactic and preventive measures. So then we also focus on hereditary condition, environmental conditions, different complaints, external observation. The nubs holds a lot of importance, pulse examination, urine and stool examination. These are the various modes of treatment. The starting from dietotherapy, pharmacotherapy, we call it ilaj bil ghiza, ilaj bil dawa, Ilaj with Tadbir, where various regimens are advised. And in Ilaj with Dawa, main focus of treating a condition is through single drugs. And then we go to compound drugs if the disease is not managed with single drugs. Then minor surgeries we are doing. This is the organization from where we are coming. Me and my colleagues over here will be talking in these sessions. This is Central Council for Research in Unani Medicine. It is the research council under Ministry of Ayush. And all the research councils, whether it in Ayurveda, Yoga and Naturopathy, Homeopathy, they're housed in this building. Our network of peripheral institutes is spread pan-India. As you can see, we have network of 24 peripheral institutes, a dedicated National Research Institute from Hyderabad. Two of our officers are from there, Dr. Gulam and Dr. Rooj. They'll be making their presentation. Then a Central Research Institute in Lucknow. So like they're different levels, and a dedicated institute to look at the classical literature. And it is the backbone of this system. This is a snapshot of our peripheral institutes, just to give an idea, the strong infrastructure and government support which we get, and like in Mumbai, Aligarh, Srinagar. So the main objective of our research council is to formulate the aims and patterns of research on scientific life in Unani medicine, and we undertake research and other related programs, and then prosecution and assistant in research and propagation of knowledge. These are the research programs which are run by different program officers: preclinical and clinical research, fundamental research, focusing on validating the fundamental aspect of the system, drug standardization, focusing on developing monographs and pharmacopoeial standards, survey and cultivation of medicinal plants, as medicinal plant is the backbone of the system. So our institutes are involved in conducting surveys, collecting folklore knowledge, and cultivating for conservation and sustainable use of medicinal plants. Literary research program, of course, the classical text
which is there for this traditional medicine, and creating awareness through various means of IC activities. So just to give you a snapshot of major initiatives of CCRU, we are adopting the best practices. Our institutes, hospitals are NABH accredited, and laboratories, medical and drugs testing are NABL accredited. So these are the bodies working under Quality Council of India, and our pharmacies are GMP certified, and one pharmacy is DTL. So, and the Center of Excellence is established in regimen therapy at Srinagar. So to bring in standards in our practices, cupping, you all might be aware, we call it hijama. We have developed these standard operating procedures as we observe that this is practiced at various level in international and national platforms to give uniformity and to assist the regulators and provide practitioners the proper guidelines. We have launched this, and here you can see our Secretary Ayush and Advisor Unani, along with our Director General, Dr. N. Zahir Ahmed, launching this book, which is freely downloadable from our website. Similarly, we had brought out standard treatment guidelines. Musculoskeletal disorder is one of our strength areas. For traditional medicines, we are focusing on this. So we had published it through the Ayush vertical in Directorate General of Health Services, which is under Ministry of Health and Family Welfare. Same, you can see, we have launched, our council officers have worked in the development of these guidelines for management of metabolic disorders. These have been also been published by Directorate General of Health Services, Ayush vertical. Then standard unitary treatment guidelines for common diseases. It contains a list of 130 diseases, and we have also developed an app for that. So there's a Ayush vertical in Bureau of Indian Standards also. With these examples, you will see that how integration is a buzzword, and we are all moving toward that. Whether it is establishment of Ayush vertical under DGHS in Ministry of Health and Family Welfare, or Ayush vertical in Bureau of Indian Standards. So where we are developing standards for single drugs, terminologies, and for cupping also. So, our team has also worked in development of orientation guidelines for community health officers under Unani stream. So, this helps in mainstreaming healthcare in a proper way, and these guidelines focus more on early intervention based on Unani principle and practices. And this book we have listed how PHC, like primary health centers, secondary health centers, and district health centers community health centers and district health centers should function. So those guidelines are there of different level for mainstreaming. We bring out two journals. One is Hippocratic Journal of Unani Medicine and Jahanetim in Urdu language, because most of the text of this system is in Urdu and Persian language. So earlier, when the UGC care list was there in vogue, at that time our journals were listed in UGC care list. So this is our research policy, where we have laid down the priorities areas which we undertake. So as we get many collaborative projects from reputed institutes, so and from Chandigarh also. So I would like you to have a look at this document, which is freely downloadable. And our officer over here, Dr. Nikhat Anjum, she looks after intramural research programs, and Dr. Ritu Kawasra on collaborative expression of interest programs, where we invite proposals and that are scrutinized on the priority areas. So this is freely downloadable. You can have a look at that. We give support also, financial support. So these are our priority areas of research, whether it is autoimmune diseases, lifestyle disorders, viral infection, adjuvant therapies, diseases originating due to radiation and environmental pollution effects. So we invite proposal on these priority areas for research in both mode, expression of interest scheme, collaborative projects, and intramural research schemes. So we have also published training module for geriatric healthcare and manual on geriatric healthcare in Unani medicine. This document is also freely downloadable from our website, where we have laid down different modules how to conduct training programs for geriatric when you have to provide geriatric healthcare in this system. So Ministry of Ayush is also closely working with the World Health Organization, and our research officers are actively involved when we are finalizing the documents. The WHO has published benchmarks for training in Unani medicine to assist member states and countries if they want to do some training program in this system. And if they want to establish practice in Unani medicine, then WHO has also published benchmarks for practice in Unani medicine. We also have benchmarks for international Unani terminology, and where the definitions of these Unani terms have been standardized and published. And Unani mobility codes, along with other Ayush system, have been included in ICD-11 ISU Traditional Medicine 2 chapter. And WHO representation in conferences, like our officers go there in the meeting and they also come and participate in our conferences. So as you can see, this was a watershed moment when Honorable PM has inaugurated WHO Global Center for Traditional Medicine at Jamnagar. And these are the snapshot of the documents which are freely downloadable from WHO websites in Unani medicine. So we sign memorandum of understanding with premium institutes for fostering collaboration with partners, whether these are CSIR institutes like CCMB Hyderabad, NIPER Hyderabad, ICMR institutes, and some reputed universities. And now we are having an active dialogue with Punjab University also, and we are hopeful that we'll be able to take it to next level. So internationally, we have signed MOU with Iran, Tajikistan, Bangladesh. So we do sign institute MOU, and we also establish Unani chair in any university or organization when we receive requests from these international bodies. So after all the formalities and political clearance, we sign these MOUs. So we have been granted 19 patents, and few patents applications are under process. So like, because these are based on traditional knowledge, we have to take approval from National Biodiversity Authority also. So our two premium institute, one in Hyderabad and one in Srinagar, are actively involved not only in research, but have ventured in education also. And they're offering PG programs in medicine and pharmacology. And now, very soon, we'll be starting PhD programs also. So, pharmacovigilance initiative taken by efforts done by Ministry of Ayush, and we have a dedicated National Pharmacovigilance Center, and CCRUM along with its peripheral institutes are actively contributing on this initiative. So now Ayush sector is included in insurance coverage also for all this system. We have assisted in developing insurance SDGs guidelines for insurance sector also. So for e-Aushadhi portal, where the product approvals of Ayush are given, and for medicinal plants, we have a dedicated National Medicinal Plant Board, which is a statutory body under Ministry of Ayush, which is involved in conservation and sustainable use of medicinal plants. So from digital angle, we have developed 5 applications. This is for the use of general public, Unani professionals or Ayush professionals. One is you can know your temperament by clicking on this link. You'll come to know what is your temperament and you'll get a advice accordingly. I'll request all of you to go through this link and assess your temperament. Then we have developed an app on common remedies in Unani medicine. This is also a click away. This is for general public, where you can see the items which you use in your kitchen or generally freely available, how you can use them as common remedies to treat some common ailments. Then there's an app on single Unani drugs listing their uses, Unani formulations, and Unani treatment guidelines. So this is one of the strength area of this system. We called it as regimenal therapy. I have listed some example. Our peripheral institutes are engaged in running dedicated OPDs on regimenal therapy, where these procedures are given: cupping therapy, venesection, leech therapy, massage therapy, steam bath, diaphoresis. These pictures are from our peripheral institutes only, mainly from Chennai, Hyderabad, and Srinagar. So, dietotherapy, you might have heard about Ayush Ahar. We have ventured into Unani Ahar, where we have launched preparations like Gulkand, Halwa Ghee Kawar, Harira, Murabba Amla, and Unani Kahwa, which has got very good feedback. And these are displayed during various Arogyas and trade fairs. Now also in India International Trade Fair in Pragati Maidan, all these items are displayed and we get a good feedback. Then in the last Unani Day, which we celebrate on 11th February, we have launched this easy to use Talvina instant dalia, especially for elderly. Talvina cookies, main ingredient is barley in this, and Talvina flakes in two flavors, lychee and cardamom and chocolate flavor, so that to lure the children that they can have it a healthy snack in the morning. So this kind of support and patronage we get. In the last Unani Day, Honorable President of India was there to inaugurate our event, where we created a history when Madam has come, and it was a great encouragement for all of us. So now coming to integrative medicine and key to mainstreaming, we all know that it is a buzzword, and it has been defined as interdisciplinary and evidence-based approach to health and well-being by using a combination of biomedical and traditional complementary medical knowledge. We have a dedicated national health policy which champions the concept of integrative medicine by advocating the mainstreaming of Ayush. So we have got the policy supports for integrating these services into national health programs. So here, if you'll see, we have these kind of mechanism when we are talking about integration. It is physical integration, where the facilities health services delivery network of the country. Is functional integration for achieving national health goals. Education integration by inclusion of modern medicine components in Unani course curricula. Clinical practice integration. So we have dedicated centers in tertiary care allopathic hospital. Research integration, where interdisciplinary and collaborative research where integrative protocols is undertaken, and then standard setting integration for quality assurance in products by using modern technical tools. So this is one example where we had adopted one district for carrying out this national program for prevention and control of cancer, diabetes, cardiovascular diseases, and stroke, and where health promotion and patient management services was carried out and given along with the training in yoga. Here you can see we have a dedicated Unani medical centers at Dr. Ramanoloya Hospital, Deen Dayal Upadhyaya, Safdarjung Hospital. These centers are managed by council, and the patients are referred from allopathic side to us and from our side to allopathic OPDs also. This is also one example of integration in clinical practice. In collaborative research, I just mentioned we invite proposal, and then I'll just go through this. There's a proper mechanism where like we get proposal from these reputed institutes. So now when we are talking of integrative research or integration in mainstream healthcare, so we really felt, do we need addendum to already existing ethical guidelines or the regulatory provisions? So there was brainstorming sessions, and then it was felt as integrative medicine involves a multimodal approach where Ayush systems are integrated alongside modern conventional medicine to enhance patient care and improve health outcomes. So it was felt that ethical and regulatory clarity is essential to ensure the credibility, safety, and efficacy to integrative approaches. So ICMR along with Ayush took this initiative, and this addendum was drafted, which aim was to guide researchers, institutions, and ethics committee and regulatory bodies involved in integrative medicine research. So this is also freely downloadable. It is an addition to the already existing 2017 guidelines, specifically addressing the when you are conducting research in Ayush system, traditional medicine in India, then you have to follow these guidelines. So what is it basically saying? So when an ethic committee is considering this kind of integrative research, two Ayush subject matter experts with at least one being external to the institution, ensuring well-rounded and informed deliberation should be there. And they also tweak the informed consent standards. And all these should align with the regulatory national regulatory provisions. So now when you are working on a collaborative project with Ayush system and you're looking for Ayush related invention, so it was felt that sometimes these Ayush related inventions, they do not get patents and the patents are rejected. So to assess the scientist, these guidelines have been launched, which you can go through, and it uh, very meticulously list and explain 6 guiding principles for assessing patent applications related to Ayush interventions. So, where if you're making claim for extracts, alkaloids, or isolated active ingredients of plants that are naturally present and known in prior art, it cannot be considered novel or inventive. However, processes for obtaining such extracts or alloys may be patentable. Similarly, there are combinations of known ingredients, or if an ingredient is already known for treating a disease. So I'll request all of you to just download these guidelines and you'll come to know what is patentable and what is not. Same, so for these, for they have listed for invention related to equipment or devices also. So basically, you have to fill the criteria for novelty, inventive step, and industrial applicability. But there's a very fine line when you're talking about traditional knowledge or prior art, which is already listed in our classical text. I see the young crowd now gathering after lunch. I welcome you all. So now we have heard a lot about AI also, artificial intelligence. So these are being strengthened now by advanced technologies to provide cutting edge technologies to deliver more safe, personalized, effective, and accessible care. For this, again, WHO prepared a technical brief on mapping the application of artificial intelligence in traditional medicine. So this was launched under the global initiative, and it offers a roadmap harnessing this potential responsibility while safeguarding cultural heritage and data sovereignty. This is the technical brief which can be downloaded. It gives an insight into the rapidly evolving AI for health and its landscape, how it might be utilized in TM, or what are the ethical issues which might pop up. This is the scope of AI and traditional medicine, where we talk about data analysis and pattern recognition. AI can help us when we are talking about misage analysis or temperament analysis. AI can help us. It can also help in drug discovery and herb analysis, preservation of our classical heritage, and assist in telemedicine accessibility also. So here I just want to say that the key takeaway is that these systems offer safe, natural, and holistic strategies. And by addressing both physiological and psychological dimensions, it can be a sustainable model for promoting health and well being. And research in integrative medicine can further provide evidence based data for health and well being. And ethical and regulatory clarity is essential to ensure the credibility as I just mentioned, an addendum is in place, which is freely downloadable. And traditional health logic it's a dynamic process. Like you can add to this knowledge. This can give you positive leads to address many health challenges, and those leads can be added to these knowledge because these are processes dynamic in nature. So these systems are well established in India and further undergoing state of the art research, resulting in new products and processes. So these intend to provide clarity to the filing and processing of patent application, as I just mentioned, because we get many queries that we were doing this research, but when we had gone to apply for patent, it was told that it is prior art. So those guidelines are available. Please go through that, and that will be very helpful. Thank you so much. This was just to set the tone, what Ayush system is and what is our strength area. Now my colleagues from Hyderabad and headquarter, they will highlight how we can integrate this system. Thanks a lot. Thanks to those claps also, which I'm getting from this crowd. Thanks.
Thank you, Dr. Ghazala. I hope, as you already mentioned, that this sets the tone. Or maybe for many of you, Unani system of medicine, the word and the various things that were highlighted in the presentation are very new. But just to sum up in a line, that the Central Council for Research in Unani Medicine, is working towards integration, and that integration comes with the generation of evidence-based data. Evidence-based data on a knowledge which is ages old, and the wisdom which we already have in India through it is mentioned in our classical texts. So all that knowledge, and on the basis of that classical knowledge, patients are being treated since the time the knowledge exists. So just bridging the gap between the say mechanistic or we should say that the mechanistic approach or the mechanism of action needs to be highlighted on. We already know that the drugs work, and in India, especially in Unani, Ayurveda, and the other Ayush systems, they have a strong base. So we just need to bridge that, make that connection on how it. So with this, I think with the first lecture, uh, we gave you an introduction on what we are doing, and as a council, what prospects are there for further research. And second, coming up with this, yeah, this we have a little change in the schedule, as our next speaker, Dr. Ritu Karvasra, scientist from CCRM, New Delhi. She has a flight back. So she will be giving her talk first, followed by the other two. She will.
Just give a quick introduction of Dr. Ritu. She's a research officer in clinical pharmacology at Central Council for Research in Unani Medicine with a PhD in pharmacology. She brings over a decade of clinical research experience, specializing in pharmacological, molecular, and analytical methodologies. Through her role at CCRM, Dr. Karvasra contributes to the scientific evaluation of Unani medicines, particularly focusing on drug safety, pharmacokinetics, and therapeutic efficacy. So I welcome Ritu. Please go ahead.
Thank you, Dr. Javed, for such an wonderful talk. Now I request session chair to present a token of gratitude. Please.
Respected chairperson, distinguished pharmacologists, researchers, faculty, and dear colleagues, very good afternoon to all of you. So, first of all, I would like to thank my Director General, sir, for providing me this opportunity, and to IPSCON 2025 to providing me this opportunity to deliver a talk. So I would like to explain today my experimental work on the topic treatment with pomegranate that attenuates tacrolimus induced nephrotoxicity via the mechanism is the suppression of oxidative stress apoptosis in Wistar rats. This is the experimental study. So, starting with the background of tacrolimus, as we all know that tacrolimus is a widely used immunosuppressant drug. So, here it is on right hand side you can see the chemical structure of tacrolimus. This moiety, this tacrolimus drug is being uh, produced from this bacteria, Streptomyces succubensis, from the soil samples which we derived from Japan in the year 1984. So this moiety produced from the fermentation of this bacteria. So it's a macrolide immunosuppressant, just like next generation of cyclosporins. It is a widely used calcineurin inhibitor and widely used in organ transplantation, in solid organ transplantation. It is indicated for prophylaxis of organ rejection in patient receiving allogenic liver, kidney, heart transplant, and nowadays for composite tissue transplants also we are using tacrolimus, both in the form of oral, IV, and even topical formulation of tacrolimus are also there, which we used in psoriasis treatment. So it is concomitantly used with the corticosteroids in kidney and heart transplants. It is used in conjunction with azathioprine or mycophenolate mofetil. So here's the first of all, I would like to explain the pharmacokinetics of tacrolimus, because before proceeding with the tacrolimus induced nephrotoxicity, we have a brief introduction how this drug will work in our body. So it has a large variable pharmacokinetics. If we orally administer this drug, then the bioavailability varies from 5 to 93%. Oral doses of tacrolimus should be 3 to 5 times higher than the intravenous, because it has a high bioavailability differences due to differences in CYP3A4 expression, drug-drug interaction, drug-food interaction, and certain other factors are also involved. So in most of the patient, it is absorbed rapidly with peak plasma blood concentration that would be observed in 0.5 to 1 hour. However, we still see a lag time of 0 to 2 hour in case of transplant patient, liver transplant patients. So these are the absorption characteristics of tacrolimus drug. In GIT, this tacrolimus absorption significantly varies in GIT, as we can as we had earlier seen that it has high oral variability, oral bioavailability differences in their variation in uh, that. So careful monitoring of this drug, therapeutic drug monitoring is required in case of tacrolimus pharmacotherapies. And second, food interaction. Certain food intakes are also interact with this tacrolimus drug and cause interaction study, because it increases the expression of CYP3A4 enzyme, that is metabolizing enzymes. So this is the biodistribution of tacrolimus. Tacrolimus significantly accumulated in liver, kidney, intestinal tissues following the oral administration, and higher doses lead to increased bioavailability, but higher doses are to be given with high dose adjustment, because the major limiting side effect is nephrotoxicity. And these drugs show interaction studies also too. So drug interaction and patient specific factors also vary the distribution of tacrolimus. So, in metabolism, it is metabolized primarily by CYP3A4 enzymes. The average half life is 12 hours in stable healthy patients. Excretion is mostly via bile with minimum renal clearance involved. And for interaction, you have to monitor the patient. It causes drug-drug interaction as well as drug-herb interaction, and those which are CYP3A4 inducers and inhibitor, you have to adjust the dosage also when you are concomitantly administered with these inducers or inhibitors. So this slide shows the global perspectives on tacrolimus use. See, tacrolimus is widely used in transplant patient because of its high potency, and it is widely used throughout the world. But it has two major challenges. First major challenges, which many transplant registries in USA, Europe, and Japan, Asia, they showed that it has 30 to 50% of patients they had nephrotoxicity as their dose-dependent nephrotoxicity. The tacrolimus drug showed in their patient data, and second is variation in kinetics, pharmacokinetics of this drug. So this has two challenges with tacrolimus drug. So in 1, 2, 3, 4, 5, I have highlighted certain different regions, and they have observed some challenges with the tacrolimus. In case of one, the higher tacrolimus concentration observed in tissue samples, a significant variation in pharmacokinetics among the individuals of ethnic origin. In Asia and in Europe, they have different CYP isoenzymes, and that would differ the pharmacokinetics of this tacrolimus drug in different regions. So notable adverse effect, that is nephrotoxicity, is the most notable adverse effect. So, first of all, I would like to explain the mechanism of tacrolimus drug. It bind to the intracellular receptor and significantly bind to calcineurin. We can call tacrolimus as calcineurin inhibitor also, because it inhibit this calcineurin, and this further inhibit the NFAT pathway. You had studied this in your pharmacology textbooks. So this will decreases the IL-2 interleukin 2 expression, and further it suppresses the T lymphocyte activation. So likewise it causes its immunosuppressive effect. So this is the mechanism how the tacrolimus drug it in the cells, how it got uh, how it works. So it decreases the activation of T lymphocyte cells. How it decreases? By binding to these FK506 binding proteins, that is FKBP. Tacrolimus binds to this FKBP, and subsequent inhibition of NFAT, nuclear factor of activated T cell target genes, and thereby contribute to immunosuppression. So, the major dose limiting toxicity is tacrolimus nephrotoxicity. But I already told that certain uh, transplant registries show that 30 to 50% of patients have nephrotoxicity due to this drug. So, both type of nephrotoxicity we have observed, acute as well as chronic, but because it shows dose dependent, so there are more chances of chronic nephrotoxicity. So how it causes? It causes the tubular atrophy, interstitial fibrosis, arterial helionesis, and the mechanism is due to increase in ROS, mitochondrial dysfunction, ER stress, and activation of apoptotic proteins. Caspase 3 VAX are pro-apoptotic factor, and BCL2 is anti-apoptotic factors. So it causes nephrotoxicity due to these 3 or 4 possible mechanisms. So this is the impact of tacrolimus on PCT cell. In our neuron, we have PCT, DCT, and convoluted tubule, as we all know. So on proximal tubule cell, this tacrolimus causes excessive loss of sodium ions due to these mechanisms, due to shortage of time. So I'll straightforward come to my experimental work. So first of all, the research question is, actually the tacrolimus cause severe nephrotoxicity. So we need some protective agents that will reduce its nephrotoxicity and that will not interact with tacrolimus drug. So first is treatment of, so my research question is treatment with pomegranate, that is herbal therapy, which have possible antioxidant, anti-inflammatory, and an anti-apoptotic role. It attenuates the tacrolimus induced nephrotoxicity via suppression of oxidative stress and apoptosis. So the primary objective is to evaluate the protective effect in this tacrolimus induced nephrotoxicity model, that is of 4 weeks model, and secondary objective is to evaluate the assessment of renal function, serum creatinine, BUN levels, oxidative stress markers, histopathological analysis uh, to evident the change in pathological changes in kidney tissues, and the expression of apoptotic markers. So this is the gap that as we all know, that we do not have any specific antidote to counteract this tacrolimus induced nephrotoxicity. We have two things, that either we can reduce the dose, in that case we have rejection risk, or either we can supplement it with calcium channel blocker, but that have partial benefit. So by these two is the management process. So we need a safe, natural, antioxidant rich adjuvants that do not interact with this drug and possibly provide the nephroprotective action. So I have selected this Punica granatum. As we all know, in Unani it is called as Gulnar. And for this study, we have used the dried pomegranate rind extracts, because the rind extract is rich in ellagic, punicalgin, and anthocyanin, and these have powerful antioxidant, anti-inflammatory, anti-apoptotic in multiple models. They have documented this thing, and rinds have more quantity of these polyphenols. So we have selected this extract. So study design is male with star rat we have chosen. The duration is 4 weeks, 28 days. Group is N is equals to 6, and we have 4 groups. First group is our normal control. Second is we use tacrolimus in a dose 3 mg per kg by oral route. And then we have 3 subsequent groups with pomegranate in different doses, that is 50, 100, and 200 mg per kg. And this dose is calculated after conducting the toxicity studies. And the per se group, pomegranate extract alone group. So the parameter we have studied is renal function, oxidative stress, histology, and apoptosis. So these three are the selected doses for punica granatum. This is the IAEC number, and prior to experiment, the animals are fully acclimatized according to humidity and temperature condition. So this is my nephrotoxicity model. We induce the nephrotoxicity of tacrolimus in Vistar rat on day 0. We administered our test drug, because it's a pre-treatment, it's a protective effect. So we administered the test drug subsequently for 28 days, and on after 1 hour on day 1, tacrolimus was administered per oral, except normal control group. And on 28th day, we assess all the parameters, the kidney function test, the histopathological examination by sacrificing, and immunohistochemical, and all the apoptotic markers. So these are the results of my study. That you can see that the first table described the serum creatinine and BUN level. In second serial number 2 in the table, the tacrolimus 3 mg per kg had significantly increased serum creatinine. The normal value of serum creatinine is 0.9, but tacrolimus increased the creatinine value to 1.5 and BUN value to 82.83. But with in case of PG uh, dose, this value got decreased, and the most potent dose is PG 200 mg per kg. Likewise, in second table, we had shown the antioxidant parameters: glutathione, SOD, MDAT bars. This is the histopathological and immunohistochemical analysis of punica granatum. As you can see, the figure B, it shows some tubular atrophy in these sections of PCT. So it shows tubular atrophy, which was decreased in section F, and section E, that is punica granatum 200 mg per kg. Likewise, this is the immunohistochemical analysis of caspase 3, BCL2, and BAX proteins. It one thing in this slide is that it increases the expression of BCL2, that is our anti-apoptotic protein, and the pro-apoptotic protein, that is caspase 3 and BAX, it decreases the expression of these, as it is clearly evident from the immunohistochemical slides. So I had also conducted the toxicity study, the oral toxicity study, acute toxicity study, and provided that this is the toxicity study of our test drug, punica granatum. So we observed all the animals for 10 days. And this is the experimental model for 28-day oral toxicity study, that is subacute model. And both these experimental procedures were conducted as per OECD guidelines, OECD 425 for acute and OECD 407 for subacute toxicity studies. So these are the observation that in our Punica granatum extract, none of the animal died uh, for days when we observe the mice for 10 days. And this is the subacute toxicity studies. And these are the biochemical and hematological parameters which are in normal range. So this is the pathological analysis of Punica granatum in subacute study. Okay. So this is the conclusion that we had evaluated the Punica granatum rind hydroalcoholic extract. We have evaluated the biochemical parameters, serum creatinine, blood urea nitrogen, and TNF alpha level. These got decreased when we administered the group uh, with the pre-treatment of Punica granatum. The antioxidant parameters, MDA level decrease and GSH and SOD level increase. Histopathological, the PG supplementation showed normal architecture of kidney and no signs of tubular damage. And in immunohistochemical analysis, the Punica granatum attenuated the increased level of various biomarkers. So, Punica granatum demonstrate nephroprotection in tacrolimus-induced nephrotoxicity model, and it is safe in acute as well as subacute study. We observed no biochemical hematological changes as well as no pathological changes were observed in any of the section of liver, heart, kidney, testis, stomach, spleen, ovaries, and brain of male and female rat as we compared them with the normal rats. So thank you. If you have any questions, I'm happy to answer.
We will be having questions. Okay, okay. Thank you, Dr. Vitu, for the comprehensive presentation. Do we have any questions or suggestions or any observation? Because she'll be leaving, she has to catch a flight. Okay. Thank you, Dr. Ritu, for such a enlightening and influential talk. Now I request session chairs to kindly facilitate. Ma'am. Next, we have Dr. Uh, Dr. Ghulam Hussain is a pharmacologist. He's a pharmacologist with 14 years of experience in pharmacology and toxicological evaluation of traditional and herbal medicine. He's a scientist, research officer pharmacology, scientist 3 at the National Research Institute of Unani Medicine for Skin Disorders at Hyderabad, which is an institute under the CCRU, Ministry of Ayush. He has previously served as a lecturer in pharmacology and toxicology at NIPER Raebareli and as a chemical safety and regulatory professional and evaluator Gurugram. He earned his MPharm and PhD in pharmacology from Banaras Hindu University after seeking AIR 95 in GATE and university first rank in BPharm. He brings as you can see, he brings himself with him an overall experience in research, industry, and academics. And today he's here to present his talk on pharmacological evaluation of traditional Unani medicine, challenges and way forward.
Thank you, madam, for introduction. Respected chairs, dignitaries of the dais, researchers, and dear fellow pharmacologists, Today I will discuss about pharmacological evaluation of traditional Unani medicine in particular. What are the challenges and way forward? First of all, I would like to thank my Director General, Dr. N. Zahir Ahmed Saab, who has allowed me to participate and deliver this presentation over here, and Professor Anil sir for giving me opportunity to be part of this IPS conference. So, as the tone is already set by our AD, Dr. Ghazala Javed Madam, that traditional medicines being a part of a culture all around the world, WHO has notified that almost all countries have one or other form of traditional medicine in place in their healthcare system, which are basically holistic approaches, and traditional medicine emphasizes nature-based remedies and holistic personalized approaches to restore balance of mind, body, and environment. So, as opposite to conventional allopathic medicine, uh, all traditional medicine focuses on a balance between mind, body, and environment to maintain health. It is believed that herbal drugs are safer than synthetic drugs, but there is a rider. People generally think that they are being derived from natural origin, natural sources, they are safe. But this safety can only be ascertained while we systematically evaluate these traditional medicine and practices being used throughout the world. So we have to adapt scientifically valid methodology, and we have to show the world that these practices or these medicine, be it a herbal or any practice just like yoga or acupuncture or some massage therapy or panchkarma therapy being used in Ayurveda, these all encompasses some uh, traditional cultural roots, but we have to prove them scientifically, clinically, as well as preclinically that these systems work. So this I will skip because Madam has already elaborated a lot on the traditional medicines recognized by Government of India. I particularly discuss related to traditional Unani medicine, but same concept can be applied to Ayurveda and other Chinese traditional medicine as well. So what now I will be discussing some basic points which we as a pharmacologist, as a bench worker, we uh, are exposed to. So these particular topics I'm going to cover in this presentation, which are related to test formulation, their dosage regimen, drug administration issues, pharmacokinetic and bioanalytical challenges, ethics, particularly very important while we are designing clinical trials, and how to design trials of traditional medicine which are having multifaceted intervention and drug interaction aspects. So coming to test formulations. So when we consider test formulation in modern medicine, usually oral solid doses form, which are tablet or capsule, are considered best as of now because of ease of administration, long shelf life, and a high patient compliance. But we are having so many formulations in traditional medicines which are now being upgraded to equivalent to tablet and capsule forms. There are some unstandardized, we can say, dosage forms which are in the form of semi-solid dosage form, some liquids, which are some powders like churnas in Ayurveda or safuf in our Unani system of medicine, which are bulky in nature. So test formulation has to be standardized. There are batch to batch variation as well, because many of the traditional medicine, if we talk about pharmacotherapy point of view, they are herbal products or derived from herbal ingredients. So when we collect from herbal or mineral origin ingredients, there might be source variation, there might be seasonal variation, there might be a variation in the cultivar or species of the particular herb or uh, animal origin drug. So that may lead to batch variation. And our practices of processing that raw material are also not standardized earlier. But now, since the advent of good manufacturing practices and adoption of these manufacturing practices by Unani pharmaceutical industry or Ayush industry as a whole, these practices are being standardized and there are minimal batch to batch variation in these formulation. Similarly, quality control, as I discussed, is a big issue for the raw material and finished product as well. So our Unani Pharmacopoeia of India or Ayurvedic Pharmacopoeia of India or Siddha Pharmacopoeia or Homeopathic Pharmacopoeia, now they have given stringent quality control measures in the form of monograph, which we have to comply. The manufacturer has to comply, and they have to do complete stability shelf life studies, and they have to show that under this given circumstances in these storage condition that product should be stable enough, and patients safety cannot be compromised. Patient compliance is a big issue, while dosage form is not in the standardized form, as I said, oral solid dosage form. Sometimes we ask patient, still we have some formulation which we ask patient to soak in the water and take as a form of decoction after boiling or cold infusion, just after straining the raw herbal ingredients. But these formulation have poor patient compliance as well as lack of uh, equality all the time, because once we ask a patient that you have to dissolve this pouch in one glass of water and boil for 2 minutes, somebody will boil for 2 minutes, someone will boil for 5 minutes and heat. So these things has to be standardized. So instead of these, nowadays we are coming up with the SOPs to prepare the particular extract in the form of decoction or infusion. So that is the way forward, that instead of asking patients to do this process, we have to give patient a better dosage form which is consistent in nature. Coming to dosage or dose, so dose regimen is the biggest issue in the traditional medicine, because an ancient text, be it any traditional medicine, it is described vividly by varying number of doses, dosage regimen. Somewhere you will find that 1 gram daily it is written. Sometimes you will find some 1 gram twice a day. Even in older texts you will not find grams, but instead you will find older metric system or empirical weighing measures. So that is the big issue. So it has to be standardized, and Pharmacopoeia Commission of Indian Medicine and Homeopathy has taken this issue forward, and they have converted whatever written in the classical text into metric system, and now they are uh, uh, standardize the dose. So ambiguity should be avoided, and whenever there is a doubt, you have to check the original classical text to see the description, detailed description. But as far as a pharmacologist is concerned, large doses poses always challenge for uh, difficult for administration. So we have to see how we have to administer large doses to animals. Sometimes we have doses as good as 40 ml, 60 ml per kg for human. So while we are converting those doses to animal equivalent based on body surface area conversion, it is coming very high dose which we cannot administer to rodent. So we have to see alternate approaches, whether we have to concentrate those formulation or we have to make some extract sort of thing, so that a little bit m- uh, uh, knowledge you have to apply to standardize the thing. Then, as I discussed, seasonal and geographical variation are always there. Constituents in the plant vary depending upon their geological geographical condition. One plant grown in Himalayas will having a different quantity of the constituent. If we take curcumin content which from haldi, which is grown in the southern part of the India, it will be very high compared to northern growth haldi. So that has to be taken care of. That's why now Pharmacopoeia and all agencies are emphasizing that you have to give passport data as well. Passport data means which soil condition, which agricultural practices has been adopted while cultivating these medicinal plants. That has to be standardized. And those is big issue. Pharmacotherapy is fine, but when it comes to procedure based therapies, like I said, acupuncture or cupping therapy or leaching therapy, so then those has to be decided. So what we can do, we have to fix the frequency of applying these therapy, for how long. So for that task, our council has taken a very good step to publish standard treatment guidelines for various regimenal therapy, and cupping and leaching. Already our guidelines are available, as madam has discussed. These are freely available at ccrum.res.in, so everybody can access them, especially for medical practitioner. Drug administration, already discussed that it is a big issue, since majority of drugs are raw ingredients, just processed somewhat like grinding and sieving, and then make into the form of tablet or capsule, or just as such as a powder. So they are it is quite obvious that plant part are not directly water soluble, so you will not get a fine solution like normal saline to be administered via intraperitoneal or oral route. So what we get is mostly is a suspension, which we have to administer through oral gavage to the rodents, or we have to make a thick paste, and then we have to apply a particular solvent, usually water, to make a to add a suspending agent, and then we have to administer into the rats. But sometime what happens with, especially with semi-solid dosage form, like we can see on downside, it is difficult to get syringeability, because if we are administering in the mouse, so hardly we can go up to 18 or 20 gauge uh, gavage. So sometimes they are not we are not able to syringe them, then we have to see alternate option, whether we have to go for extraction, or we have to even milling sort of thing. Then why, how to do cell based experiment? Because for testing cytotoxicity or some cell based experiment, and we are moving from apart from animal testing, we have to see the alternative testing procedures. So we need to treat cell lines uh, with our formulation. So as such, formulation cannot be treated, but we have to prepare different type of extract, and we have to use ethanol, methanol, or hydroalcoholic extract sort of thing. Then we can, fair enough, we can do the treatment with the cell culture experiment as well. So these are the challenges. Now coming to the pharmacokinetic and bioanalytical challenges. So as you can see that even one formulation can contain 5, 10 herbal ingredients, sometime herbal ingredients mixed with some mineral, and sometime complex of both herbal and mineral. So that time, in one plant there might be some 8, 10 active ingredient. There might be thousands of molecule, but active ingredients, let us speak. We have to measure those in kinetic experiment. We have to measure some drug. Suppose we are doing kinetic of atorvastatin, we can measure atorvastatin using LCMS or something. But in plants, what you will measure? At least representative biomarker or analytical marker, we can say, it may be responsible for biological effect. That is fair enough. If at all it is not responsible for biological product, but it should reflect in the blood stream, then only we can say that it is bioavailable or not. So it is the most challenging aspect of the herbal complexes or herbal formulations, that we have to develop method for their bioanalytical analysis. Then we have to validate method. Due to advent of new technologies like HRMS or metabolomics sort of approaches, we can easily, not easily, but at least we can characterize some marker, analytical marker, to have some kinetic data of herbal formulation. So people are studying these kinetic data, and now so many work has been published from our Unani Council as well. Now coming to some clinical aspect, what we challenge, as madam has already discussed some clinical aspects, so I will quickly go through. First and foremost is we have to take the consent of participant. It should be informed consent. Then we have to see the risk benefit analysis of our traditional formulation, whether our traditional formulation has to be given for that particular condition or not, because there are so many condition for which we cannot give our traditional medicine, being these are some infective disorder, and they have a notified disorder basically, and there is a standard treatment guideline issued by the health authorities. So every pathological condition you cannot intervene. Then how to design a trial and how to take control arm, because when we talk about clinical studies, always people what first come into the mind is randomized control clinical trial. So that is the best in the power and validity. With traditional medicine, we cannot always design randomized control trial because of several reasons. Because we cannot match the placebo, we cannot have always a control drug from allopathic side, because we have to again have one investigator from the modern medicine. So we have to on case basis, we have to decide what type of the trial will be feasible for that particular formulation or that particular therapy. Because for therapy as well, non pharmacological intervention as well, we have to prove the clinical efficacy. And as already discussed by madam, that ICMR has come with the addendum to national ethical guideline for clinical trial involving human participant, which was published in 2017. So addendum came in March 2025, and ICMR reiterate that whenever whenever evaluating any trial protocol, there should be at least two expert, one from traditional medicine, preferably outside of the institute, and one from inside of the institute. Rest of the ethical committee member will always be there. And now, since the notification of new drug and clinical trial rules, you all are aware, 2019, our ethics committees which are doing clinical trial on traditional medicine, these committees are also being accredited by Department of Health Research, Ministry of Health, Government of India. So now this is a big step to increase the reliability and ethics aspect in the clinical study of traditional medicine. And one more important is ASU GCP. Uh, ASU stand for Ayurveda, Siddha and Unani drugs, and Government of India Ministry, that type Department of Ayush under Ministry of Health and Family Welfare in 2013. They have in 2013 given good clinical practices guideline. So you may access them through Ministry of Ayush website, and that has beautifully given what ethical aspect you have to take care. So here, when we are coming to trial design, basically, so when we are designing the trial, we have to see some aspect. Not only we have to go directly by modern medicine aspect, like diagnostic criteria, inclusion and exclusion criteria. We have to see our system criteria, classification of diseases criteria. Just like in Unani, we have four type of temperament of the people. We can whole population can be divided four subtypes. So they have different phenotypic characteristic, they have different genotypic characteristic, so obviously they will respond to treatment differently. So they will not it is not always true that as per our traditional uh, concept, that all people will not respond therapy equally. Similarly, in Ayurveda, we have three types of prakritis, like Vata, Pitta and Kapha. So it is considered that we can divide all population into three subtypes or three subgenomic phenotypic as well as genotypic characteristic. So that aspect has to be taken care when outcomes we are assigning, we are making protocol. So outcomes, usually what we do, suppose a hypertension trial, so we will see systolic BP should go down this much, and diastolic BP should go down this much. So that will be our assessment criteria. But our traditional approach should also be there, that how to we observe pulses, nubs में कितना changes है, so that concept should also be there. And then actual integration is possible. If we are recruiting patient based on modern criteria, evaluating them based on the modern criteria, then our actual approach will lose somewhere. So while designing the trial protocol, all these aspects has to be taken care. And as I said, that especially for non-pharmacological intervention like cupping therapy or other dietotherapy, we have to take utmost care that how to design trial. Obviously, in these cases, it will not be randomized control trial, but maybe an observational study or some experimental study without randomization or without appropriate control. Then also we have to gather the evidence for to prove these efficacy of these traditional regimes. I'll not go to detail this. All you know that drug interaction, there might be chances of interaction of drug from herb as well as food of herb, because ultimately these plant material or minerals, they contain some phytochemicals which have effect on pharmacokinetic interaction sort of thing, and they may have some pharmacodynamic interaction sort of thing, and they can interact with the food as well as the drug which we are simultaneously taking. Because what happened, people will come up with our OPDs, they are already diabetic, so obviously they are taking some sort of metformin, and if they are hypertensive they might be taking one modern medicine, and they don't tell to physicians actually that I am on some therapy, and they will take some our medicine as well. So that time it is a big risk to the patient. If we have any pharmacokinetic interaction data with those drug, that will be better. So initiation has been done by Ayurveda and our council to have data of pharmacokinetic as well as pharmacodynamic interaction of our commonly used formulation with, at least for commonly used medicine like diabetic for metformin, say for hypertensive drug, or some other long-term chronic disorder. So this aspect has to be considered while trialing design. So way forward is there is a need to implement stringent quality control measure and adoption of good agricultural practices, good manufacturing practices, and good clinical practices specified by ASU as well as CDSCO. There is a need to adopt flexible clinical trial methodologies to better mimic the holistic nature of traditional medicine while simultaneously ensuring the scientific rigor. Patient safety and well-being should be the utmost priority. Emerging technologies in various domains of drug development, including standardization, formulation development, and electronic data capture in clinical trial must be adopted. Half drug interaction studies must be conducted on commonly used traditional medicine, which are supposed to be co-administered with conventional drug. And there is a need of collaborative approach while designing clinical trial on traditional medicinal product involving experts from traditional and modern medicine. The development of standardized formulation with well-defined bioactive constituents followed by efficacy assessment through well-designed clinical trial is the need of time. So thank you very much for patient listening. I would like to once again acknowledge my Director General and my Director in charge, Dr. Yunus Munshi Sahab. And I'm thankful to Professor Anil Kumar and our entire organizing team of IPS Conference 2025 for providing me this opportunity. Thank you.
Thank you, Dr. Gulam, for comprehensively explaining what are the challenges which we face when we are planning for pharmacological evaluation of traditional Unani medicine. So there are many aspects and multifaceted approach. We have to take care of these nuances when we plan for preclinical or clinical research. We do have various guidelines and regulatory provisions in place which will help you in designing these trials. Thank you so much. We have some quick questions. We are running short of time. We are getting requests from organizers to wind up this session as soon as possible. Otherwise, he's staying back, Dr. Gulam over here. You can discuss with him over a cup of tea
Sure.
or we can take one question. Anyone? So, thank you so much.
Thank you, Dr. Gulam. I now request session chairs to kindly facilitate.
That I'll very quickly invite our colleague, Dr. Mohammad Uruj, who is a research officer in the Pharmacological Research Laboratory at National Research Institute of Unani Medicine for Skin Disorders in CCRUM. He has contributed to the pharmacological evaluation of traditional Unani formulations through both preclinical and in vivo studies, investigating anti-inflammatory, analgesic, antipyretic, anti-epileptic, and antidepressant activities. So he'll be detailing upon integration of traditional Unani medicine, challenges and prospects. So I invite Dr. Muhammad Uruj. Will request him to finish in 15-20 minutes.
Okay.
Thank you.
Thank you. Thank you, Dr. Ghazala. Respected chair, different scientists from different organizations, dear students, good afternoon to everyone. So, Dr. Ghazala has covered some points of my presentation, but I will try to give a deep insight of that points. And firstly, I would like to make a statement which is my personal opinion, and I strongly believe that traditional medicine is also a mainstream healthcare as equivalent to the modern medicine, because when WHO is saying that 80% of the global population is rely or depends upon the herbal medicine, and the data by the NSSO India is showing that 85 to 90% of Indian population lives in rural or semi-urban areas, where still the people used to visit the Hakims and Ayurvedacharya for the diagnosis and treatment. In that scenario, we cannot say traditional medicine as a secondary healthcare. It is also a mainstream healthcare, and it also contribute equally as a modern medicine to the nation health and reduce the disease burden in India. So the question is, why we need the integration of traditional medicine with the modern medicine? Yes, because it is as need as because it provides a personalized treatment with better efficacy, safety, tailored treatment which is designed based on the individual need, and lastly, it provides a cost-effective medicine to the patient. So these are the contents of the presentation, bridging two worlds. What are the benefit and strength of each approach? What are the challenges in the integration? What are the successful strategies for integration? Successful integration model in the future of integrative medicine, future directions. So traditional medicine is actually culturally based. We have a history of around 5,000 years back, or we can say it is from the stone ages. It passes through generations, and it relies on the knowledge of the Hakims and Ayurvedacharya. And we in this presentation we can see that 40% of the today's pharmaceutical products are derived from the natural products. Like for example, the aspirin, which we commonly use, is derived from the willow bark. Similarly, the Nobel Prize winning research artemisinin, which has been derived from the Artemisia annua, and the discovery of the smallpox vaccine, which is also based on the since ancient inoculation technique. Modern medicine, modern medicine actually grounded on a rigorous scientific preclinical and clinical research, and it emphasizes the use of pharmaceutical and surgery and advanced diagnostics for disease diagnosis and management. And the major revolution in the modern medicines comes into picture when there is an integration of artificial intelligence, machine learning, deep learning, new natural language processing, which brings out the discovery of the drug devices. And these are three AI software which recently approved by the US FDA in 2024. ARI score for determination of brain volumetry. Brain C is for diagnosis, early diagnosis of the Alzheimer disease and dementia. And ICO brain area is recently approved by the US FDA for radio imaging diagnosis of beta amyloid plaques in the brain. This is the advantages of traditional medicine. It is quite accessible and affordable. We can see these herbal medicine in our surrounding areas easily. It can be found and affordable. It is a cost effective. Culturally, it is really a passes through generation. So there is a cultural connect between the people towards the use of the traditional medicine. The strength of modern medicine is that it is quite good for management of acute conditions, emergency conditions, and AI integration of AI in the healthcare sector provides uh, such a wonderful machines or devices like CGM, continuous glucose monitoring, where you can monitor your blood glucose in the blood on your phone 24 hours. Similarly, 24-hour Holter ECG monitoring. You can monitor your ECG on your phone. Activity of the pacemaker is available on your phone. Such devices is because of the integration of AI and machine learning and deep learning. So these points has been discussed by Dr. Gulam. So major problem is the raw material is the major problem in traditional medicine, because the raw material which is directly procured from the market for the preparation of these traditional medicine, and it is stored since long in the way how in the shops, and there are the chances of contamination, heavy metal toxicity, and pesticide contaminations, and sometimes there is also an adulterate these single ingredients present in the market. Second, standardization of drug and formulations due to inconsistency of raw material and process optimization. There is a variability in the formulation. There is always a batch to batch variability. We cannot say that two product of the same name having the same activity, because there is a difference in the content. Diagnostic criteria. The challenges of traditional medicine is that diagnostic criteria which we used for diagnosis based on the traditional literature is cannot be measured, like temperament, color of tongue. We use these diagnostic tool: color of tongue, color of urine, loss amount of appetite. So these are not measurable factors. Dose and dosage form, again the dose is very high and dosage form is a kind which cannot be used by the diabetic patients. Duration of treatment is inconsistent. In different literature is saying you have to use this medicine for 10 days, another literature is saying you have to use that medicine for 1 month. Lack of evidence. It is now the Ministry of Ayush and CCRUM is trying to generate this evidence for the claims of ancient Unani physician based on the scientific modern using the modern scientific tools. One challenge is that how to validate the factor of emotions and interaction of patients with the physician. This is also a holistic diagnostic criteria in traditional system of medicine which cannot be measured. And last one is the PK/PD interaction. We cannot use the two drugs from one is from modern medicine and one from traditional system of medicine. There may be the chances of interaction which we know now. So there is a need to study this kind of interaction where the peoples are using uh, two drugs from two different streams simultaneously. These are even we cannot say there are challenges in traditional medicine. Challenges are also in the modern medicine, which generally we don't discuss. And the major challenge is healthcare disparities and inequities. Disparity is actually the different health outcomes across the populations. Means the outcome of health is different due to social, economic, and geographical. So the recent report published by WHO is saying that in the developing nations, children below the age of 5 years are 13 times more likely to die as compared to the developed nation. Chronic disease burden and management. Here I would like to give a data which is recently published in 2025 that by 2030, 75% of the world global population, the death of the 75% of the world will be due to non-communicable disease, especially cardiovascular, diabetes, cancer, and chronic respiratory disease. Rising healthcare cost and affordability. It is one of the major challenge that modern medicines are quite it's not cheap actually. It's not accessible by the middle class or lower middle class. And healthcare workforce shortage and burnout. This again, all nations, especially the developing nation like India, Asian countries, Africa, there is a shortage of healthcare workers or paramedical staff. In India, we have one doctor at 830 830 peoples in the India. There is only one doctor. So there is a healthcare workforce shortage, and due to shortage of work, there is a workload on those healthcare givers, and there is a sense of dissatisfaction among them. So this is the burnout, and most and recognized challenge in modern medicine. So, what are the strategies? How can we integrate better in a better way? That establishing regulatory framework where the Ministry of Ayush is playing a good role. That we are come with a roadmap to ensure the availability of the quality controlled medicine in the market. Second, we are developing a licensing and certification program where these traditional healers, yani hakims, or whether it is Ayurvedic peoples. So licensing and certification programs, we are ensure the accountability of the traditional healers and the manufacturing units. So in these sections, the Ministry of Ayush and all the councils of the Ayush are working together to bring this quality medicine in the market. Second, in investing in research and development, it is also the Ayush Ministry is in the direction, in consultation with all council. Ministry of Ayush is giving instruction that we have to develop the evidence of the traditional claims which was given in the our literature. We are conducting a robust clinical trial, randomized blinding, and we are also conducting the preclinical studies to validate the mechanism of action of these traditional formulation. Education and training, this is also a good step where we are trying to integrate, or we can it's a suggestion that we can integrate this traditional knowledge in the curriculum of the graduates. Like the MBBS student, we can add the chapters of traditional systems in the curriculum of the MBBS student. Similarly, we can introduce the syllabus of MBBS student in the BMS students. So these are the successful integration model. We we know that China is far away in integration of traditional and Chinese medicine, and there is a association known as Hong Kong Association for Integration of Chinese Medicine, which was incorporated in 2001. You can see this is a team of integrated traditional Chinese and Western medicine working in the Western medicine of West China Hospital, which was founded in 1956. And you will shock that in China there are 705 TCM hospitals. There is shortage of time, so I would like quickly wrap up the this. So future direction is that we can ensure the availability of traditional medicine, or we can ensure the proper integration in a better way by encouraging the collaboration among researchers, healthcare professionals, policymakers, and communities is essential. And secondly, we can provide the sustainable healthcare by research, education, and regulatory framework. Thank you.
Thank you, Dr. Uruj, for highlighting the various aspects and prospects of of traditional medicine. Um, Now we can have but we are already beyond schedule. But one question, one or two, if there is, we can take right now. Else, Dr. Rouge is available. You can discuss with him on a tea break also. Thank you, Dr. Rouge.
Thank you, Dr. Mohammad Urus. And now I request towards presiding the present the session chair to present the moment of appreciation, the token of our gratitude. Now, I also request Dr. Javed to facilitate Dr. Nigat. Thank you, ma'am. Okay, ma'am. Thank you. Next to have slides on.
यहाँ पे कभी हो गए आज तो मैं लाओ तीनों के होंगे तो पहले चीज़ों का नहीं आता होगा मैं कौन तो सर आपको बट सब consider after start now. Clear now. तो कुछ भी करोगे तो तीन रही है, ये नंबर 2 है, ये नंबर 3 है, ठीक है? एक और डाल के फिर नंबर 1 2 3 कर दो, फिर ये तो ये नंबर 3 है। चलो ठीक है, कोई बात बैठना से ज्यादा नहीं, मैं बैठूंगा। अब ये बची ये बन ये पहन फिर ये रखिए, ये से सामने रखिए, बड़ी बात है। पीछे का सर सर
Which one is yours?
Çocuklar meeting. Çocuklar I hope that is small.
Please stand up.
First one. Peter was a little पीटर सर कहाँ पे है? पीटर सर को बुला दो। हाँ है। व्हाट्सएप व्हाट्सएप चलेगा? सीधे में चलेगी। ये बाद में डाल करने का कुछ फर्क आता है। मतलब कैसे? दोस्तों को पोस्ट करो। जब तक सर व्हाट्सएप पर अपडेट कर दो। सीधे ब्रांड वो बोलो। कौन सी सेमी का लगी और इस पे लाओ मेरे भी वाली पीटर का पैन
Good evening, everyone present here. Now, starting the last session of the first day of IPSCON 2025, for which we have Dr. M.N. Sharaf and Professor V.R. Sinha for the session of chair. I have the honor to welcome Dr. M.N. Sharaf and V.R. Sinha. Maybe Sir will be joined later. Before starting the session, I would like to introduce our chairperson, Dr. M.N. Sharaf. He is a distinguished pharmacology academic and administrator over 4 decades of exemplary contribution to pharmaceutical education, research, and institutional leadership. He has served in key academic position. He has also senior lecturership role as professor and associate dean at NIMS School of Pharmacy and dean principal at HK College of Pharmacy. Under his leadership, Bombay College of Pharmacy earned the distinction of Best Industry Linked Pharmacy Institution in India for 3 consecutive years, awarded by Ministry of Higher and Technical Education, Government of India. He has been honored with prestigious recognition including the APTI Principal of the Year, Pharmacology Teacher of Excellence Award IPS, and Padma Shri Amrit Modi Distinguished Researcher Award. Dr. Sharaf continues to serve the profession through scientific leadership, mentorship, and active contribution to the Indian Pharmacological Society and other professional bodies. Our next chair, Professor V.R. Sinha. He is a distinguished pharmaceutical scientist and research professor at UIPS Punjab University, Chandigarh. He is widely recognized for his pioneering work in novel drug delivery system, pharmaceutical technology, formulation development, and Sir has a reflecting significant global research impact. He has mentored numerous PhD scholars who serve in academia and in industry. His innovation include technology transfer formulation developed at UIPS, reflecting his strong linkage between research and translation. He has held major academic leadership position including chairperson UIPS and contributed to Punjab University academic ecosystem through curriculum development, research collaboration and institutional quality enhancement. We welcome you, sir, and we'll start the session.
Before we start, I request Dr. Rohit Goel to chair the session also along with Dr. Aman Ghosh. Thank you.
सर ये आगे का नीले पॉइंटर है हमारे पे ठीक है ये
अभी सर
I don't see that either. That's okay, but wait. And this is a pointer. So yeah, highlighter हमारे पास. Good. ये point you can change from here. Perfect.
Excuse me, sir. Excuse me, sir. Just wait. We'll be introducing you.
Yeah. I think I will take your some time for introduction, a common introduction. Sir, my pleasure. I have pleasure to introduce the first speaker of the session, Dr. Peter Nanasi. But before I start with that, I would like to just quickly say that there is already delay in the program. So time limits are there. Please try to restrict the talk to 10 minutes, followed by 5 minutes discussion. So keeping that in mind, let's proceed. The first speaker is Dr. Peter Nanasi, who is from a professor, full-time professor in the Department of Physiology, University of Debrecen, and also having the position of the chairman, Department of Oral Physiology and Pharmacology at the Faculty of Dentistry in the same university. Professor Nanasi has been medical graduate and he did his MD in 1980, then PhD and subsequently DSc in the medical branch of Hungarian Academy of Medical Sciences.
Dr. Anasi has a significant contribution in the research area of physiology and pharmacology, particularly in the cardiac ion channels. And he has been a member of the Hungarian Physiological Society and Cardiology and the European Working Group of Cardiac Cellular Electrophysiology. Outstanding career, research career with 196 publications, 9 book chapters, and has delivered more than 320 lectures in the field of cellular and the cardiac electrophysiology. Over to Professor Nanasi.
Thank you very much for the introduction. And also, I have to start with the words of thanks to the organizer, to Professor uh, uh, Kunil, and also Professor Boyar. You know, it's not the first time that I am here, it's fourth time, and I'm really very happy to be in this beautiful country. This is the first time I'm here at the northern part of India, and really, we very enjoyed this excursion. Well, the topic is not pharmacology, it is physiology, and I try to simplify the story for you. Every second year student of medicine or pharmacology knows well how the heart is regulated by catecholamines. Epinephrine is known to exert positive inotropic effects, and some of these inotropic effects will involve the activation of some surface membrane ion channels. It's well known for decades, it's nothing new in it. The real question is, how does it organize? The classical theory says that when epinephrine will be bound to the receptor, G protein coupled activation of adenylate cyclase turns on, protein kinase is activated, protein kinase will phosphorylate a couple of ion channels, including L-type calcium channels, and finally, this will lead in activation of it will increase calcium concentration, and through activation of calmodulin, the COM2 kinase will be activated, and COM2 kinases may be responsible for activation of some ion channels. The real question is that what is the role in this protein kinase, and what is the role in calmodulin kinase 2? The situation is a bit more complicated because there's a crosstalk between these. Oh, thank you very much. Because there is a crosstalk in these regulatory pathways, the protein kinase A, as I have shown previously, will activate COM kinase 2. On the other hand, COM kinase will phosphorylate also L-type calcium channel, and COM kinase may also phosphorylate protein kinase A. Furthermore, this is not the only pathway to activate COM kinase 2. There are alternative pathways which are consequences of adenylate cyclase activation. EPEC may activate by two pathways COM kinase 2. So it's very, very complicated and quite unclear regulatory patterns can be seen here. And the question we have addressed that which are the possible pathways in various types of cardiac ion channels, including L-type calcium channel, sodium calcium exchange current, inward rectifier potassium current, delayed rectifier potassium current. So these are the questions we addressed, and we had a very simple approach. We studied the effect of isoproterenol, which is the more or less specific activator of the beta 1 receptor in the heart. We have applied canine ventricular cells. These are isolated ventricular cells of the dog, and electrophysiological experiments were performed using typically action potential voltage clamp or conventional voltage clamp. Now the point is that we have measured ion currents, and what we have done was to measure the ion current under control conditions, measure the ion current in response to isoproterenol activation, and we had 3 more experimental groups, namely
Professor, please hold the mic closely so that it will be audible.
and we had 3 more experimental groups, namely isoproterenol activation when protein kinase A was inhibited, isoproterenol activation when COM kinase 2 was inhibited, and the fifth group when both enzymes were inhibited. For some reason it doesn't work. I will try this one. Okay, so it was quite important for us to assure absolutely physiological conditions. First of all, we didn't buffer cytosolic calcium, so free calcium cycling was allowed during our experiments. We have used action potential voltage clamp techniques. In this case, we could visualize the actual behavior of the ion channels, which may flow during actual cardiac action potential. Pretty low concentration of isoproterenol when applied. This 10 millimole isoproterenol is considered to mimic the normal activation of beta adrenergic receptors. And finally, benign myocytes were chosen because the electrophysiological properties of dog ventricular cells are quite similar to human ones. No. Let's start with the first current. This is the in-one rectifier potassium current. This is the profile of the IK1 current under action potential voltage clamp conditions. The current is large at rest, pretty low during the plateau, and slowly it climbs up and will give its maximum during phase 3 repolarization. Well, we have measured the current here at the middle of the plateau, so we will speak about mid-plateau currents, in this case of IK1, and also in the case of the forthcoming ion channels. So here you see the 5 groups which I have mentioned. Control. The colors, unfortunately, are different from my color I had, sorry. So the effect of ISO can be seen here. Here is a significant augmentation of the current, and here are the further 3 groups: inhibition of protein kinase A. It's misspelled, it's protein kinase A, using this H89. COM kinase inhibition was evoked by KN93, of course, in the presence of ISO. And finally, both inhibitors were applied. Let's see the results on the next plate. This is the mid-plateau current. Not this one. This is the mid-plateau current atlas. You see that isoproterenol significantly increases the current. This increase was fully abolished by inhibition of COM kinase, but was not abolished by inhibition of protein kinase A. And if you apply both inhibitors, you will have the same level as you have seen in the case of KN93 alone. So another approach is to measure at a fixed potential the current. Here it is enlarged, this region of the plateau. And here you can probably better see the same thing. ISO increased the current. This was prevented by inhibition of COM kinase, but wasn't prevented by inhibition of protein kinase A. And the combination of the two inhibitors didn't give any plus inhibition to the system. We have applied rectangular current pulses also, and you can see again the same pattern. ISO stimulates the current, and this is prevented exclusively by protein, by a COM kinase 2 inhibitor. The other inhibitor had no effect. This was the ISO-induced elevation of current. Under baseline condition, these inhibitors have absolutely no effect on the amplitude of IK1. So, in conclusion, these experiments prove that the conventional pathway, including the activation of protein kinase A, is not involved in the ISO-induced beta adrenergic increase in IK1. Instead, the EPEC-based two pathways are likely involved. One is based on the activation of RAP and PLC epsilon, and the other one, and I don't know what is the relative contribution of these two pathways. Anyway, the other one is based on the activation of NO synthase. So it's a different pathway than we typically expect during beta adrenergic activation. The next current we studied is the slow component of the delayed rectifier potassium current, this IKS. You can see that there is a tremendous increase in the current amplitude under action potential voltage lamp conditions in response to 10 nanomolar of isoproterenol. And also you can see that if we block calcium entry and we reduce intracellular calcium concentration, we used nizoldipine for this purpose, there is a reduction of the current amplitude. Now, we have done the same protocol as I have already shown you in the case of IK1. Isoproterenol increase the current. This is the control, and this is the control here. And we applied the two blockers. Again, the pattern was a little bit similar that I have previously shown, namely, inhibition of COM kinase prevented, significantly decreased the current. Here is mid-plateau current again. But inhibition of protein kinase A didn't significantly reduce the effect. There is some inhibition, but it was not significant statistically. And if you applied both inhibitors, the inhibition level is more or less the same, and there is something else. If you apply nizoldipine to block calcium entry, quite surprisingly, nizoldipine didn't prevent the action of isoproterenol. It is just the opposite what you have seen under baseline conditions. Under baseline conditions, again, this is mid-plateau current. Here, no isoproterenol was applied, but either the inhibition of COM kinase and or the inhibition, if you cannot see because it's yellow here for some reason, and also the inhibition of protein kinase will significantly reduce the amplitude of the current. And also there is a similar effect of nizoldipine. So you have seen a white Janus phase pattern because under baseline conditions, all inhibitors, including the depression of intracellular calcium had a negative effect, decreased the slow delayed rectifier current. In contrast to this, in the case of the iso-induced elevation of the current, calcium had no effect, depressing intracellular calcium had no effect, and inhibition of protein kinase A had no significant effect. So it's a very interesting situation. However, the conclusion to be, well, we have applied another inhibitor, which is even more specific inhibitor than KN93, and you can see that this inhibitor very effectively reduced the iso-induced increase in IKS. So, conclusion for this part of experiments, since under baseline conditions, very likely the conventional protein kinase A pathway is involved in activation of COMP2 kinase, which is the actual activator of the channel. But this is the baseline. However, under conditions of isoproterenol activation, the effect-related two pathways are likely to be involved. Next current is very easy now, is a rapid delay rectifier potassium current. You can see that there is no effect of isoproterenol. In other words, sympathetic activation will not influence the magnitude of this current.
Professor Nanasi, please summarize your talk. Time is getting over. Please.
I will try to summarize it. Okay. So, if we jump a little bit, L-type calcium current, there is an iso effect, but both enzyme inhibitors will prevent the effect of isoproterenol, and their combination will not yield a higher block. In the case of sodium-calcium exchange current, you see the typical pattern. Both will block the effect of isoproterenol. What is really interesting in this point, that the ratio of the exchange current and L-type calcium current is coupled. There is a fixed ratio of 1 to 2. Well, 2 positive charge will enter the cell when a calcium ion enters, and 1 positive charge will enter the channel when calcium comes out. So this arises the possibility, this very strongly coupled situation, that not the phosphorylation will govern the exchange current, but just the amount of calcium entering the cell. And here it is shown, phosphorylation, of course, very likely takes part. However, since L-type calcium channel is phosphorylated but COM2 kinase, this will elevate intracellular calcium. This elevation may also increase directly the activity of the sodium-calcium exchanger. And here is the summary. IKR is not affected by beta-adrenergic regulation. The isoproterenol-induced activation of IK1 is mediated exclusively by the EPEC COMP kinase pathway. Iso-induced activation of the slow component of delayed rectifier is, I dare to say only, that is dominantly mediated by the EPEC COMP kinase pathway. Iso-induced activation of L-type calcium current is mediated exclusively by the protein kinase A COMP kinase pathway. And finally, the iso-induced activation of the changer current, it seems to be mediated by the protein kinase kinase 2 pathway, but it is directly or indirectly may involve the changes or elevation of intracellular calcium concentration. Thank you for the attention.
Thank you, Dr. Nanasi. The intricacies involved in the beta adrenergic activation and deeper electrophysiology involved is very nicely explained. And now it is open for any questions. Yeah.
Yes, sir. So thank you for talk. So my query is around the CAM protein that you presented, that is the calcium colmodelin, right? So my query is around the interaction happening with calcium and the colmodelin. And if you compare with calcium with calbindin, so how these two systems operate within the cell, maintaining the integrity and execution by protein kinase. Any
Carbidin is a calcium binding protein sequestrated inside the sarcoplasmic reticulum. So it is responsible only for uh, not chelation, for keeping the ionic calcium concentration low inside the SI. It's a calcium buffer. COM kinase and calmodulin itself is also a calcium sensor, but it is working in the intracellular compartment. That is actually that sensor which will govern the whole COM kinase story. From the side of protein kinase A, matter of fact, the other side, the HPEC-related side, is absolutely not sensitive to calcium because it doesn't require the activation of COM kinase 2.
Thank you.
Thank you, Professor Nanasi.
Um, Thank you, Dr. Peter, for a wonderful talk. Now I request our esteemed session chair to kindly facilitate Dr. Peter.
We move on to the next speaker, Dr. Sanjeev Dhingra. I invite Dr. Sanjeev Dhingra. Let me introduce to you Dr. Sanjeev Dhingra is a professor and associate head of the Department of Physiology and Pathophysiology at the University of Manitoba, Winnipeg, and director of Canada-Italy Tissue Engineering Program at Saint Boniface Hospital Research Center, Canada. He has been having a lot of research focus on cardiac regeneration and tissue engineering, and his contributions have been immense with special focus on these cardiovascular research. He has chaired many international conferences, and he has, to his credit, outstanding number of achievement awards, including Outstanding Leadership Award in the cardiovascular research. May I invite Dr. Sanjeev Dhingra to give a talk on his topic, which he will introduce. Thank you.
Thank you. Thank you very much, Mr. Chairman, for the kind introduction. Can I request students to maintain silence for the rest of the session? We are almost there. I know you all are tired, but please listen to when people are presenting their science to you. Okay, so as mentioned, we focus on cardiac stem cell therapy and tissue engineering, and in that process, we end up using different types of stem cells and biomaterials for cardiac repair and regeneration. Nothing to declare in terms of conflict related to this talk, other than these patents that we filed in the last 3 to 4 years. These are now approved. These are related to a material that I'm going to talk in today's lecture, so I thought it's important. heart disease, I don't think I need to emphasize on the fact, is now turning out to be a leading cause of death in today's world. The traditional therapies have have shown a lot of promise in terms of improving the quality of life of patients with cardiovascular disease. But all these therapies have not been able to provide permanent solution to the problem. And the reason is irreversible loss of functional cardiomyocytes after a heart attack or after any cardiac injury. Why? Because cardiomyocytes are terminally differentiated. They don't multiply themselves like all other cell types in the body. So, what is the solution then? If you want to fix the heart after a heart attack, the only solution is to replace dead cells with the new ones. How can we do it? This is where stem cell therapy can help. So stem cells have shown a lot of promise in terms of repairing and regenerating the injured heart. Why? Because stem cells, they are able to differentiate into any cell in our body, including heart cells, cardiomyocytes, and stem cells secrete different kinds of cytokines, growth factors, and anti-inflammatory factors. These are the mechanisms of stem cell mediated repair after you implant these cells to the heart. So when it comes to heart repair, different types of stem cells are being tested at different levels. Some of these cells are in clinical trials, whereas the other cell types, they are still in preclinical stage. In different animal models, they are being tested. In today's lecture, we'll be focusing mainly on these two cell types, bone marrow-derived mesenchymal stem cells, iPSCs or induced pluripotent stem cells, or iPSC-derived cardiomyocytes. Because these two cell types are in clinical trials, but they are not there yet in terms of making it to clinical practice. And there have been different challenges reported in the field. And I'm going to talk about some of those challenges as well, and mitigation strategies that we are developing in our research program. So iPSCs or induced pluripotent stem cells, just a bit of background about this cell type. These days, there are technologies available. You can reprogram any somatic cell in the body to induce pluripotency. You can bring them back to stem cell stage. Once they are at stem cell stage, you can differentiate them into different cell types, uh, cardiomyocytes, neurons, liver cells, kidney cells. You name any cell type, there are protocols available to differentiate these cells. And these you can use these cells to test different drugs. Uh, this whole field is called drug screening or new drug development, and you can use them to model any genetic disorder because you can recapitulate the mutation that you would see in a patient. And you can use these cells as a source of cell therapy. You can transplant them in different injured tissues or organs, and these cells help in starting the repair process. So in our lab, what we do is we take blood from patients or healthy individuals and then isolate mononuclear cells from blood, reprogram blood cells to generate iPSCs, and differentiate iPSCs towards different types of cells, cardiomyocytes, neurons, fibroblasts, depending upon the condition that we want to model in the lab. This is the team, the pictures I'm showing here that is working in this field. This is one of the examples from the lab where we we have the protocols. We can differentiate iPSCs to waiting cardiac cell sheets, and we use them, as I said, for different purposes, for drug testing and as a source of transplant as well. Uh, so allogenic stem cells, no matter if they are bone marrow derived MSCs or iPSC derived cardiomyocytes, when you transplant them in, they are able to improve heart function, promote angiogenesis in the infarct areas. This has already been tested and reported in different animal models. And the outcome of clinical trials with allogenic MSCs or iPSC-derived cardiomyocytes is encouraging. Cells are safe to after transplantation to the patients, but this this outcome is not as effective as people observed in animal studies, and different challenges were reported in terms of muted response of clinical trials. And one of the challenges is poor survival of transplanted cells and rejection by host immune system after implantation in the injured heart. So with this, we became interested in understanding the immunogenicity of transplanted stem cells in the heart. This is all reported. I wouldn't get into this detail. You can check PubMed if you want to know more about how these transplanted cells become immunogenic in the heart. But I want to talk about some of the biomaterial, nanomaterial-based strategies that we are developing in the lab to prevent rejection of transplanted stem cells in the heart. And one of the materials that we use in the lab is mexine. Mexine is a carbon-based material, and we synthesize mexine nanosheets and quantum dots by etching bulky max phase. The application of mexine as anti-cancer agent, as a contrast agent for imaging, and as energy storage devices is being exploited at different levels. In my lab, we are mainly interested in cardioimmunology when it comes to application of mexines. We have now tailored the surface of mexines to make it intrinsically immunomodulatory in nature. In terms of biocompatibility of mexine, it is highly safe. When we tested its compatibility with different types of stem cells, what we found was that there was no toxicity that mexine induced in mesenchymal stem cells, iPSCs, or iPSC-derived cardiomyocytes, neurons, fibroblasts, and many other cell types that we tested at the doses that we are using in our lab. So in our ongoing experiments, what we do is we use mexine quantum dots. We incorporate them into chitosan. We are using chitosan as base material to develop 3D platforms to deliver stem cells to the injured heart. So when we use this immunomodulatory hydrogel, what we have found is that it is able to prolong the survival of transplanted stem cells in the heart. So how mixing promotes survival? We performed global RNA-seq analysis. And what we found was that mixing quantum dots are able to upregulate the expression of several genes related to cell survival and downregulate the level of genes related to interferon gamma and inflammation. When we got into depth of this, we found that mixing quantum dots are able to downregulate the level of cytotoxic CD4 positive T cells. And mixine was also able to increase the production of regulatory T cells. Uh, how mixing does it? So we performed global metabolomic analysis in immune cells with or without mixine treatment. What we found was that mixine treatment was able to reprogram immune cells towards regulatory T cells. Regulatory T cells, they are able to suppress proliferation of cytotoxic T cells. So in terms of this details, this is how mexine is working. We are also using mexine to test its efficacy if it can prevent the rejection of whole organ as such. Uh, so we developed this model in the lab. We transplanted a piece of aorta from one species of rat to the other with or without mexine treatment. This is a very good model of allograft vasculopathy, which is the starting point for organ rejection, heart transplant, kidney, or any other organ. It's a very good model if you are interested in understanding cell-mediated rejection or you want to see histopathological changes in the allograft itself. So what we found was that treatment with Mexine was able to reduce the infiltration of immune cells within the allograft. Uh, and Mexine also increased the number of regulatory T cells. We also tested if Mexine treatment is able to prevent damage to the allograft or transplanted organ as such. For this, we performed alpha SMA staining, which is a very good indicator of tissue damage if you want to test that. What we found was that in the control group, there was a decrease in the expression of alpha SMA, and treatment with Mexine recovered this level. So Mexine treatment was preventing the damage to the allograft itself. So I think I can safely say that Mexine treatment is able to prevent allograft vasculopathy, prolonged survival of transplant whole organ as such. At least it has the potential. How Mexine works, Mexine quantum dots, what we have found is they are able to get internalized into antigen presenting cells. Once inside the cell, they are able to downregulate CD86 levels and upregulate PDL1 levels with the net result of T cell suppression. So this is how Mexine works. I think I'll stop here in the interest of time. I'll skip these slides because we are already late. So I want to thank people in the lab who actually work on the bench to generate data that I'm presenting here. These are the pictures taken in the last summer. This is current composition of my lab. Funding agencies, the major chunk of funding for the work I presented came from CIHR, ANSER, and European Union. I want to thank my collaborators. Without their support, we wouldn't be able to do what we are doing currently. Thank you very much, and I'm happy to take any question. We're always recruiting students, postdocs, anybody interested, we can talk.
Thank you.
Thank you.
Dr. Dhingra. It's an excellent presentation.
Thank you.
Something unique in terms of the need-based therapy. And you have elucidated the underlying immunology so nicely.
Thank you so
So
much.
now it is open for discussion. If there are any questions. Dr. Dhingra, are the helper T cell population increase in this scenario or in suppressor of the
Yeah, so we are testing now Th1 Th2 ratio if
Okay.
there's any effect of mixins on that.
Mhm.
If I have to guess, assume, yes, I would see some differences in the ratio.
Okay.
But I don't know yet what.
So immunoregulation
Yeah.
is basically happening through changes that are brought about
Yeah,
in terms of downregulation of the so-called inflammatory mediators.
Yeah, and vaccine is able, as I showed, it promotes Treg cells. They are immunosuppressants
Yes.
in nature. There was a hand raised by a student.
Yes, may I have that question? Yes, please.
Mm,
Hello. Sir, I have a question that rather than using pluripotent stem cell derived cardiomyocytes, isn't it better to transplant sheets or pieces of skeletal muscle cells over the injured part of heart to increase its overall efficiency and decrease the load on heart?
So, when cell therapy started 25 years back, that was the first cell people tried, skeletal muscle. The one you're
Yes, yes. I am like
mentioned.
talking about the sheets of muscles from.
But those cells, yeah, go ahead.
Yeah, I'm talking about the sheet of skeletal muscles from thighs or actually fast or slow twitching
Yeah,
fibers.
it's a good thought, but what happens is skeletal muscle, it doesn't beat with the frequency that heart muscle does. So there was arrhythmia. that people reported, which is not good. So that's why that cell type didn't go anywhere. That was the first cell type. If you read review articles published back in 90s on cell therapy, skeletal muscle was the first cell type. But people thought, no, it will bring more complications to the remaining heart muscle.
Thank you.
Good question. Thank you.
There are no more questions. I ask the
Sir, please. Thank you, sir, for a wonderful and enlightening talk. Now I request our session chair to kindly facilitate Dr. Dinga.
Thank you, sir. So we move on to the next speaker, Dr. Ramesh Goel. I am honored to introduce Dr. Goel, who is a distinguished academician and researcher. I'm sorry. I have pleasure to introduce to you Professor Ramesh Goel, a good friend of mine. He's been distinguished academician and researcher with over 46 years of experience in pharmacology and pharmaceutical sciences. He served as vice chancellor in two different universities, one at Dipsar and one the MS University, Baroda. He is amongst the world's top 2% recognized scientists, and Goel has been having extensive academic portfolio with 416 publications, 45 authored books, 6 patents to his credit, with 47 PhD scholars and 79 uh, national and international awards to his credit.
Thank you, Professor Sarab, Professor Gupta, Rahul.
Over to Ramesh.
Well, you are a friend. That's why you are speaking so much. It's not the two speakers who have given hardcore molecular and the state of art research. And now, when I'm going to speak, I don't know how I will look like, because what I'm going to do is going in a reverse way. Dr. Dhingra has told about the stem cell therapy, the future, or rather already present and now going to be future. The regeneration, regenerative thing, and then engineering, again, tissue engineering. And Peter Nancy again talking about the beta adrenoceptors going down to particular current. Well, I will have to go a little faster because I cannot go on talking too much, although I had too many things to talk. But in the end, only thing I wanted to give a small message to the young researchers, because when I was in NMIMS, many times I saw that everybody was testing for all toxicity and then trying to identify the active compound. I said, no, do it first and then go for toxicity. So similarly, I never liked in my life to work on the herbals, to be very honest, in the beginning. First 20 years, I was not interested in herbals. But somehow when I became interested, I went on doing. And Professor Harpal Butler is sitting here and he always promoting the traditional part. So there, and then to talk about the AI, ANN, it is all the more here. So I am dividing into three parts. So come to the first part. See, my basic dream right from the day has been to bring out something new. And it took 40 years for me to bring at least one drug in which went to the market. So that is the story. So I wish that, like me, others are not the failures. So I always remember this Australian pharmacologist who was an autonomic pharmacologist. He used to say that I am enjoying my life. So, like that, I can also say that yes, I am enjoying my life with the research, publications, and all that, all decorations. But no, the ultimate goal of getting a new drug, that was the important thing. And then professors are always psychic. And incidentally, I became professor at a very early stage. In 85, I was associate and then professor. Within 5 years, I was professor also. So you can imagine. And I have seen all these revolutions occurring in pharmacology. By the time I catch something new, state of art, I'm lost. I don't know. I could not match that speed. I have my friend Dr. D.K. Agrawal, who was, I don't know how he has been matching all this time. Every time something new and very well, as if he has done for years together the same work. Well, it was a difficult task. But what I know is that today, everybody, they are talking about AI, ANN, molecular pharmacology, and all that. Even the drug discovery process has undergone different phases. I've seen all those phases of drug discovery. But certainly one start with the disease and then discovering there was something like STS and all they were introduced, but nothing turned out to be really fruitful, can fast giving a new drug. That is a reality, as I understand, but you can comment on that. Well, today, if we see, I will not go into detail, but everybody, you might have seen it repeatedly all how the drug, new drug is discovered 12 years, although we say it is shortened, but nothing is shortened. And so it is there. Even the pharmacology has also changed a lot. Well, people are talking about AI and ANN. I remember one of my students, Jignesh Patel, he did the work in 2004 on ANN, and it was for the diagnostics of cardiovascular diseases. That based on symptom you can diagnose. I mean, just a few symptoms. It was something, a database was made and ANN was used. I feel proud that yes, it is coming out now. I might not be. And I mean, this is just a testimony that this paper was published in somewhere in 2006 and 7. Well, I will not go into detail. Time is also not there that what is ANN, but definitely it is integrate. It is not that easy also. But certainly through AI, sometimes people feel that, oh, immediately they will get when HPLCs and all, oh, one can immediately auto analyzers. I don't know, auto analyzers when they came in somewhere in 90s, 80s, I mean, in our India, it became common. We used to feel people, public will feel that, okay, just inject and you will get all the results at a time. It has never happened like that. So, if we continue thinking about that, we talk of AI, ANN, but there are a lot of differences. The basic difference is that ultimately the input you need for any drug is certainly a chemical structure, but at the same time, the other side is targets. For years together, so many targets have come out. Like in last 20, 30 years, tremendous plethora of targets have come out, receptor subtypes and all. It has led to discovery. There is no question. 5-HT was ignored neurotransmitter, but the moment 5-HT receptor subtypes were discovered, ondansetron and all that drugs came out. We all know that. They are not incorrect. But with the subcellular mechanisms going deeper and cytokines and all that, things are not coming out. This is a truth. Now, when we come to herbal part, so this drug discovery is never a easy task, and people are talking. Now, recently, 15 days ago only, I was in China. I was amazed to see they don't listen to anybody. They don't listen what US says and all that. They have their own regulation. They said, we don't care for patent of US or like that. We want our patent. And if it is working, it is working. They have used AI, and rather in 2021, the President Jinping has written that no, integrate this traditional medicine with AI. So this is the reason that it prompts me to think what we should do. So anyway, I am trying to integrate this. Part two is the, like, ever since I went to Canada in 1984 with John McNeil, I was studying cardiomyopathy. Cardiomyopathy, for years together, rather I will say for 40 years, we have been talking that proper selection of antihypertensive or anti-diabetic or anti-hyperlipidemic or something that will give the answer of the cardiomyopathy. A new drug for cardiomyopathy is yet to be there. But if you see from the traditional medicine field, lot of work has come from Arjuna. But so I was in search of that. So my focus remained all throughout my 46 years of was the cardio complications, and tried to look into that. Well, I will not go into detail. Diabetic cardiomyopathy, that is the real key. And I will not again, and this, as I told you, in 84 itself, I started and continued to work. And when we listen to Dr. Dhalla or like that, so much complicated picture emerges about the cardiomyopathy molecular mechanism. And each circle has so many targets again. Well, the same way, the mechanism. So pharmacologists are trying to search the mechanisms. And this is the history also speaks the same. And how to integrate that with the local, that was the important part. So I tried at that time, Dr. Ashok Vaid and R.I. Mashelkar, I don't know whom you must have heard the names, reverse pharmacology. Reverse pharmacology to them was that if text has mentioned that this is the activity, try to do systematic clinical trial and prove it again. That was, and then try to go into the mechanism. Don't go first mechanisms and then try to justify that this particular herbal component is useful, whether it is Unani, homeopathy, Ayurveda, like that. Anyway, so reverse pharmacology was the approach. And coincidentally, although they published this work in 2003-4, but I noticed that I utilize that only. Anicostima literally was one of the drug that was available, mentioned in the Ayurvedic text as anti useful in the liver diseases. But there were Ayurvedic doctors who were using it anti-diabetic, but they could not prove it properly. In CDRI in 1970s, the work was done and it was kept aside. This may not be effective. We did this work, and it was a 12, 13 years work, clinical, preclinical, toxicological, and clinical studies, and everything proved that yes, it is effective. And even after 5 years follow-up, the patients, they were stable. It can be a full lecture, but it was a clear. So we went in a reverse pharmacology manner, and going further, we also found these pictures are not clear because of some reason, but even the DNA damage was also prevented by that. And this work was done not at our place, at MSU University Baroda, at US also, in Newfoundland, one of my Dr. Chima, and we found that yes, this molecule, Swartia marine, this is the plant which has 8 to 9% active constituent. That was again, the nature has provided that. And it was equivalent to Galelia officinale, from which the metformin came. So this drug was effective like that. And yes, we could find, I mean, to cut the story short, what I want to say that yes, using that approach, we could identify that. But it was not satisfactory. We did it. So Now, what happened during COVID, we found that there was an dire need of a drug, and we wanted something from Ayurveda or something from traditional medicine. So there came this reverse engineering approach. Let me tell you now what simple, very simple. I mean, on one side, talks this artificial intelligence and all that has come, and technology has to. But reverse engineering is a very simple. Of course, Vishwakarma he told at that time that you dismantle something and then reassemble. To me, dismantling traditional medicines means extract or whatever way they have been done into chemicals. And if you see hundreds of years, everybody has published chemical structure present in that. And on the other side, we have Schrodinger's and others which can dock it and find out. And for last 20, 30 years, targets of every disease are available. So why not to come together to see that? That was my approach. And exactly I went in the same manner. So reverse engineering means dismantle, like identify the phytoconstituents. So in COVID, in February, the conference concluded of IACS. I immediately sat on it, found the target, and found with the experts the plants. And based on the plants, I asked one of the scientists to find out only structures, nothing else, and from literature, not to reinvent the wheel. And pocket with the targets. And after so many hits, we found it and we were successful. So, this is the approach we had, that, and this is the reverse engineering. So, renin angiotensin system, clear cut, it was there. And Dr. Dhalla had at that time asked me to write a review article on the targets. We could identify ACE2 as the target. And then when we went through the history, this ACE2 angiotensin system was not just sodium potassium balance, but hypertension, retinopathy. But 2020 gave it is important in fibrosis, and that was the thing which we. But it came later, and then in 22, 23, everything became clear. It is affecting practically everything, and we did that. And out of 3 lakhs, we could get 10 final leads, and these things were taken, and based on that, formulation was made, and it was sent to University of Missouri, not at our place. And to their surprise, the beautiful dose response curve was also there. And the utilizing those cells, we found that yes, viral role was also decreased. There was a beautiful separation of the curve. The clinical study also proved the same. So this was a reverse engineering, whether you call reverse translation or repurposing, but certainly targets and this. So many times, instead of devoting time in just extractions and all that, or just trying to see the pharmacological effect, why not to check it mechanistically, biotechnologically? This is what is the thing which I want to promote, that yes, this is the only way that the traditional medicine we can work on it and faster way. So, so this way, just few success stories, like we could come out with the Sorsha marine, we could develop even the compounds, and these were we are really patenting, and we got various targets of cardiomyopathy. See, holistic cardiomyopathy is not a single entity; it's multiple biomarkers are involved, and that's what one has to see, and that's what we have exactly seen. And same thing goes true for, I mean, we were trying to find some other VChem, IChem. Dr. S.K. Gupta was involved in that. So using that NFKB, we did the work. We again found the plants, and based on that, 4 plant material we took, and the formulation was made, and it was found to be successful. Because of time, I will not go into detail. But what I'm trying to tell, I mean, everything was very clear. The effect, even when we give extract or the drug, particularly, it is effective. Individually, also the effects were seen, and it was found to be correct. But the docking and that matched. That's what I want to say. So I will not. I will. So what I'm saying is that yes, people feel that, I mean, we concluded that yes, reverse engineering approach can be for the faster development of the herbal formulation properly. And it will be acceptable. No other country, one can challenge this. That is there, what is there in Chavanpras, or nobody will ask like that. It is already clear now. And at the same time, it is authentic. You have removed the unwanted things, and everything can come out. So that was done. And but only thing is that when some new technology comes, don't take it just like that. Try to find out how one can utilize in our way rather than following that. That's what it I felt. And actually, Einstein 70 years back wrote that yes, a time will come, everybody will try to be as if robots can do everything. No, it is not going to be that true. You have to work in your way. So still, I feel that whether, I mean, we cannot answer whether egg comes first or head comes first. We don't know. So, do we require artificial intelligence or intelligent application? That is what a question which one has to think. And accordingly, one should design the experiments if you are working on herbal drugs or trying to have a new drug discovery and with the limited resources, but in particular. So, this is the only answer. Whatever I have been trying is that only. There are all a large number of students who have worked. Social Marine was this group. Then during COVID and new drug which we are trying to find, it was Dr. S.K. Gupta's concept, but we have taken it further with two students. So I thank you all for giving it. And as I told you, I wanted to give a message. I mean, I have my own concept which I have trying to present before you. With these words, thank you very much for.
Thank you, Dr. Ramesh Goyal. A unique concept of reverse engineering. I think a lot of work is going on in India in number of institutions with the herbal products, and I think the time has come to really look into newer approaches of drug discoveries. Thank you very much, Dr. Goyal. Now the session is open for questions, if any.
क्या हाँ हाँ कर दीजिए
See, in this in modern science, what we observe about isolating single compound set, that makes a casing. There is this algorithm principle scientism that comes from the combinatorial science. There is the multiple compounds are working.
Yeah.
If that is a rationalized pharmacological approach, handling the plant-based material wherever there is a multiple compounds acting in a different.
Yeah, very good question. See, this is what is the, we are not, I mean, challenging Ayurveda or anything. Holistic approach is required. That's why I gave the example of diabetic cardiomyopathy. Now that was there, multiple components are there. So maybe one Arjuna is not enough. Maybe we have to have that formulation, and that's what Ayurveda says. But on other side, I have, now nature is nature. I found one plant, antidepressant. It was a Chinese plant having four different constituents, and all are acting on targets of depression only. 5-HT2A, norepinephrine, histamine. I was surprised that how come this single plant has all the components. But it is a truth. Nature is nature ultimately. So this is what we have to see. So now Swarsha Marin, it is anti-diabetic, no question. But just like metformin, all the effects you can observe in that. So I mean, my approach, I mean, is not to antagonize what modern science is there, not to antagonize or challenge the Ayurveda. Let us come together, integrate for the welfare of the human being.
Yeah, I think thank you, Dr. Goyal. Conclude.
Thank you, sir, for a wonderful talk. Now I request session chair to kindly present a token of gratitude to sir.
We are heading to the last uh, speaker, Dr. Let me introduce to the last speaker, Dr. Payodhi Dhar, who is a distinguished medical doctor, educator, entrepreneur, a visionary leader, and one of the active members of Executive Council of Indian Pharmacological Society. He is a founder and president of Kolkata Nurture Foundation and strives to bring universal healthcare and education to underserved communities. As a chairman of Valmiki Healthcare Private Limited, he oversees an expanding healthcare enterprise with a strong focus on community health. I think this is the need of the day. There is outstanding his career as he is associated actively in number of professional bodies and serving as General Secretary West Bengal and Eastern India in charge of the Indian Psychiatric Society, and he is helping to steer the psychiatric disorders and policy in the region. He has outstanding career, and I would now request Dr. Dhar to give his lecture. Thank you, Dr. Dhar. Dr. Dhar.
Thank you, sir. Thank you for such a vivid, elaborated description of mine. My special regards to all on the chair. Good evening. Can you hear me? Sure. How much sure are you? One. How is the Josh? I can't hear you. Good. So this is the session for you practically. We are talking about positioning the pharmacologist in the patient practice, the current practice of the patient-centric care. So the learning objectives will be to reimagine the pharmacologist's role in the patient-centric care, to find out the integration of AI, data services, and entrepreneurship in practice, to explore India's collaborative health policies and global diplomacy, and how we can, as pharmacologists and individuals, contribute to the national goal, and also the inspire you, the next generation pharmacologist, towards the translational leadership. So we are standing in a transition of science strategy startup, which ultimately did some benevolence to the society. Why do you at all need to talk about it? You know, if you look at the global healthcare crisis, near about 74% of deaths are due to non communicable diseases. 74%, I mind you. 537 million people are diabetics, as of we know, and we are probably going to reach it by 2030. It is 789 million. India is again becoming the diabetic capital of the world. Right now, we have 12%. We are supposed to reach 21% by 2030. Projected NCD cost in this decade is near about 47 trillion. And you have seen COVID. You can imagine what was the scenario in the acute diseases. If this is the scenario, what was WHO doing? Okay, WHO thought about 25 in 25. In which month are we standing in 2025? Which month is this? December? November. Okay. So we are actually entering towards the end of 2025. In this time, WHO actually thought of decreasing few goals, reaching few goals, so that there is 25% reduction of premature mortality in NCTs. What were the goals? First, 10% reduction in alcohol use and 10% in physical inability control, 50% reduction in sodium intake or extra salt intake, and 30% reduction in tobacco use, halt the fast progression of obesity and diabetes, 80% access to the essential medicines, even to the remotest and the poorest, and a super vigilance. But that did not happen. So in September, a global conglomeration in this year thought of creating a new bunch of people. So they thought who can be the most important people. You see, pharmacologists are normally known as the legacy roles, the teacher of drugs, bench scientists, and observer of area. Yes, we do this. But also, the WHO now think us as therapeutic system architect, clinical decision support lead, and predictor of AI analytics. That's how we come as an integrator and a central position. Now, is it happening anywhere in the world? Yes, it is happening. In UK NHS, it is happening. In Kaiser Permanente, the largest group of public health, they are doing it. Singapore Health Service has already taken up the AI protocol. Mayo Clinic, as far as I know, have been there on drug-related policy. So the change is starting, and so is the scope of you. Why pharmacologists matter at all? Because we understand the polypharmacy optimization, we understand the pharmacovigilance and data analytics, and we can bridge between the bench and bedside where lies the business. Have you ever heard about a term, institution known as OECD? Now, what is OECD? You have heard about UNICEF, you have heard about IMF, you have heard about WHO. What is OECD? OECD is actually the Organization for Economic Cooperation and Development, a conglomeration of rich developed countries. They have found out the study between India, who is probably going to become the global leader in healthcare by 2030, versus what is there. There are a few discrepancies. We have less than 15% institutions with TDM lab, minimum pharmacologists present on the hospital boards, especially private hospital boards, no entrepreneurship training model for the pharmacologists. So where does lie the opportunities? Pardon the change of AV. I'll just name the scopes. It's clinical integration, digital therapeutics and AI, CRO leadership. In this year only, the global CRO work is of 60 billion US dollar. So there is a huge opportunity for each one of you. Drug repurposing and innovation, and also the reverse pharmacology, as Sarah has already mentioned. You have learned about stem cell therapy and the future, which is already going on. So these are the areas, but don't forget the integrative nutraceutical market. That is a huge market in India. Pharmacovigilance 2.0, academic spin-offs, lab research opportunities. Yes, research opportunities. The national registries are there. HTA collaborations are there. PG startups for startup funds for you, it is there. And in AIMS, it has already started. Does Indian policymaker at all think that we are important? Yes. In Ayushman Bharat Digital Mission, the primary harmonization is being done by the pharmacologists. In NPCDS, in e-Sanjeevani, we are doing the central part. Now, if you want to become an systems architect, or so to say, understand the system, you need to understand the cost analysis ratio of it. For that, there is a body in India known as Health Technology Assessment Board of India. They understand what should be the budget, what is the utilization of it, and how it should be done. You will be happy to know 3 key positions out of 7 are held by pharmacologists. And now they are trying to come in to the grassroots level at every government and aided setups where we can be a part of it. In diagnostics and AI, I don't need to elaborate on it. In public health entrepreneurship model, the CSR funds, as Dr. Dhingra was already talking about, the funds from you and others, the financial seed models, all these are there. But what you require is 3 V. One is vision, that is science, validation, that is the strategy. Your theory must be validated, and the value for it, the soul. So now, is it only in India? No. The government of India is now looking at becoming the pivotal peak, reaching the pivotal peak of welfare diplomacy, which is a part of health diplomacy. In healthcare diplomacy, India has already excelled in Vaccine Maitri, G20 healthcare leaderships, and in 2025 till September, 8,500 health techs have started. Near about 33% of that are coming from pharmacology background, in whichever way that may be. There are loans, collateral free schemes of 10 crore in CGTMSE, PLI, APS, and BRACs. I will come back to that later. So, what do you need to do? You first need to identify the problem, one problem. Then, two, innovate the solution for that. Three, incubate the solution and find out how is it working, and then integrate it into a business model. Indian government support systems are so many. Is it there in UK and outside India? Yes, there are. Is there any model which is happening right now in Punjab? Yes, Oxford GSK model is running on right now here. In 2026, India is going to launch innovation hub in therapeutics. Primarily, a hall out of 4 halls is on pharmacotherapeutics. Data mining. The data is the most powerful tool right now. Precision medicine, the genomic. These are the areas where we have scopes, and I believe we'll take part into it. I will not get into the details of it due to the paucity of time, so I'll just touch the points. AI and digital health pharmacology, designing lab for the future. There is requirement of curriculum evolution and collaborative approach. So WHO and Government of India collaboratively visions a pharmacologist in 2035 as an academician, clinician, innovator, and also an entrepreneur. But sir, do you think that in acute care, pharmacologists have any role? Yes, we do have. In acute care, there is zero margin of error. And we can become the safety gatekeeper. There is required, is there any data that proves that presence of pharmacologists in hospital board, in decision making, in clinical lead decision taking may be helpful? Yes, there is a data of Mayo Clinic. It decreases ADR by 30 to 40%. I'm talking about acute setup, ICU setup. Decreases ADR by 30 to 40%, medication errors by 50%, sepsis mortality by 10 to 15%, decreases ICU stay for near about 1 day, and emergency antibiotic accuracy is increased by 25%. So there is role. Is there in chronic care? Yes. Multimorbidity, there is role. In diabetes, cardiology, nephrology, neurology, gastroenterology, geriatrics, mental health, women's chronic health, oncology, things are going on. But is there any collaborative approach is going on in India? Yes. In Kolkata, we are doing right now the diabetes hub, heart failure clinic, CKD safety program, geriatric deprescribing, close-up in clinic. All of them are in collaboration with government and private setup. And in this month, we have started allergy and immunogenic clinic also. So, am I talking about my story or the story of Dr. Pai, who has established Monipal, or somebody of all of us? Do you know these people? They are unicorns. Do you know any one of them? Rohit Sharma, Reena Fogart, Dr. Arvind Singhal, Harshit Jain, they have become successful in 2025. And you'll be happy to know that Dr. Reena Fogart is from this institution. She is from this institution, your institution. So the people are succeeding. Why do we matter? Because we are the bridge trust. We know about the ethics. We have the basic education, the drugs, the diseases. We work on evidence based therapy and we understand empathy. That's how we come at the core of the healthcare system. So we become central to the drug policy, safety, AI, and also pharmacoeconomics. That is the reason we can be reimagined of the health integrator. So the key takeaways from the discussion may be pharmacology is no more just the science of drugs, is the science of healthcare decisions. Integration of science, strategy, and soul is the way of India's healthcare renaissance. The pharmacologist and the clinician should act hand in hand, the core of patient care together for the complementary contribution. As the founder chairman of the Group of Hope, which is the largest conglomeration of doctors in India, having 15,000 specialists in India, I think there is hope for all of us. Thank you and best wishes to all of you. In the next year, we are organizing IPSCON 2026 in Kolkata. As organizing secretary of IPSCON 2026, I welcome you all. Thank you.
Thank you, Dr. Payodhidhar. You have given a newer insight to the understanding of pharmacology, that it's not just the pharmacology of science of the drugs, but it has a large connotation in terms of the different insights which can directly relate to community by large.
Exactly, sir.
And I think the time has come to really explore that. The new young generation has to really pursue that, particularly in the entrepreneurship and the areas allied, to see how the knowledge can translate into its application path in a big way. Thank you very much.
Thank
Now
you,
the
sir.
session is open for discussion and questions, if any. I would like to, particularly the young audience, to speak their minds on this. May I invite some questions from the young audience, please? It's a very interesting topic, and Dr. Dhar has been actively associated with the path related to community. They may have some interactive. Yes, please.
Sir. Thank you, sir.
Success rate of these startup people are very less. Like very the domain what you're talking about, it's very niche area, right? So how fair this what is the success rate of these in the niche area?
Wonderful question, sir. So that is the question which should have come from you. But sir has asked a very, very unique question. Yes, it's a very niche area. There are scopes of failure, and that's why there are two parts of it, sir. One is the fund flow. As I have mentioned about CGTMAC, it's a collateral free government backed up fund. So there are many other funds where there is no risk. But at the same time, the success rate of this cannot be presumed by one attempt. If you see, there are many, you have to understand your own niche. What are you good at? If I may talk about my own story, I did everything cardiology, endocrinology from Royal College UK.